So hello everybody, it's just a warm welcome to all of you. It's a pleasure to have you again. So pleased for us to have such a big number of delegates, and I would also like to thank the faculty, the guest faculty this year, coming from Saudi, from India and from Turkey, and also USA. So it's a really good pleasure. And we also have a faculty from France, which is important for us. It's a pleasure again. So we will start the session. We are running late, but you know, we are here in the south of France, so it's always late, about some delays. That's the kind of way of life of the south of France. That's it. And so we're going to start live surgery after John's talk. I switch a little bit the program. I'm going to, as usual, I'm going to do the revision stapes first, and then the primary. But apart this, everything is on the program, and so you have everything you need. The second point is about the Wi-Fi. We need to reset up the system because it doesn't seem to work with the number. So it will be ready soon. We'll call the guy and he will arrange everything. It's not what is written in the program. I made a mistake. You have to go and check conference. The Wi-Fi, you need to find conference. And then if you click there, you will have to enter your name, first name, and the email address. And then you need to send by SMS using your iPhone, your phone. You need to send the number that is given to you, okay? But this doesn't work yet, so just wait. I think it works for the French number and not for international. So I'm sorry. This is maybe coming from the US. I don't know. Okay, let's see. So thanks again for everything. We'll be in touch, and of course during the live surgery, you can ask questions at any time, and we will reply. There's also an online session with the YouTube channel, and it's live, and there will be questions also, and if you can check that for us first. Benesh. Thank you, and see you later. John. So John is the one who was able to set up the course since the beginning. He's a very close friend. A part is English, but sometimes French can be friend with English people also, but we are still French. So it's a great pleasure to have him all the time. He never missed any course, right?
One.
Was the best one, in fact.
Yeah. I was in the Pacific. Yeah.
And so we built up the course, by the way, together, a long time ago, 26 years. So he's a very important person for me and for the course, so it's a fantastic pleasure. He's retired, but still he has a great experience in stapes surgery. So I think he's going to talk about the basics in stapes surgery. And so I think it is important to start with the concept of the Causse clinic stapes technique, which I must say that we never present things to you saying that this is the best technique. Absolutely not. This is our technique, and just explaining why we do it. It's debatable. It's the main of this course is to debate and to talk and to give different opinions, and I think it is important to share that. It is important to disagree sometimes, not too much, please, but we can. And this we learn from the disagreement, I think, which I think should be the same in this world at the moment, but it's not. Okay, thank you. See you later.
Thanks very much, Robert. Right, it's usually my job to wake you all up. If you see me limping around, normally I jump around the stage, but I've just had some treatment to my right hip and having some problems with vision as well, so I'm not doing any more stapes surgery. I'd really just like to talk about the technique here and how perhaps some of those earlier in your career can speed up developing your skills. So the aims: to thank Robert and wake you all up, to tell a story, to issue a warning about the French and the Dutch. This course has never started on time in 26 years, which is why some of the faculty turn up late. Okay. Can we have sound? Can we have sound? No, we have to have sound. Can we have the sound? No, but it doesn't want to go on. We had it when we practiced. A couple of minutes ago. This. Let's just have a show of hands. Who of you are trainees? Hands up. No trainees. You're not a trainee. You're old. You're half as old as me. Okay, who are specialists in their first 5 years? Okay. Specialists in their first 10 years? Okay, old farts. Okay, so we're sort of aiming really at the young specialists. You can't teach the old farts anything. When I started in surgery, I was going to be the best otologist in the world. I had no doubt about it. And you very rapidly realise when you start that you make all the mistakes that your predecessors made, and you're not going to be the best otologist in the world, but you can be very good. And that's the basis of the lecture, really. How are we doing?
Sorry, I don't find why.
Yeah.
No, I don't
It's a
find
great shame because it's a great video. And it was working 5 minutes ago. I think we may just have to scrap it.
I don't know why.
Just play it and I'll talk over
If I
it.
unplug and plug.
I know the words. Just we'll do it. What's annoying is we did this 5 minutes ago and it worked.
No, I don't know why.
Okay.
I really don't know.
Okay, I'll talk over it.
I'm really sorry.
Yeah, yeah. So. Well, I'll play it anyway. Where have we gone? So anyway, this man's being chased through the jungle with machine guns, and then the tree falls. He jumps in the river and grabs hold of the tree, goes over the waterfall, escaping from the terrorists. Then he ends up in the sawmill. He's a Frenchman. And then here he is, he ends up in the bedroom of a very beautiful woman. She's in the bed and this is the husband. And he can't believe the story. Yeah. So we're pretty good about lovemaking in the UK as well. And here we are. This is what happens in the UK. I said, I can't do it. This is my dad's car. He said, oh, go on. I love you so much. And she says, no, I just can't. So he's very upset. And the father's in the front seat, says, just get on with it. Okay. So our story starts at 3:40 in the morning on the 28th of June, 1955. Does anybody know why that was a really important day in otology? Yeah, I was bored, yes, vital. But around the same time, something far more important was happening. John Shea, the father of modern stapes surgery or stapes surgery, really started getting to grips with replacing the stapes with prosthetics. And he got together with an engineer called Harry Treese. This is John Shea. He's a really handsome character, but he was rather a difficult character. He got together with Harry Treese, who was originally in the company that became Zomed Medtronic and then Medtronic. Harry Treese was an engineer, and Shea went to him on a Friday and said, I want a stapes prosthesis, and it was delivered on Monday. And they fitted it. No Food and Drug Administration. They just got on with it. And we can't listen now, unfortunately, to the video, but the video shows John Shea putting one of the first stapes prostheses in, and he talks while he's doing it, and we'll see in a second, about how he prepares the prosthesis. And he puts a notch in a piece of plastic tubing, which he snugs down onto the lenticular process of the stapes, and he bevels the end and rests it on a graft of vein. So this is 1956. We've tried every technique since then, and Nothing's changed. All we've done is fine-tune it to get very slightly better results than him. Sorry. Right, so this is a modern sports car, very efficient. How much energy do you think gets from the engine to the road? How much do you lose? Anybody know? Best German engineers, 25 to 30% of the energy from the engine is lost. Aren't we lucky? We perform a stapes operation. This is what we call a sink bodger for unblocking sinks, but this is basically what we do. We have a strut with an end on it, our vane graft, and we managed to get almost perfect sound transmission. You know, God, Allah, whoever you believe in, did a very good job of the middle ear, which makes it very easy for us, if we get it right, to get good hearing results. What are the problems we were talking about when you start up as a young trainee, as you're going to reinvent the wheel? The trouble is you only have perhaps 30 years, if you're lucky, of your adult career as a specialist. So I decided the best thing to do was go and look at somebody who was quite good at it. And I came to watch Robert in 1991, and I thought, he's all right, but I'm almost as good as that. And then I came back 2 years later, and he'd done 700 stapeses. And I thought, actually, he's very good. So I decided the best way to learn quickly was to come and watch him. Now, of course, everybody cheats, and you should never go with your friend who's got a camera, but you can see there how the French cheat. And one of the first papers that came out was Robert's first 3,000 cases, which was pretty impressive, really. And there are a couple of other important people on there, Neil Sperling and one of my trainees, Mudit Jindal, who did a lot of the research work on it. Now, has everybody heard of learning curves? This Gordon Hughes in the States decided to publish his learning curve for the first 100 stapeses. This was about 30 years ago, when the States was already having big medical legal problems. And this was his learning curve. Anything that's below the line is a failure. It's the first 100 cases. You just couldn't do this in the UK, in Europe, or North America now. If you've got that many failures, they just say, you're not going to do stapes surgery. Too many dead ears, too many problems. So we decided to look and see whether we got any better. And a well-known guy called Matthew Young, who's done a lot of work on cholesteatoma, came to me and said, let's look at our first 100 cases. He was fellowship trained. I taught myself. And this is my learning curve. Anywhere where you see the line rising is a failure. Anywhere where you see the line dropping is a success. And you can see you have to do round about 60 to 65 cases before you start getting good results. And this is a really big problem, because how do you say to the patient, I've only done 10, but I'm going to get good at it? And that's why fellowship training is quite useful. So I would say that the important things to think about are patient selection for your first one, preparation and positioning, illumination, and good instrumentation, plus a good technique. And we're going to go through each of those quickly. Pick your patient. You'd probably be better to pick somebody with bilateral disease rather than this unilateral disease, because if you've got bilateral disease and you make one ear even slightly better, they'll be pleased. Whereas if there's unilateral disease, you've got to get a good result. But we'll just show this patient who's got a good speech audiogram, and this is the loss on the one ear, and this is 3 months later. And that's a good result, and the important thing to look at is 4K. If you're getting good results at 4K, you've done your job well, and there's been relatively little trauma to the inner ear. This is in the OR, where Robert is at the moment. It's a bit like the Spanish Inquisition. They strap you down with straps. And this was my OR, with an operating table that was about 100 years old. But you just know that the gears and everything in that table would probably power a supertanker and wouldn't break. The electric tables we have now break all the time. And this is where we've picked a rather rotund pregnant patient. This is me. And this proves that you can turn the table a long way head down before the patient slips off. And this is on the left-hand side, I haven't got a laser pointer, but is a pregnancy board, and that stops you rolling off. And you'll see why we do this in a minute. Table flat, table rolled at 12 degrees. We do it because we want the speculum holder to give us a flat platform. And we want the ear canal to be perpendicular so that when we're putting the prosthesis in, it doesn't fall over. And this is quite difficult to do to begin with, but once you get used to it, it makes your ear surgery much easier. This is the speculum holder that I use over on the left-hand side. Zomed Medtronic sell it, and I find that very good, or I used. This is the Yashagil. You've probably all heard of Yashagil. He's still alive. He's 101, unless he's died in the last year. And they're both very good. The problem with the Yashagil is it sticks out. And if you're a bit porky like me, your stomach hits the speculum holder, and you see that as a vibration when you're looking through the microscope. So I would recommend the holder on the right-hand side, the Medtronic one. So you want maximum image stability, get the right speculum holder, and give yourself room to work. Now, this is how the microscope looks. You can see that the eyepieces come out on the right-hand side, and the microscope is vertical. It's not angled like you would normally think. And a ceiling-mounted microscope, preferable to one that moves around the floor, because there's always somebody kicking it at the vital minute. And here's me, and you can see, again, the vertical position. The other thing is light. Nobody's ever been able to tell me the law that dictates light down a tube. We know what dictates flow for fluids, but there isn't really a law for light. But that's a 5mm speculum. All the work here, and I think Chris Aldrin looked at it. Chris Aldrin and myself did 2 operations out of 3,000 where we had to make an endoral slit. As long as the canal's bigger than 3 to 4mm, you can do the surgery without any cuts. Cuts cause bleeding. Can you see on the 6mm side, 1mm larger, much brighter, much better view. We can argue about endoscopes later with Jose Carlos. In my practice, we used hypotension. This is a cholesteatoma operation. It doesn't take me that long to do stapes. But look at this anaesthetist. This guy is red hot, red hot. I mean, to keep a blood pressure like that for a couple of hours requires real skills. And the rule is that you must not take the systolic blood pressure any lower than the resting diastolic. If you do that, you lose cerebral autoregulation, and you end up with the patient waking up. We say gaga. We've had one patient take the other ear surgeons out of just over 5,000 who woke up a bit gaga, but he was from Burton-on-Trent, and an hour later he was eating a steak. So that's the only morbidity that we had. And all my operations, apart from laryngeal work, have been done with a laryngeal mask. It's brilliant because the patient doesn't heave or choke when they wake up. But you have to have an anaesthetist that's used to using a laryngeal mask, and you have to have an anaesthetist you're used to working with. If you're not used to working with the anaesthetist, you need an endotracheal tube. This is important, angled instruments. You can see here, I'm trying to demonstrate how little view there is using straight instruments and the difference with angled instruments. All these little things are tiny, but when you put them all together, you get a slight improvement. This changed my life. It's the KTP laser, and that's the endo otoprobe on the left-hand side. Unfortunately, now this one's not available. And this is the OmniGuide, which is a great laser, but the fibers are very expensive. Good instruments, and I'll show you how we adapt a couple. If you haven't got good instruments, you pop next door to the eye theatre and you steal one of these blades on the right-hand side. If you cut yourself with them, it bleeds for about a month. But that's very effective for doing the circumferential incision. and you can bend it yourself. And this is much better than the joint knife. This is just a little trick. If you take one thing home from this lecture, that's a crocodile forceps, and that's a keratotomy knife, again stolen from the eye surgeons, and it produces the best joint knife known to man. It goes through first time, every time, rather than poking at it. So this is the vein graft. You know, Robert and I both use vein grafts. So we take this off the dorsum of the hand and then peel off the perivenous tissue, just like pulling off a piece of toilet paper. Keep that just in case you have a hole in the drum. Split the vein and put it sticky side down, which obviously the sticky side is the outside, on a glass block. This is what we want to see when we start doing the surgery. You're doing the down the canal approach, but you want to be able to see you want to be able to see the pyramid, the tendon, the incus, and posterior crus, and the facial nerve there on the left side. If you can't see that, you're going to have problems. So there's the joint knife that I just showed you, dividing the joint. You cannot decide whether a stapes is fixed without dividing the incustopedial joint. Many of the revisions that I've done and Robert has done have been, they haven't had the joint divided. The surgeon hasn't therefore been able to make his mind up where the fixation is in the ossicular chain. So it's not a failure, it's a failure of technique, not a failure in any other way. So this can show you what a good camera will do. You can see the rouleau. And this is there's a little trick. I want to go back to the previous one. There's a little trick, that's about the only thing I've ever managed to teach Robert, is if you lift the incus, you get the joint sucks in, and the joint is always a little bit further down on the lenticular process than you think it is. But once you've done that, you're able to divide the joint, and then you can assess mobility. So there we are. The incus is moving, and we now want to do lateral movement of the stapes and pressure on the top of the stapes. Here's the lateral movement. Looks pretty fixed. And the all-important pressure on the capitulum. So we decided it is otosclerosis, we're going to proceed. I use the laser to divide the tendon, Robert uses the scissors, doesn't really matter. We've tried reconstructing the tendon, it doesn't work. Subiculum down the right side, but that's not causing a problem, but I've just decided to remove it there to give me a bit more space. And you can see how accurate the laser is. But a lot of us are not able to use the laser now really because of the cost of the fibres, which is a bit of a shame. Because you wouldn't tell an orthopaedic surgeon he couldn't use an instrument. So we're going through the posterior crust. You can sometimes get at the anterior crust with the laser. Pointing away from the facial nerve. I've got a couple of facial palsies I'll tell you about at the end. And then the microdrill or the pick. Off goes the superstructure and gives a clear view of the footplate. Not always. So now we're going to form a rosette. 1 watt, 0.2 of a second with a KCP. Wilco might mention lasers and penetration, but the CO2 laser is definitely safer than the KTP, which is safer than the diode laser. I think that's right, isn't it, Wilco? So there's our rosette, and we're really going to use the microdrill just to blow away the char. We're not making a hole with it, we're just fanning away the char. And the B&Air microdrill is the best. The Medtronic was the best, but they've now got disposable burrs and they wobble. Now measuring the distance between the surface of the fluid. You have to measure once you've made the hole, not before you've made the hole. These are the two prostheses that we use. That's the large loop Causse prosthesis at the top and the bucket handle. And we'll explain why we use what in a minute. And that's the cutting block. So here's the bucket handle going in, and you would use this if you have a short incus and the lenticular process overhangs the foot plate. Down onto the vein graft. And then, quite difficult this, you have to lift the incus while you're moving. It's a bit like patting your head and rubbing your tummy. You have to lift the incus while you're moving the prosthesis. The bucket handle doesn't really matter. It doesn't really do anything. But it's there, so if you can get it into position, fine. And then we do spreading the graft, which you'll see Robert do, and we do what's called the bending sign. If you bend it and it bends, it must be in the hole. If it flicks out, you're too short. But with this technique, you measure the prosthesis exactly the length, so it's only just into the perilymph. It's pushed a little bit of vein in. If it's too long, you'll see the vein tent like an umbrella. I'm not sure where I'm doing this one. That slides the wrong way round. Should have been the first one. That's spreading the graft again. You have to try and remember in your brain where the hole is. Yep. Sticky side. Outside down. But for the first 100, I got it the wrong way around. It made no difference. So you can, pay your money and take your choices. Yeah, my terrible results. Wilco's going to blow all what I've said out of the water in about half an hour's time anyway. So, right. And there we are. I think you can just about see a round window reflex. Don't normally check it unless I have medical students who want to see it. And just to prove that I can put a prosthesis on, a loop prosthesis, the important thing here is that you face the loop up to the attic, because if you face it the other way, it'll catch on the lenticular process. And this is the critical part of the operation where your heart's in your heart's in your throat, and you think, for God, I want to finish this operation, I want to get a good result, and you start fiddling around, and it just starts the adrenaline flowing and makes things difficult. If you haven't given that view that I showed you to begin with, you won't be able to get the instruments in, so you do need to make sure that little bit of scutal bone has been removed. So lift and push at the same time, and there's a thing called the moment of a couple. You probably saw that at the beginning. And there we are. That's in a nice position. And if you've removed the right amount of bone, you can get the crimper in. Robert does it with 2 needles, very impressive, but not for the faint-hearted. And you see there we've got enough room for the lower part of the crimper to get in. And it doesn't want to be over-crimped, just a light crimp. Okay, so this is my series. Sensory needle loss greater than 20 dB was 0.7%, pretty good. Vertigo, 0.5%. Dead ears due to surgery, it's debatable whether they all were, because one patient was seen using a cotton bud on the day after surgery, and another one had a road traffic accident. But I don't actually believe that any form of road traffic accident will shift a prosthesis, because the mass is so low. So I think probably 4 dead ears due to surgery, out of 1,400. And then 3 facial nerve weaknesses. One using a British NHS needle that had got a barb on it that I think caught the undersurface of the facial nerve when I was removing the superstructure, and 2 due to the laser, one of which didn't get better and the woman never came back again, so I don't know what happened to her. The other woman got a facial palsy that lasted for over a year. She got complete recovery, despite the fact the neurophysiologist told me it was never going to work again. I nearly gave up stapes surgery. And the second one, the laser got knocked. It was attached to a floor-mounted microscope, and one of the nurses tripped over it at the vital at the vital technique, and I think I probably lasered the facial nerve, but that got better. Tinnitus, one of which was suicidal. Perfect hearing result across the board between 0 and 5 dB, but uncontrollable high-pitched tinnitus, despite really good result at 4K, so we don't know why that happened. But her family came to see me afterwards and said, don't worry, she's had some mental illness problems, she's had some alcohol problems, and her son's just died, and this was just the final straw. We said the final straw that broke the camel's back. So, unfortunately, we can't show this. It's a very funny video, but maybe another time. Thanks very much. I don't know whether we're ready to go to the block or whether we should have a quick question and answer. At the back? Yeah. Is somebody going to do the microphones? Pass the microphone. We've got a... Okay, shout loud. I can't hear. Sorry, I can't hear from here. Could you give him a microphone? Yeah.
I want to thank you for a great presentation. My name is Bob Owens. I'm a otologist from Dallas, Fort Worth. I wanted to remark that the dead ear, I think that's a very common incidence of dead ear, at least in my experience, my personal experience and my training. The only people who have less dead ears apparently is my competitors across town that claim 1 in 22,000, which I find interesting.
Absolutely. I mean, I say to patients, and on several websites I'm involved with, if your surgeon tells you he's never had a failure with stapes surgery, he's either lying, he's fooling himself, or he hasn't done enough. You know, we all get failures, even Robert. Robert's failure rate is 0.03% reported. So I think probably 0.03, 0.3. So I think probably 0.3, 0.4. I would expect a very good stapes surgeon to be less than 1%. But everybody quotes 1% as a generic figure. And we all know that it's not 1%. There are colleagues that get a 5% failure rate. So you have to say, are these your results or are these your departmental results? Because one good guy in the department can lift the figures of everybody. Good question.
We quote 1 in 3, 1 in 350.
Yeah.
And I think that's
realistic.
accurate.
That's realistic, and you're being honest, and the patient believes you then, if you say, I've never had a failure. Right, okay. I have actually. I mean, the whole reason I started using bucket handles was because I thought it might prevent necrosis. But I've had 2 or 3 in the series. Certainly less than the ones that get necrosis of the long process.
And how did you come to know post-operative, and how did you manage that?
Well, you have to go back in, and then you're going to... I don't want to spoil what Robert's going to do, because I don't know what the revision is, but you may well have heard of the operation of malleus relocation. He and I would do a malleus relocation with a malleostapedotomy. But again, not for the faint-hearted. That's one to be referred to your colleague who's skilled in that technique. And the results are still very good. But you have to remember that you've got a slightly different situation then. You've effectively got a vertical strut going down into the foot plate. And it does mean that if they start fooling about with cotton buds or doing anything stupid like that, they can get the prosthesis pushed into the vestibule. But it does give very good hearing results.
Thank you so much.
Yep, go ahead.
Excellent talk. One thing I do a little bit different is that I place the patient like you in a Trendelenburg position, but turn the patient towards me. I see that you do the opposite. So, because the stapes is a posterior structure, so when I turn it, I see the ear canal better. So you see more direct. I think when we turn it, we can see it better. But
I must admit, I've never tried. You know, it works. Is the block ready? Right, we're ready to go to the block. You won't see this again. This is the revision, but you will see it in the primary surgery. He'll do exactly what I did there, I think. This is an interactive meeting, so this is really good. Normally people don't start asking questions at this stage, but we must do this because it makes much more fun. Okay, the block.
And it's absolutely important is if there are any questions, please don't hesitate, ask. Okay, a little bit down, put the noise down. And we now go to the block.
Il faut me filmer moi là maintenant.
Robert is going to show you how he's going to harvest the vein. Robert?
Yes, can you hear me?
No, not really. Yes, of course. Yes, very good.
Okay. I'm not sure you understand what I'm saying because I'm speaking English. You don't speak English, do you?
No, not very much, sir.
Not very much. Okay, it's a pleasure again. So this is the beginning of the revision stapes operation. Tu peux baisser le son là parce que j'ai un retour. So of course I will start by the vein graft deposition. Just a few words about the case. This is something like 75-year-old male. Has been operated 2 times on his right ear by another surgeon. And if I understand the history, because I don't have any file, there was immediate failure the first time. So then it was revised, I think, 5-6 years after. And again, there was an immediate failure. And the CT scan shows a dislocated prosthesis. So I think, because we have quite a large airborne gap, but mainly on the high frequencies, which is important for me, because it's related usually when it's larger on the high frequencies. My experience, it's more related to dislocated prosthesis, and especially with eroded incus. So I think probably, but we will see, of course, we'll discover everything operatively. What I think is that probably there was a partial erosion of the incus during the revision operation, and maybe the surgeon tried to reattach the prosthesis to the residual incus, but we will see. So if it is the case, of course, I would do a malleus to stapedotomy procedure. So I use vein graft interposition, which is one of the bases of the Causse technique, introduced by Jean-René Causse and then Jean-Bernard Causse. I will find the vein here and then dissect it and use it to seal the labyrinth. So you understand that the aim of this technique is not to improve the results. I think it is important to say that. It doesn't make any difference in terms of hearing outcomes between interposition or not interposition. I believe in this for sure. So what I try to do here with this technique, which I believe was a very nice one when I started using it, is to seal the labyrinth, to be sure that we will avoid any fluid leakage post-operatively. I know that many of my friends and colleagues, and including the faculty here, do not use interposition, and they are very happy without any increased incidence of fistula, which probably is true. The difference is that in this technique, we perform a 0.8, I am talking about the primary, of course, or 0.8 millimeter fenestra, which is covered by the vein, and then I use 0.4 millimeter diameter Teflon piston, which is completely different if you do not interpose something. I think probably you do a 0.8 millimeter stapedotomy, and then you use a 0.6 millimeter diameter piston. But here we have to take into account the thickness of the vein, so this is why I still use 0.4 millimeter.
Robert, can you tell me what the suture material is that you're using? Yeah.
Again,
monochrome? Because with this technique, it's a brilliant technique and I use it, but the female patients in particular complain about even the smallest scar on the back of their hand.
Yes, that's right.
And occasionally they get a little lump where the suture is. Yeah, no, we left it. Yeah, where the suture is. And of course, the other thing is, if the clip comes off, you lose the vein. They get a hematoma on the back of the hand, so you do have to be quite careful.
Well, I know that. I always think that the British are more complicated
than
the French.
We're incompetent, yeah.
No, yeah, of course. So I do a horizontal incision, a very small one. So only one stitch.
That's the first conclusion of the meeting.
And then you need to follow the line, the natural line of the skin, which is usually like this. So if you do a vertical incision like this, transversal, I don't think is the best. Horizontal incision is better.
And Robert,
So-
sometimes you see those huge veins on the hand. I see you take a pretty big vein now.
Yes.
No, he's a big vein. Do you always take the biggest vein that you see in the hand, or
Sorry?
do you always take the biggest vein that you see in the hand?
Not always. I try to find the best one. Sometimes you don't have the choice. All of them are very thin, so you have to take one of them. And sometimes one of them is too big, and then I try to find average, I would say. But if it's a big one, if a large one, there's no choice. You have to take it. Encore, allez-y. And then I press it. I put it on the press to decrease the thickness of the vein. That is important.
Okay.
So I do transcanal approach, of course. But the problem with this
we're now
patient
doing
is
wrong OR. This is a very brute stapedotomy.
no. We have to go back to my OR.
Tell
Là,
me
il
in
se trompe là en
French.
bas, hein. Il se trompe là. Il a basculé sur l'autre. Oh, okay. All right.
Yeah.
Okay, so I do transcanal approach. The problem that I have with this patient is that we have quite an old person, and he has a very difficult neck to move. So usually I like to place the head on hyperextension, but it's going to be a problem here with this patient. So I will probably have to move the whole table. We have a setting here which is very nice. Means that the head of this table is separated from the body of the table, so we can move separately. So I try to hold the vein with this small instrument, and I will give it to my nurse. She will hold it. Céline, that's her name, and I work with her since now the beginning. Which means we are making such a kind of a couple, fighting sometimes together, which is good, but she's very, very good. So this is the vein, and we are facing at the moment the lateral side of the vein, which is the adventitial side, the sticky side of the vein. And of course, I'm going to use this side to stick the vein to the full plate. So first, we need to...
And this is a glass plate, eh, Robert?
Yes, yeah, with a hole in the middle to pre-shape the vein.
Yeah.
So first, I will remove some perivenous connective tissues. I have to dissect this to get only the vein itself thin enough to be used. And you see the difference now already. It's much better. So it's going to be okay. And now I'm going to cut the vein itself. And of course, I will open the vein now, and I will face the intima in a second. So I will cut it like this, transversally. I didn't make it well. Okay, fine. So now I'm opening the vein, placing the adventitial side of the vein, the glass plate like this. So now we are facing the intima of the vein over the hole, which is going to be used to pre-shape the vein. So usually I use such size like this, but this one I will take a longer one in case of malus to stapedotomy procedure. So the thing which is debatable is the interposition for sure, for primary or any other type of stapy surgery. But I'm pretty sure that if we do a malus to stapedotomy procedure, we really need to interpose something. And the vein is a real very nice material compared to pericardial fascia because it's very elastic. So you see, I push the vein down into the hole. So, and now we're going to wait until the end, so the patron will stay wet while the external part will dry. Ok. Montrez la table, s'il vous plaît. On ne peut pas basculer du tout la tête, hein, c'est pas possible.
What I can say, the OR table here is still quite old, but it's much better than, I mean, I've worked all my life in academia, and then you don't have the chance or the possibility to adjust the patient exactly the way you like it. Yeah. Here it's, I mean, you can rotate the head, you can rotate the patient. It's old, but it's much more functional than the modern electric tables.
Yes, absolutely. That's
They
right.
threw my table away the day I retired. For health and safety reasons, apparently it wasn't strong enough, but actually it was 10 times as strong as the electric one. What you were saying about the interposition with a malleus stapedotomy, if I can just explain, with the malleus stapedotomy, the prosthesis is quite heavy, and therefore you need to stop it prolapsing into the vestibule. So you have to have an interposition.
Yes.
With the technique here, you would not be able to do it without a vein graft.
Yeah. So I'm now infiltrating the ear canal. One infiltration at 12 o'clock and the other one at 6. It's a mixture of xylocaine adrenaline, 1% adrenaline.
You know
I
the
know
questions.
the question. I know the question. Well, it's just a stupid question from the British guy close to you about
I've
the
taken away the
Vicryl.
microphone.
It's always there to ask difficult questions for me. I know, since the beginning it's the same.
Robert, what's the blood pressure?
The blood pressure, well, thanks to the anesthesia, demande la pression. On est à combien? 70 systolic, which is the best way to do it. And
For
we
the
have
surgeon.
yeah, but the anesthesia, they understand that. We have a nice anesthetic group now, and they are working very good. The only problem also, the second problem that I have, we can see a kind of exostosis here anterior to the canal. So I will see if I have to drill out this exostosis. Maybe not. I will see. I will try not to drill it now. I don't like to drill when I perform stapedotomy, stapes surgery. But anyway, maybe I will have to.
So
So
what you're doing now, you're changing the size of the speculum, huh?
Yes, and now I found the right one, and I'm fixing everything with a speculum holder. Maybe at the end of a procedure, I will show you the setting with the speculum holder. And the thing is that we have a plate which is placed underneath the head of a patient, and this speculum holder goes into the plate, and there's several joints which I can use to fix the speculum. And the point is that we have both hands free.
Robert, can we have one moment an overview of the OR so you can see what your working position is?
You want to see it now? Okay.
Yes.
Est-ce qu'on peut passer sur la vue du bloc, s'il vous plaît?
No,
caméra de champ. Allez-y.
But have a look. He works straight down, if you can see that, and that's actually very important for the working position in this technique. And
I think it is important to explain that. So this is the speculum inside the canal with a speculum holder. I fix it with this screw, and we have two more screws here to fix it in a nice position. So it's very stable, as you can see, and another one here. And this is this part which is fixed, introduced underneath the head of a patient in the plate, underneath the head of a patient. I can move it like this. It's a nice
And
setting,
can you
I
show
think.
the small cushion on your left elbow?
Oh yeah, this is for just. I like to have this stability here with my left hand, and the right arm is stable on the patient. This is the position. In my opinion, if we do transcanal approach, pure transcanal, same as for endoscopy, minimally invasive surgical approach, I think you need to be in this position. The patient needs to be lying down, and you need to be perpendicular to the patient. That's what I mean. And the fact that we have this speculum and the speculum holder gives me a lot of stability, a high stability of my hands. Now I'm getting older, I need more stable things than before.
And you use it also with the curette, eh?
Yes. And then you can do everything, and you use the anterior part of a speculum to push and to stabilize your instrument. It's kind of a platform which gives me the possibility. You will see that probably, the position of the finger.
Can we say hi to Celine while we're there?
Yes, we can say hi to Celine. I will show you.
Bonjour.
And our anesthesia team. And she's very, very good and ready. She speaks a bit English now. You improve your English. Yeah. By the way, she speaks Spanish. So Jose Carlos, you have to speak Spanish.
If I can just say, if you look at where Robert and Celine are, because there's a ceiling-mounted microscope, they're in a much more comfortable position and are able to have the table, the instruments on Robert's left side, so Celine can reach them straight away rather than reaching around a microscope and knocking it. So a ceiling-mounted microscope is a great benefit. It also means that no other surgeons will come to your theatre. General surgeons think it's the spawn of the devil.
Le cadenas, je vais montrer le... Oui, vaut mieux. So this is right here. So I show you the landmarks. This is 12 o'clock, 3 o'clock, 6, and 9 o'clock. So we can see the tympanic membrane here. This exostosis there and a little bit there. So that might be some kind of problem. We'll see. Anyway, so I will do, as usual, an incision running from 6 to 12. So this is 12, and I go back to 6 like this. It's a little bit more, of course. It's like from 5 o'clock to 1 o'clock, and the skin is not so good, so I need to take care of this. I can feel it. It's a very bad skin.
Very
So
thin.
now I will elevate the flap, and I use a smooth elevator. And I take my time to do it because of the poor quality of the skin. So a good trick when you use the sucker, you see I have both hands free, which means that I'm using the smooth elevator on my right hand and the suction on my left hand. So that's important, I think. Ciseaux. And if you use the sucker, which I control with a foot pedal, maybe John, you can explain that is a negative pressure.
Yeah, it's
System.
essential. This surgery is much more difficult if you don't have a foot regulator for the pressure of the suction, which is handy to have. I'm always surprised how big your suction is anyway. I always use a much smaller one in this stage. What size suction do you use at the moment, Robert?
At the moment, c'est un 12, ça, non? C'est ça? It's a 1.5, 15. But you see the position, I don't suck directly to the skin. I suck just behind the elevator.
What's very important for the audience is when he said he goes a little beyond 12 o'clock and 6
Direct, s'il vous
o'clock.
plaît.
If you go slightly beyond with your circumferential incision, the drum doesn't keep dropping backwards into the field of view. If you just go from 12 to 6, it's a nuisance. It gets in the way.
So I have to change the elevator because it is very narrow here due to the exostosis. And you see again the way I'm sucking, not to the skin. Now I'm following a kind of horizontal line to get a horizontal elevation of the tympanomeatal flap. Table vers moi, s'il vous plaît. Now I'm going to find the annulus. Table vers moi. And I will open up the middle cleft.
You're turning the table towards
Stop,
you, huh?
Stop. Wait. Yeah, I can move the table. Not myself.
No, you turn the table a little bit towards you to see the rim.
Yeah, I try to move that a little bit in a second. Non, je pense que je vais prendre le cannelé, s'il vous plaît. Okay. Okay, let me see. This exostosis, the posterior exostosis is hiding a little bit the exposure. Cannelé. So now I can undo that, s'il vous plaît. So I decrease now the diameter of the sucker. It's bleeding a little bit, but not much. And now I need to identify the annulus, and then open up the mucosa. That's it. This is the mucosa here. So now I can open up the mucosa and try to enter the middle cleft. Okay. Décolleur encore. And now I need to do the same to the right. There we go. Now
There's a question, Robert, there's a question.
Yes.
Dr. Robert, Dr. Sharafuddin from India. Do you have any preference to enter into the middle ear? Above the caudal eminence or below the caudal eminence?
Oh yeah.
Which area you prefer to enter into?
You have to, of course, expose the chorda tympani. I didn't see it. Maybe it has been cut. I have to check that. And then you need to open the mucosa over over the chorda. Okay, between the annulus and the chorda tympani. But in this case, because it's a revision, I don't see the chorda anymore. So it's probably have been cut before. Plaron? I don't know. Is that your question? Yes?
In primary case, you prefer to enter just above the caudal entry or below the caudal entry? To enter into the middle ear? Above?
No, above.
Always.
Always.
Above. Okay.
Yeah. Bon, I have to move the table. Montez la table, s'il vous plaît. Because I cannot, as you can see, I'm now over the round window and the promontory. I don't have any access at the moment to the oval window. So I need to change. And I need, unfortunately, to move the whole table down, which is not so good for the bleeding, but that's the only way, because I cannot move the head separately. Allez-y, basculez la table, s'il vous plaît. Encore un peu, ouais. Allez-y, allez-y. Encore. Stop. Je vais voir où j'en suis là. Qu'est-ce que ça me donne ça? Ouais, c'est un peu mieux. On va voir. So it's slightly better. Now you see we're moving towards the over window. Plaron, s'il vous plaît. And of course, if I do malus to stapedotomy, I will do the malus reposition. relocation technique. Okay, so let's see what we have. So I have to move the table more. Montez la table encore, s'il vous plaît. Stop, table encore en déclive. Stop. So you can probably see the strange position of the table there, which is a very strange position of the patient, but that's the only way to deal with. You see how it is, like this. Okay, now I think it's pretty good. The first
Robert,
thing that I would say by seeing this is that we have not a very good view
no.
of the oval window. I think the incus is intact or maybe partially eroded. This is the incus. This is the previous prosthesis. That is 0.6 millimeter. And I think, in my opinion, the bony rim resection was not large enough because you cannot really see the posterior part of a foot.
Is this your own revision, Robert? Or?
No. It's a never surgeon.
Okay.
It's a
Because
0.6 millimeter.
we frequently see in case like this that the exposure has never been sufficient.
Yes, that's what I say.
Yeah, no, it's frequently that we see that, no, in revisions.
Lancez les coudées, s'il vous plaît. So I need to, this is of course, you can see the bleeding is worse because of course of the position of the body. So all the blood is going down, but if we do transcanal, there's no other way to deal with this rather than changing the position of the whole body. Ciseaux, s'il vous plaît. Bon, ça saigne un peu là quand même. Hein? Okay, I need to cut this to have a better exposure of the superior angle. Okay, bleeding is
quite
really
a bit of
bad.
bleeding.
But
Yeah.
anyway,
Yeah.
we'll see. We have to deal with this. This is something that's it's good to show how to deal with bleeding like this. Décolleur, s'il vous plaît. Non, calmez, pardon.
I think this is really important for all of us because we've all got great potted video, like mine, of an operation that goes perfectly. But it's much more important to see how a colleague handles a difficult situation.
Yeah, sure. Correct. So again, I want to increase this bony rim resection, including this part of the exostosis. So I will remove it with the curette, which is a very nice and efficient instrument, as you can see, very strong. It's a French company. It's called Integra, and they are close to Nice. All the instruments we are using are coming from Integra. I will decrease the zoom so you can have a better view of what I'm doing.
There's no way that you can show us how you use it as a lever on the speculum.
I will explain maybe if you
Okay.
remind me at the end.
Yeah.
Okay.
Yeah.
So I can show you that from the outside. Yes, I can do that.
You're so much more efficient doing that.
Oh
than
yeah, that's
anybody
important
else.
to show that.
Yeah.
It's some tricks that the position of the hand and everything. You know, I learned everything with Jean-Bernard Causse at the beginning, and it was starting by the position of the finger to try to find the right stability of the finger, and I think it was very important. So there is no chorda tympani, as you can see, so it has been cut. I think probably. Okay, now I'm increasing now the bony rim resection. We're starting to see now the posterior half of the foot plate, which is becoming better. And I will remove the prosthesis in a second.
And do you ever use a chisel, Robert?
Sorry?
Do you ever use a chisel to go there?
I do sometimes, but I don't like too much, as you know. I prefer to use curette. You know, the chisels, it's good, it's efficient, but sometimes it can go directly straight to the facial nerve, and the ossicular chain, the incus. Pardon, s'il vous plaît. So I prefer to use the curette, which takes a little bit more time, but I think it's safer. Okay, so first, of course, I remove the prosthesis for sure. This is, as I said, 0.6 millimeter diameter Teflon prosthesis, which means that probably there was no interposition in this case. So I'm going to remove this prosthesis now. S'il vous plaît. Attendez, je vais voir si je peux l'attraper comme ça. Yeah, okay, it's coming. All right, pretty narrow as you can see. Now, what I need to do is to check the incus now, because you notice that the incus was with some fibrous tissue all around. So, c'est un 12, hein, ça? C'est ça? Ouais. Okay, so let's see the. Ça saigne beaucoup toujours là. Hein? Je sais pas si.
He's complaining that it's bleeding.
Yeah, yeah. Well, I'm just. Well, she does the best, and it's
Yeah, of
not
course,
so
of
easy.
course.
And I'm in the position of the patient is bad.
You're
If
in
it was in
you're
a
in
regular one,
Trendelenburg. Yeah.
yeah.
So that's
Yeah.
of course
So
the
I
blood
try
goes
to
down. Yeah.
increase maybe the light. So
You can't
maybe
go
the
any lower than 70 with a 75-year-old man. That's
okay. Let me check now the
getting to tiger
incus.
country.
I have some difficulties to see all the landmarks. Can you show some
Yeah.
landmarks?
Give me 1 minute. I just want to dissect the incus, and then I'll
Okay.
show the landmarks. Okay?
Yeah.
Calmez, s'il vous plaît. Okay, so the incus is there, and I try to see if we can use the incus or not. There's a strange mobility of the incus at the moment. I can feel that, so maybe we have a...
Disconnected, maybe. Yeah.
Yes, I think that's what we have. Partial erosion of the incus also, I'll show you in
Yeah.
a minute.
But clearly the piston was dislodged, so that's
Yeah, you can see the movement of the incus, which is very strange. You know, it's not normal to have that. So the bleeding is coming from the flap, in fact, which is always more difficult to deal with. Ciseaux, s'il vous plaît. Okay, now you see incus is separated from the tympanic membrane. It's very strange. The movement is strange. I don't like this, the fact that it's loose like this. This is not a good sign.
Can you move the malleus?
I did. It seems to work fine, but there's a high mobility of the incus.
Yeah.
I don't like it. I don't like it. And this is the partial erosion, okay?
Yeah.
But I don't like this. Usually you cannot make like this so freely. You understand what I mean?
Yeah. It's quite mobile. Yeah.
Yes, it's a little bit loose.
Yeah.
So I'm pretty sure there is a dislocation. But anyway, we'll see in a second. Now I'm going to show you the landmarks as you asked.
Yes, please.
The one I like to have is the facial nerve on the left. Respiration, s'il vous plaît. In fact, in this case, when you do revision like this, sometimes it's quite difficult to understand the anatomy. In this case, everything is, complicated. So we have to check the anatomical landmarks, which are the facial nerve here, the fallopian canal,
Yeah.
which is not decent, and then the promontory here.
Yeah.
Okay, so everything is fine, and we have some kind of interposition, so thick one.
Yeah.
So we'll have to dissect this, but not now. I need to check if I have to remove the incus or not. So let me see. I need to increase the bony rim resection. Un 12, s'il vous plaît. Ça c'est beaucoup, mais bon, de toute façon, il n'y a pas de solution là.
But it's incredible how minimal exposure there was at the original
Correct.
surgery.
Yes. The exposure was not good, I think.
Was it an endural or also a transcanal exposure?
I don't know. I don't have any information about the previous operation. No file. Because it was a long time ago.
Okay.
It was something like more than 10 years, 15 years.
Okay.
Okay, so I need to check. You can see the joint now between malleus and incus.
Yeah.
I enlarge it a little bit to check this joint, which I don't usually do, but can I just want to make a decision now to remove the incus or not. We have here the there is a dislocation here between in the joint here. You see, you can't see it very well, but they are moving separately. And you see what I'm doing here. This is not normal to see that. So I need to remove it anyway. I make a decision of that. Okay, so it's debatable. I'm sure some surgeon would not remove it for sure. Some surgeon would probably use semen to rebuild the incus and put a piston, but I'm not going to do it. I'm going to perform malleus epidotomy. Il faut me remettre tout là parce que c'est tout parti là-dessous.
Can you center?
Yeah, 1 second. Well, the bleeding is a real issue, as you can see. We don't see anything, but it's a mer rouge, as you know.
Yes.
A long time ago. Okay, so first step here before removing the incus is to dissect the malleus because I want to do the malleus relocation. So first is to separate the malleus from the tympanic membrane. Table en avant, s'il vous plaît.
So he's turning the table then forward.
Encore. Stop. Now, of course, the anterior exostosis might be a problem for me, but we will see. Okay. Canne du marteau. Well, I try to increase the light because I can see it's pretty dark for you.
No, the quality is pretty okay. It's
I can't
it's a big
do
flap.
much better than this because
Yeah.
you know it's what we have, what I have also. In fact,
Yeah.
this is the malleus there. So I keep the incus in position because in fact this helps me to dissect the malleus. Because if you remove the incus, then the malleus is a little bit more loose, and it's more difficult, more tricky to dissect the malleus. So what I want to do first is to make an incision through the periosteum of the malleus. So again, in this position, I need to have both hands free. So I make the incision along the
With the needle.
periosteum with the needle which is bent at the distal tip. You see that? And I'm going to try to go anterior to the malleus in a second, but first I'm going to the umbo in a second. Also, the umbo is always a problem because it's very tightly fixed to the umbo. C'est un 12 que j'ai là, c'est ça? So you see, I need to follow the bone. So the connection, the contact with the bone is important every time, all along. And we continue to go. The problem is it's difficult here because I don't see, because of the anterior exostosis, decreasing the view. So I need to do it.
At what time you would consider to remove the exostosis?
Well, we can, but you know, I think I don't like to drill out bone when I do stapes surgery. It's making a lot of vibration, and I prefer not to do it if I can. If it's necessary, if I have a big exostosis, then usually now I stage the surgery. I have one case long time ago of sensory or hearing loss following primary operation, in which I had to drill out the canal because there was exostosis. So you know, when you have experience like this, you remember it forever.
Exactly.
And you change the facts. And I prefer. Maybe it's not related to this, but I don't want to take any risk.
Yeah. Superstition.
Okay. Yes. Something like that. So that's some kind of fibrous tissue again. Maybe some residual.
That's the Gorda. That's the Gorda.
Yeah, but it's an old one. Curette.
Yeah. Yeah.
Okay. Now let's go to the neck of the malleus. The malleus handle has been separated already. Definitely a bad bleeding. Eh?
Well, our view is still good, but I know it's difficult for you. Yeah.
Yeah, for you it's good.
We're relaxed.
Okay, now I'm going to the neck of the malleus, and I think it's done. The entire malleus is separated. Now I can remove the incus. Crochet, s'il vous plaît.
So that's the big hook, eh?
Yes, 90-degree hook. So I can remove like this. And now I will have to relocate the malleus. And to do this, we need to, of course, cut first the tensiotympani tendon. At this stage now, the malleus is attached by the anterior ligament, the superior ligament, and the tensiotympani tendon. So if I really want to relocate the malleus, which means that you change completely the position of the malleus, which is really anterior in this case, you can see that. It's above the fistula antefenestrum. So I will cut now the tensiotympani tendon like this. And now we need to overstretch.
Can you center?
We need to overstretch the anterior tympanomalleal ligament. Is the picture good for you? I'm sorry about the
good picture.
The darkness of
You
that.
know,
So
Robert, notice
putting
Robert puts the hook right up by the
close
neck.
to the neck.
Otherwise, you fracture the malleus. You're good.
Two points, in fact. So you have to put it, as John said, close to the neck, and then just put the sucker on the other side so you can control the movement. So I'm trying to, overstretch the anterior ligament like this. And now I will place the malleus wherever I want. This is the new position now of the malleus. And I'm going to measure the distance between malleus to footplate later on. But first, I need to check if the tympanic membrane is intact. Because sometimes there is always a risk of making a tear. So I will reposition the tympanomeatal flap. But you see, everything is fine. There is no tear. Okay, fine. All right. So now next step is to work on the over window to find the previous fenestra, which I reopen all the time. Table vers moi. Stop. Okay, so un 9 s'il vous plaît. C'est un coussin 9 ça? Ouais. So now I'm using 0.9 millimeter diameter suction tube. It's a huge interposition. I don't know, it's a mixture of cartilage and fibrous tissue. Unfortunately, I had the laser, but it cannot use it for some specific reason. So I will have to dissect that with a micro hook. I think it's a good way to show this because some people do not have lasers. So I think you have to know how to deal with this. The way I do, so I try to find some kind of gap between the promontory here like this and the previous interposition. Put a micro hook like this and try to remove it. Of course, and this is the opening. You can see that already some fluid coming out. Of course, you need to remember where the facial nerve is, and you don't want to elevate everything towards the facial nerve. So I stay from posterior part of a foot plate to the anterior part of a foot plate. It's pretty thick. And the interposition was
the
not
whole foot plate is the whole foot plate has been taken out.
It looks not completely, but nearly, yes.
Yeah.
And of course, the other problem is that I don't want to suck into the labyrinth now, of course. So let's put this tissue away because I need to get some.
The good thing here is there's no fibrous tissue going down into the labyrinth. That would be very difficult.
Which is good.
No, it's completely removed. Yeah.
Okay, now I think it's fine. And you see it's a lot of kind of a pressure inside the labyrinth. You see that? Not a gusher, but it's quite high pressure. So now I'm going to use a 0.7 millimeter.
Robert, the head is down as well.
Yes, sure. Both. Yeah, that's right. Good point.
Thank you.
At last. All right. So the problem is that the bleeding is going over it, but there's no way to change that. I cannot do anything if I change the position of the body. Okay, so let's now measure the distance. Crochet, s'il vous plaît. So I bring the malleus posterior like this. So you see, you can really place the malleus wherever you want. That's a big difference. So you don't care anymore about the malleus.
So, Robert,
and then I will measure now.
The blood supply is coming in now through the superior ligament. That's all.
Yes.
And have you seen any malleus necrosis in the past or not?
No.
Okay.
Never. It happened with when I was using a Teflon piston, a malleus piston, in a few cases, but not due to the malleus relocation. So this is an elongated tape measuring rod. You can see we have 4 notches. The second one is in front of the malleus, which means 6 millimeter. The lower one is 5. So it's not the basic stapes measuring rod, which runs from 3.5 to 4.5. This is running from 5 to 8. So we've got the malleus there, and the second notch is in front of the malleus, which means 6. But I'm going to use a torp, which has a groove at the center of the prosthesis head. So I need to take into account the deepness of the groove, which is 0.5. So I always add 0.5, which means I measured 6, and I will cut the prosthesis at 6.5.
Well, you need to explain that later again, because
yeah. Okay, I'll show the prosthesis. You understand that?
Yeah.
So now we need to interpose the vein. So the vein here is pre-shaped. You know what I mean? It's pretty good.
It's too light.
Yeah, too light. Yeah, that's better now, right? Is it better?
Yeah, better.
Okay.
What he's going to do now looks very easy, but it's not. It's so easy to damage the vein.
Yes, that's right.
And the way you fold it onto your sucker.
But you see the patron is still wet.
Yeah, exactly.
And only the external part will dry like this, and which is good.
And
when you have
It's big, relatively big.
Yeah,
Yeah.
yeah. But I think I took a larger one because I was thinking that might be a torp. I'm holding it with a sucker 0.9.
And this is his interrupter sucker. So when he gets it in position, he will press the foot pedal, and it will stop the suction.
Je sais pas comment on va faire là parce que j'ai la veine dedans.
Even
Ben ouais,
better
là,
if you
j'ai
can
du-
have positive pressure, then go
Le problème
down.
c'est que si j'arrête de... Ok, bon ça fait rien, je peux pas faire autrement que de la mettre comme ça. Ok, I will introduce the vein. Unfortunately, I cannot remove
No.
the blood, so I need to place the vein over it, and I push everything, and the blood will go down, will go away, like this. Okay, I'm introducing it with the sucker like this. It goes down to the oval window. I'm stretching it. That's important to take a little bit of time for this. And now I will place the prosthesis. The bleeding is over it. It's nightmare, this bleeding, a nightmare.
But like you said, it's a good demonstration to show when it's difficult.
Yeah, I agree. But the problem for you is that the picture is not that good, of
but-
course. It's very dark due
no.
to the...
Yeah,
Anyway,
but we'll see it in the other surgery.
yeah.
But
For sure,
you close the diaphragm for the thing. Can you open it a bit to make it a little bit lighter?
Yeah, I will. Yeah, sure. Okay.
Yeah.
But it's very red, and I'm sorry about that. I
Yeah.
cannot do anything against that. Okay, so let's show now the prosthesis. So this is the prosthesis I designed with Grace Medical. It's a really nice one. Simple one. You see 0.4 millimeter diameter Teflon shaft, just like the regular piston. And this is what I was talking about. You can see the head of a prosthesis, which is made in hydroxapatite, which is very well tolerated by the tympanic membrane. So we don't need to interpose a cartilage with HA compared to titanium. And you see the groove, which I designed in the center of this prosthesis to accommodate the malleus relocation technique. And the deepness of the groove, again, is 0.5. So if I measure 6, for example, you need to take into account the deepness, 0.5. So I need to cut it a little bit longer, 6.5 to adapt. Okay, we're going to cut it with a knife, so it's easy. You cut it like this. And that's it. We have a 6.5 millimeter long torp. All right. Should be a lot of blood again. Donnez-moi un 9 encore d'abord, parce que là, il faut que j'enlève un peu de sang. I will try to remove a little bit of blood to try to help the picture itself that you have, decreasing the darkness, if possible.
The good thing about using the vein graft into position is that it allows you to use this technique. Without a vein graft, this prosthesis would not be possible in this case.
Absolutely.
And that's
all right. So first, we need to introduce the prosthesis and guide the shaft within the fenestra like this. Okay, it goes down to the fenestra, so it goes well. Now I need to rotate the prosthesis in order to place the groove parallel to the malleus handle. So that the next step is like this. So you need to keep the prosthesis in position, vertical position, and then you place the groove parallel to the malleus. The malleus is there. Remove some blood, and then I will grab the malleus with my right hand, holding with the sucker the head of a prosthesis, and then pulling a little bit the malleus, and then introducing the malleus within the groove. Now it turns, not good, so I need to rotate more. This blood is really bad for me because I don't see anything. Allez, crochet s'il vous plaît encore. It's very small. You see the gap here is very, very small, very narrow. Now I think it's going to be fine. Now I need to push a little bit the prosthesis anteriorly, and the malleus will fall into the groove. There we go. Okay? Can you see the position of the malleus within the groove?
Yes.
Okay, fine. I cannot show you the round window sign. It's completely dark, but there's no doubt that the prosthesis is in good position here. You see, it's working fine, stable. I need to now reposition the tympanomeatal flap. See if the prosthesis stays in position when we do this. It's important because if you cut the prosthesis too long, when you do this, when you reposition the flap, you could see when you re-elevate it that the prosthesis goes posterior, which is not the case here. So that's a sign that the length of the prosthesis is good. And now everything is fine. It's going to be, I think, pretty stable. Okay, fine.
Yeah. Okay.
Just reposition the flap.
Yeah.
And put a Merocell at the end.
Yeah. And what liquid do you put in the ear canal?
I put a Merocell now.
Yeah. Okay. Show us.
Tu peux y aller. Tu peux y aller. Tu peux y aller. C'est fini.
Okay. But what lotion do you use now in the?
I use ciprofloxacin.
Okay.
Okay. Good.
Now show us how you use the curette on the speculum.
Okay. All right. Okay. I'll show you from the outside. Okay. Plein, s'il vous plaît.
You need to push the. Yeah. Otherwise you pull it out.
Yeah.
Yep.
No, I put it out, and I'll show you this. So curette. It's everything for all instrument like this. Let's say that the speculum is inside the speculum holder, so it's held by the speculum holder. You want to cut something there, so you put the curette where you want to cut, and then you go anterior, and then the fact that you use this anterior part of a speculum will give you the stability, the efficiency, and the resistance.
Yeah, and that's why your speculum is so fixed tightly, yeah, because you use it very much as.
Thank you. So I think you should go to Thibaut. He's waiting for you. So and we have time for discussion and questions a little bit more with me if you want. But now first go to Thibaut. Okay.
Thank you, Robert.
Thank you.
Just one point about the curette. It's a good idea to use the curette whenever you can when you're doing middle ear surgery, because it's important to use the curette wherever you can in middle ear surgery, because you need to develop your thenar muscles, your thumb muscles. Don't just start using the curette without the strength. Okay, Thibaut.
This is just another opinion, huh? But anyway. Thibaut, bonjour.
Hello, il faut remonter le retour.
Yeah, and your microphone needs to be a little bit louder too.
Do you hear me?
Yes.
Okay, so I briefly present you the case. Alors ça, il faut montrer la caméra. This is a revision surgery for cholesteatoma. Appuyé. A 50 years old man. I operated on this man 4 years ago for cholesteatoma, canal wall-up tympanoplasty with ossiculoplasty. And he has currently a right hearing loss and a chronic otorrhea. And at the otoscopy, there is a recurrent cholesteatoma by an erosion of the auditory canal. You can see his audiogram on the right side. Hearing is not so bad. And on the CT, a complete opacity of the middle ear and of the mastoid. On this side, you can see that the partial prosthesis, titanium partial prosthesis in right position, but there is no aeration of the middle ear. There is erosion of the tegmen there, and an erosion of the auditory canal. That is the cause of the recurrent cholesteatoma. And you can see on the MRI the confirmation of the cholesteatoma. On va passer au microscope. Donc, so I prepared the approach, aspiration 12. Voilà, pour être mousse. So, and you can see that here there is the erosion of the auditory canal and the cholesteatoma by penetration of skin into the auditory canal through the erosion of the canal. The tympanic membrane itself is good. There is, in fact, a stable reinforced tympanic membrane, and I elevated the middle ear. the inferior part of the middle ear is safe. The reinforced tympanic membrane is safe. I can see here the head of the titanium prosthesis, which is results or less involved into the cholesteatoma. So the idea is to remove the cholesteatoma, change the ossicular prosthesis, make a reconstruction of the auditory canal, and obliteration of the mastoid with
your sound has gone
bone
down.
substitute.
Thibaut, the sound has gone quiet.
Okay.
That's better.
Alors, plaster. So the external part of the mastoid, it is more cholesterol granuloma. Here we can see the cholesteatoma, and in the depths also. So I will continue to elevate it. I will not be able to remove the cholesteatoma just in one piece. I will have to decrease to debug the cholesteatoma. Up. Voilà. I try as possible to elevate the matrix from the bone without opening the cholesteatoma matrix, but I will not be able to do that for all the cholesteatoma. It's too large. So at this stage, I will remove the big part of the cholesteatoma in order to finish to remove it in the attic. Alors, vous allez me donner une aspiration 20 et la pince râteau. Voilà, la pince râteau. Okay. Alors, and now I can revise the mastoidectomy from posteriorly the posterior part to the attic to remove all the remnants. Alors, vous allez me donner la fraise, la deuxième fraise coupante. mental diamanté. Je vais voir une autre pièce à main parce qu'elle commence à déconner celle-là. De l'eau. De l'eau.
Thibaut, we have a question
Yes.
from the audience.
Hello,
Yes.
sir. I'm Dr. Israni from India. As this is a recurrence case, no? Hello?
Hello, yes.
You told that it is a recurrence, operated 5 years back. And why not to prefer canal wall down in this case?
Because I think that I can remove the cholestoma still in canal wall up, and it will be more favorable for this patient who live here on the seashore. Up the road. And this is why we decided to keep in canal wall up surgery. Hop.
Okay.
Vous la mettez un peu plus longue et la taille en dessous. En attendant, vous me donnez le grand Rosen.
Dr. Thibaut.
Yes?
This is Dr. Sanaroglu. Very nice work until now. Can I ask you a question? How often do you make MRI after these cases? I mean, what is your protocol? Because you know, cholesteatoma recurrence happens to all of us. I mean, no doubt about it. But it looked a little bit large.
The protocol is that patient will have CT scan and MRI examination at 1 year, 2 years, and 5 years after the surgery, and then 10 years after.
So was there any recurrence in this patient, even a small one after a year?
Please?
Was there any diffusion MRI restriction after 1 year? Because this is a little large cholesteatoma recurrence. So
yes.
Usually we see some MRI findings in a case like this a year after.
But this is why he will have MRI examination 1, 2, 5, and 10 years after the surgery.
I think the question, Thibaut, is why didn't something show at 1 year and 2 years?
Why, please?
Why didn't recurrence show at 1 year and 2 years?
He had
this is quite a large
in that case, he had MRI examination 2 years after surgery. There was no recurrence of cholesteatoma. And the cholesteatoma was discovered at the 4th year after surgery. Alors, vous allez me donner le Rosen moyen. I see this patient.
Thibaut.
Yes?
There's another, continue surgery, but there's another question from the audience.
Yes, Jan Willem Bok from the Netherlands. Why the CT scan as well in 1, 2, 5, and 10 years?
On the CT, there was lack of aeration of the middle ear. No evidence of petit crochet cholesteatoma on the CT, aspiration 12, and at the MRI at year 1 and 2, no recurrence of cholesteatoma.
Thibaut, we have another question from America, from
Yes.
Owen. Here he is.
Thibaut, good luck.
Yes.
Listen, how often do you do a two-stage procedure for these cholesteatomas? Well, when I train in Los Angeles, and those guys that do a two-stage procedure for a grain of rice-sized cholesteatoma.
I no more perform two-stage procedure because in adult patients in canal wall-up surgery with mastoid obliteration, the rate of residual plus recurrent cholesteatoma is 5%. That means there is 95% of chance to need no revision surgery. And this is why I never perform nowadays two-stage surgery.
Okay. Robert, there are some other questions as well, but in the meantime, I think there's coffee as well. So if anybody wants to grab a cup of coffee, Thibaut is going to be operating anyway. We're running late as usual, and at one point we'll switch on back to the program not to lose everything. There are more questions. Thibaut, good luck.
Yes?
Very interesting case. This is Abdurrahman from Saudi Arabia. I'm wondering if you use the facial nerve monitor in such a difficult case.
Please, could you speak a little bit louder?
Do you use the facial nerve monitor in this case?
No. I usually not use facial nerve monitor in cholesteatoma surgery. I use it in malformed ear, for instance, but usually not in cholesteatoma surgery. You will see tomorrow Frédéric Venaille, who uses systematically facial nerve monitor during cholesteatoma surgery, but myself, no. Alors, fraise. So I remove the large amount of the cholesteatoma. So now I have to harmonize, non, deux tailles plus petites, the shape of the artichotomy and to drill with a diamond burr all the mastoid and the artic to prevent, as possible, any residual.
Thibaut.
Yes?
I think there is a Tegman defect on the mastoid.
Yes.
I think it is very good to show the audience because there are, young people, because there is a soft tissue on the left part of the screen, and if we are not very careful,
This
there.
Yes.
Can you please show? This is very important because sometimes we think
Cluster.
it's the capsule of the cholesteatoma. This is dura, and it is very thick. It is evident on the pre-op tomography. So we have to be very careful not to damage this. So you see, so when you use the cutting burr, we have to be very careful. So this is a Tegman defect, and we have to be very careful not to make any dural tear. It will cause meningitis afterwards.
Yes, but sure, you have to take care with cutting burr. But in fact, because of the inflammation, there was a large amount of fibrous tissue between the dura itself and the cholesteatoma, and I separated with monopolar cautery.
Yeah.
And you can see it's very solid, in fact.
Yeah, we didn't see
the
that
risk
part.
of CSF leak is, in my opinion, quite weak, quite small. But sure, I take care during the drilling. I drilled with a diamond burr, just around, and after with the mastoid obliteration, so it will maintain the dura in the right position and prevent any meningocele or myelomeningocele.
Very important to notice this on pre-op tomography and during surgery.
Yes, yes, and it is very important to anticipate the things. That mean the pre-op analysis of the CT scan has to be very good. Stop. In principle, you should have no surprise during the surgery. If there is a surprise during the surgery, it is a failure in the pre-op assessment. Alors, vous allez me donner une fraise diamantée plus petite, une aspiration 20. So I have now to reopen this part to have a better exposure of the attic and to drill all with the diamond burr. De l'eau. De l'eau. De l'eau. And you will see that I will be able to have a good exposure of the attic. In order to polish all the bone with the diamond burr. You can see very far in the anterior attic, and you can see that the exposure is good. The exposure is the key point to avoid residual, and the reconstruction is the key point to prevent recurrent cholesteatoma. And so the first thing is to have a good exposure of all the middle ear and mastoid cavity. Here is the tympanic portion of the facial nerve. I gently drill there. Plus petite, petit rosen en attendant. Tympanosclerosis there. The fallopian canal is intact. The nerve is not naked. Fraise. De l'eau. And I drill there around the lateral semicircular canal. De l'eau. And in that case, if during the drilling I expose the dura, it's not very a big problem because there will be a mastoid obliteration, and so it's not a very big problem if there is body defects in the tegmen. Voilà, hop. C'est retransmis toujours dans la salle ou... Voilà. So now I want to have a look through the posterior tympanotomy. I will enlarge it a little. Petit rosen. Okay, the tympanic portion of the facial nerve is there. The lateral semicircular canal is there. And I will enlarge a little bit the posterior tympanotomy, starting from the fossa incudis. Alors, fraise plus petite. De l'eau. Hop. Le moteur chevrotte. C'est pas un moteur Chevrolet, c'est un moteur chevrotant. Ok. Petit rosen. And so now I think it's quite good on the mastoid side. And so I go to the middle ear, malade vers moi. Stop, plaster. So I can see here the reinforced tympanic membrane that I will keep because it's good. Now I will check the oval fossa. Malade un peu vers moi. Stop. Inspiration. Petit rosen. Malade vers moi un peu. Stop. So, and if I check the oval fossa, I can see that there is remnants of the stapes arch. There. Petit crochet. Okay, stapes arch is intact. And so I will use a partial prosthesis that I will put on the top of the stapes. Alors, il faut juste que je finisse de nettoyer. I just have to finish to clean there. Alors, vous allez me donner la fraise. Oui, mais ça, c'est parce que le moteur qui chevrotte, c'est un peu pénible. Hein. Rosen moyen. Alors. Here in the retrotympanum there was no cholesteatoma. So that's okay. And here, petit crochet. Non, micro-pince à l'instant. Boucher. Boucher. And so I can say that I will have a large reconstruction of the auditory canal to perform. And for that, I harvested conchal cartilage. Fraise. Bon. Rosen. So now I will start the reconstruction with conchal cartilage for the tympanic membrane, and after, malade en avant, perform the mastoid obliteration. Stop. Micro-ciseaux. Boucher. Plaster. Okay. Bon. Now I will check the size and the shape of the cartilage. Petit crochet. So I will use the cartilage to reconstruct the auditory canal wall. Up. Something like that. Oh. No, I will thin it. I will thin it and curve it by thinning the cartilage in a different way on both sides. I see that the size of the cartilage is large enough, pince mousse. Non, ça c'est là. And now I have to fit the shape of the cartilage to the auditory canal reconstruction. Now, to curve it, I have to thin it on the face that will be applied on the auditory canal wall. And I will do that progressively. Hop. Je suis centré là. see. On that side, the border is thin. I have to thin it on the other side and try after that to see the shape. Okay, let's see. Il faudrait regarder sur, il faut avoir des gabarits de prothèse partielle et regarder sur le compte rendu précédent la taille de la prothèse que j'avais utilisée. So let's see if I use the cartilage like that. It will be okay, but just okay. There is not a lot of margin for the size of the cartilage, but it will be okay. And the fact that it will be maintained by the mastoid obliteration will help a lot in order to prevent a displacement of the cartilage into the mastoid in post-op. I'll try it on the other side like that. Oh, both are good. Bon, donc ça c'est bon. Okay, for the cartilage now, pince mousse. I have to perform the mastoid obliteration. I use for that a French glass ionomer. Alors, malade un peu en avant. Top, which is called biology glass. It's very good product. I mix it. I use a granule ionomer. At the beginning of surgery, I mix it with blood in order to let the mix of blood and glass ionomer coagulate. And I put into some rifampicin to prevent infection as possible. Yes? Yeah?
Thibault, thank you for the nice surgical site. I have 3 questions.
Yes.
From the video, we have the impression that in the area around the semicircular canals, the mastoid cells contain some white particles like pearls. We cannot differentiate it. It looks as if the cholesteatoma has grown into remnant cells.
You can see in that area?
Where the red blood is, more behind.
There?
Left.
I will wash to look to that.
No.
There is some tympanosclerosis there.
Okay. The white is tympanosclerosis. So
yes, this one. This is tympanosclerosis.
Okay. Yeah, there are more in the depths. And second question is, what do you do with the granulation tissue and the dura? And has this some impact on the obliteration with ionomeric cement? Will you put something in between or put...
No, no, I will put the obliteration simply like in contact to this fibrous tissue as a dura. This glass ionomer is used in neurosurgery, and there is no problem if it is in contact with the dura. The first step is that
well, in our experience 30 years ago with the ionomeric cement, there were some problems. No, it's the mixture, and you have the prefabricated.
So the first step I have today to separate the middle ear from the attic in order to prevent migration of the glass ionomer into the middle
We will
ear.
continue here in 15 minutes.
Et vous allez me donner le glace bone. And I will start the obliteration from the attic. So you can see here the mix of glass ionomer and blood. It is quite coherent and more easy to use in that way. And so I will first go very anteriorly in the attic.
Are there any questions that you would like to ask Thibault?
And I have to ensure that I do not perform over obliteration. Alors, Flester. I want to have the obliteration just at the level of the attic wall.
Thibault, there's a question.
Yes? Boucher.
If you have to do revision surgery on Adrian from Dublin, if you have to go back in that ear in a few years' time, what does the glass looks like? Do you have to drill again, or does it just suction out of the mastoid?
It makes a mix of fibrous tissue and bone substitute. In fact, it do not ossify really. According to what says the manufacturer, in orthopedic surgery, for instance, there is ossification, real ossification of the bone substitute, but in the mastoid, it keeps a mix of fibrous tissue and bone substitute with no real ossification, and so it's very easy to remove.
Thibault, there's a question. What kind of imaging schedule will you do after this surgery?
I will do a CT and MRI.
At what interval?
Please?
At what interval?
I will do CT and MRI 1 year, 2 years, 5 years, and 10 years after surgery. Alors, qu'est-ce qui reste comme tissu mou?
No. Yes, of course. There's another question.
Hi, Thibault. Asher from New Zealand. Have you had any recurrence with the obliteration, and if it recurs, what does it look like?
I had some recurrence or residual with obliterated ear. It's not a problem. I remove all the obliteration in order to reach the eventual residual cholesteatoma. Non, je vais mettre d'autres glass bones. And at the end of surgery, I perform a new obliteration.
Thank you.
Allez-y. Voilà, encore un tout petit peu avec la grosse rugine. And now I have to take care, do not over-obliterate. It could lateralize the pinna. And now I will first, alors Plester, aspiration 12, check that there is no over-obliteration, then put a prosthesis, and then the cartilage to reconstruct the auditory canal wall. Alors la prothèse, c'était une combien que j'avais mis? 1,5. Malade vers moi. On va prendre un gabarit, hop, de 1,5, top. Alors, attendez, je vais prendre une aspiration de 10. So you can see the stapes head is there, a little bit eroded, but usable. And I will try with the dummy. Hop, voilà, petit crochet. Ou pointe-mousse plutôt pour que je ne risque pas de... It is a 1.5 millimeter dummy, and I think it will be a little bit short. So I will use a 2 millimeter dummy. This one, if I put back the tympanic membrane in the right position, I think it will be a little bit short. So I will use a 2 millimeter dummy to try. Hop, tenez. Ah. Vous mettez un demi-millimètre dans le conduit. Okay. And if I put back the tympanic membrane in the right position, I see that it is okay. So I will put a 2 millimeter middle partial prosthesis with a Dresden clip, 2 mm. And in that configuration, that means cholesteatoma surgery, canal wall-up tympanoplasty, intact stapes, and the partial prosthesis by Medel. The average post-op airborne gap is 12 decibel, and there is 85% of patients with less than 20 decibel airborne gap. I'm very happy with this result, with this prosthesis. Voilà. Okay, you can see here the prosthesis. It looks very similar to the Causse prosthesis. The difference is that the clip for the stapes arch is symmetrical. It is a difference with the Causse prosthesis. But in fact, the results are similar. So I will put the prosthesis on the stapes head and push gently to insert the prosthesis on the stapes head. And so it's in the right position. And now if I put back the tympanic membrane in the right position, the reinforced tympanic membrane, it will be okay. So I have to place the cartilage for reconstruction of the auditory canal. Fais attention au micro, Camille, s'il vous plaît.
Yeah. I'm going to start 5 minutes. Can you send everybody from the cafeteria here so that we start again? And then we start exactly at 11.
And you can see that I complete the reconstruction of the auditory canal with the cartilage, and the fact that there is body obliteration prevents the displacement of the cartilage into the mastoid postoperatively. Alors, je vais prendre une donnée sur le... Vous le donnez sur le espace. Then I have to cover the cartilage with pericardium that I harvested trempez-le. Et pointe-mousse. Okay, and I have just to maintain it with packing of the auditory canal. Donnez-moi la bande. Pointe-mousse. Le mérocel. Pointe-mousse. De l'eau. Voilà. And so now I will replace the auricle in right position, and when the auricle will be in right position, then I will finish the packing with a cylinder of silastic and full mérocel. And the packing of the auditory canal will be removed at day 10. Alors, pince-me. So I replace the skin in the right position, and I will close now the rétroauriculaire approach. Hop, et on va passer à la caméra. Il faut mettre mes lunettes, s'il vous plaît.
Thibaut, we're going to leave you in 4 minutes.
Yes.
But it was a full demonstration. Thank you very much. But they're still with you, of course, for the next 3 minutes. If there are any questions?
Yes?
No, I'm asking if they are. Everything seems clear. That's good.
Yeah, I hear you, yes?
That prosthesis is made by Causse, Thibaut?
No, it's by Medel.
Medel, okay, well. That's the same guy that went from Causse to Medel.
Yes.
Uwe Steiner.
I think for the partial prosthesis, Causse and Medel are equivalent. But for the total prosthesis, the Medel are better because they are a little bit stiffer than the Causse.
Here. There's another question, a very critical question.
Yes?
Here it comes.
Just one question. Are you not going to support? Hello, hi, I'm Samir from India.
Yes?
Just wanted to ask you whether you're going to keep anything between the prosthesis and the eardrum so that the prosthesis doesn't get extruded, like a piece of cartilage over it.
With this prosthesis in my hand, the rate of extrusion is 1%.
Okay, thank you.
Bon, ben, c'était pas si mal, on a pu bien retransmettre. Je me disais, ils vont tous aller prendre leur café et puis il n'y aura plus personne, mais non. And so I close the periosteal plan with overcast stitch in order to have a very tightened and waterproof or blood-proof suture. It separates completely the mastoid from the temporal plan. I had one time a child who had postoperatively an abscess in the temporal dissection plan, but there was no communication with the mastoid because of this tightened suture.
Okay, thank you very much, Thibaut. We have to go now.
Okay, bye-bye.
Thank you very much. Okay, well, it's a great pleasure to Wilco Grob stage. We've known each other for about 20 years. Wilco is the technological genius behind the Lion Network, which you may or may not have heard of. It's not transmitting at the moment, but certainly has transmitted to 99 countries around the world in the past, so pretty impressive, and kept going during COVID. He's going to blow out of the water everything I've said and be extremely rude, but I'm just going to show that the British are magnanimous by saying nice things about him.
That's a first, John. Thank you very much. My name is Wilco Groman. I work here in the clinic as well, and it's a pleasure to something about evidence-based medicine, because that's the only thing about evidence. And well, I'm not sure if it's very appropriate in a surgical course. It says 25 years, but it's the 26th year. I have the feeling that je crois le micro marche pas trop bien en fait. Il est coupé tout le temps. Well, je okay. No. Je prétends de précédent. D'accord. Okay, so this is what I'm going to discuss. I'm going to deviate a little bit from the presentation because I think it's a funny example of how things can go wrong. And obviously I have no financial things to declare because I'm a poor guy anyway. So a brief deviation from otology. We're all here for otology, so I won't make it very long, but I just want to discuss this because typical for this meeting, John will say, no, I'll tell you, you need to use cartilage. And someone else, no, it's perichondrium, that's for sure. So take everything with a grain of salt, and that's actually my goal to make. As long as you understand that there's no one way to skim a cat, then I'll be happy. So we need to sort the difference between myth and truth, because all the doctors here will claim to know the truth, but that's very questionable in my case as well. I'm not excluding myself from this at all. So you always need to look at whether there's a certain relevance of what people say. In my hands, I've done one. I mean, that's not a lot of relevance. Or the risk of bias, because you need to remember, if you do your consultation, whatever you see is, of course, your region and the people that come to you. So not always the data that we have is transportable to other clinics, because they may not be the same. Especially in India, I'm sure there's a huge bias and selection bias. And I just wanted to show this. can imagine, John gave this one to me, because John always has videos, etc. What I want to discuss with you, I mean, we do lots of, I've done quite a bit of research in the past, and many of us probably do, and we're always happy if you have a sample size of maybe 50 or maybe 100 patients, and we're proud to say, like, I've had a sample size of 100, and look, these are my results. I'm going to give you a very interesting research that was done in the early days, in 1938, I think, where for the American elections in 1936, I should say, they sampled almost 2.5 million patients or people to predict the American election outcomes. Well, that makes sense, because I mean, it's very important. It's going to be a Democrat or Republican, who knows? So what they did, they used phone books and car registrations, and they asked the people, hey, they called them up or they saw the car, what are you going to vote? And so they were able to compile a very reliable, predictable outcome. Because I mean, with a sample size of more than 2 million, that's huge, huge, huge. In healthcare, we hardly have anything similar. So in that investigation that they did, clearly Alf Langdon was going to win. Now, everybody here doesn't know Alf Langdon at all, so clearly he did not win. But according to this poll, he was going to win and going to beat the other opponent. And the other opponent we do know. And it's very interesting to see there was a high outcome, and of the constituents, 523 would have gone to the Alf Langdon, but in the end, it was eventually Roosevelt that won. So that's crazy. They sampled more than 2 million samples, and apparently they got it wrong. Why would that be? Well, the truth is they sampled, of course, all the phone books and telephone registration. But this was the reality in that period in America. In 1936, you could see the happy life with the dog leaning out of the window and a happy family in the car. But the truth is, of course, in that period, life was like this. People were standing in line for food. So if you sample only driver's license and phone numbers, you miss the people that are standing in line for food. And it's a very, very good example of a selection bias. And I like to point out all that we do, I'm sure we have selection bias. I'm not saying our selection bias is that big, but you need to realize selection bias is absolutely a serious issue in medical research. And some of you, and maybe all of you, know this pyramid. All what you see today, or all our opinions, and I'm not saying that our opinions are wrong, but you need to make sure that you value it at its right value. It's all expert opinion, and it can be true, but it can also not be true. So that's what you need to realize. Everybody who may be very convincing, saying, oh, in my hands, I'm sure so-and-so, that may be true, but it may not be applicable to all of us. So realize that we don't share any high-quality evidence. The question is anything in a surgical procedure like a stapedotomy that we can improve or that we can learn about? That's interesting, because Robert uses the vein graft. I use the vein graft now, but most of my life I never used the vein graft, and I never did endural. I always did endural, never did transcanal. So if you look at the procedure of stapedotomy, there are certain phases that you can see that are possibly important. Should you do it under local or general anesthesia, transcanal, endural? How would you do the bony rim resection with a curette or a drill or a chisel? I use a chisel a lot, Robert, the curette. And I know many people use frequently in a skeeter or so to open up the bony rim resection to get a good exposure of the stapes. And whether you should use a laser or a skeeter, etc., there are many opinions about that. So I've done research in the past, and I'm not saying that I'm the gold standard, not at all, but I did look at some research in the past for things that were intriguing to us. And I'm not going to discuss everything. I just only going to have to look at clipping prosthesis or the diameter of the prosthesis, if that makes any sense. And if you know the difference between clipping and non-clipping, on the green side you see that's a prosthesis typically that you would need to clip after you put it in place. And the other side is one of the examples of non-clipping prosthesis, but it's the nitinol. There are many other types that are non-clipping prosthesis. And potentially that could be a difference in the end result, because after all, with stapes surgery, we want to close the airborne gap. So, of course, the transmission of sound with the ossicles is quite important in that case. So, I did a prospective research at one time where I used the A-Wangen clip piston. Now there's a newer version, but I used the A-Wangen. and we used always also the titanium K piston. As you can see, in that period, I never used the vein graft. We always just made a smaller hole than a 0.7 or 0.8, and put the prosthesis in. Just a show of hands, who uses a vein graft now? One. Who doesn't use a vein graft? Is everybody awake? Okay, so the majority. So that's an interesting discussion. What we did, we looked at a clipping and non-clipping prosthesis. And what's interesting to see, and this is a prospective study, but relatively small samples, if you see, we could clearly find that if you had a non-clipping prosthesis where you did not close the loop, the airborne gap closure was better than compared to a clipping prosthesis, which surprised us. And you can see these two, depends on the frequencies. In Europe, we use the 4,000 hertz, in America, the 3,000 hertz. But you can see there was a significant difference in airborne gap closure. And that's interesting to know, because why would that be the case? Apparently, it makes a tighter fit. At the same time, when I used that prosthesis, I had patients that came back with noise of distortion, of scratching sounds. And there is something to say, and I'm not saying that that's the truth, but it may possibly be a explanation. With some of the non-clipping prosthesis, as you can see in A, the attachment to the incus can be maybe too tight. And what you see, if the incus angulation changes a bit, the prosthesis starts scratching to the foot plate. Even though the airborne gap closure was better with the Wenger prosthesis, there was still a certain percentage was unhappy because it gave extra noises. So that's something to take into consideration. There are multiple factors that you need to consider when you do stapes surgery, obviously. And then another discussion is, course, I mean, it's an old discussion. What diameter should you use? 0.4, 0.6? Some people do 0.8. And that's interesting. And the question is, does the diameter of the prosthesis matter if you use a vein graft? Because the vein graft by itself makes the surface bigger. So if you look at the literature, and this is the way I was trained, and I trained people in Utrecht to use it like this, either the Pico or this standard. Does anybody know the Pico standard for looking, searching internet for results? Mark Arts knows it, but anybody else? Okay. So Pico, I mean, if you go onto PubMed, you want to look for literature in a systematic way. Like Pico would be patient. What patients are you looking for? These are, of course, patients with otosclerosis. Intervention would be stapedidotomy or not. Compare the outcome and compare and then the outcome. What are you looking for? And for stapes, typically for maybe dead ears and airborne gap closure. So this is the typical way that we would do it. We would use the right keywords. We would use for otosclerosis and all the synonyms, and then prosthesis diameter, etc. And then you start with, if you look at PubMed, Embase, or Cochrane, you get all the articles out. By the time you crunch down, like, are there duplicates, read the abstracts to see if they're truly relevant. In the end, we ended up only with a very few articles in this case. And then when you get the articles that you find, we like to systematically appraise the articles according to over a fixed questionnaire. Because in the end, we want to know what is the amount of risk of bias of the results. If the risk of bias is very high, you need to be very skeptical of the results that they present. And this is the typical way that we do that. And here you see the better articles, but they're all relatively bad. They're all medium quality, I would say. And then if you look at the other articles, you need to be very cautious of the results or the conclusions that they draw. So in literature, it's very difficult to find a true support for the diameter of the prosthesis. However, if you do look in laboratory results, and we've done that in Canada with Manohar, we did research on that, and we did find that a slightly bigger prosthesis could increase the airborne gap closure, etc. This was actually published as well. You can see the two articles that we published this finding at. But to tell you honestly, in clinical settings, there's hardly any proof that is a high-level proof, I should say. And the same thing about lasers, because we've been talking about lasers all the time. We always say lasers are the best to have in stapes surgery. Today you don't see the laser because of currently we don't have any laser at our disposal. But anyway, this is a typical, this was live surgery. Like John said, I arranged technically from the technical point of view and as the line director, the live surgeries. And this was what happened during one live surgery. I hope you can see this. There are different ways of applying a laser. You can do a laser via the microscope. That would be typically a CO2. And the otherwise, it would be fiber delivered. And here you see a result of a person, live surgery this was, where he cut the incus while he was trying to do the perforation of the oval foot plate. Yeah, oh, I don't want to rub it in. And the same guy did surgery the year after, and exactly the same thing happened. So, I mean, questionable. So, what's your name? Okay. Anyway, good. Yeah, so it's interesting. And that's the risk maybe of doing live surgery. Maybe it puts pressure on people. So typically, the most used lasers currently for stapes would be a KTP laser, a CO2 laser, or diode. And diode is very popular at the moment because it's so relatively cheap, or economic, I should say. Thulium is a laser that's frequently used in gynecology. And the interesting thing about thulium, it's a laser that's in between CO2 and the other lasers. In theory, you would like to use a laser that's very well absorbed in liquid. Because the risk as soon as you make a perforation with the laser of the foot plate is that you shoot through the foot plate and you damage the endoneurium. And if you have a laser that's very, very well absorbed by water, it will produce heat, but it will not damage any tissue behind or under the foot plate. So from a theory, you would say the CO2 is the most ideal, but difficult to deliver, because CO2 doesn't allow bending normally. Thulium is in between, diode is there, and KTP is maybe even more dangerous, but KTP is very good, well adjustable. That's a big advantage. We also looked in research at the sound level production. And we do know that CO2 produces a little bit of an explosion in the ear. And if you looked at all the lasers, etc., and we could find absolutely statistical differences in sound production with lasers. And of course, the least favorable would be the microburr or the skeeter, the osteostap. They make relatively a lot of sound. And the KTP and the diode would be better regarding the sound production. But the question is how much of the sound production will cause high frequency central neural hearing loss. So we looked in literature to see if there's any proof of the difference of type of laser and the result in surgery. And this is exactly the same procedure that I explained to you. We would look in all the published literature, look according to the PICO procedure, and then remove the duplicates, screen the titles and the summaries, and then end up with just 2 articles. So if you really look in the literature, there's not much of better quality written about lasers than one would expect. And surprisingly enough, there are 2 articles. And one of the articles I was involved in with Robert, and the other was Marchesi from Italy, etc. And we found that, strangely enough, with certain lasers, we found a slightly better hearing result in the end. And CO2 is probably the best laser to use in staple surgery because it's safer. The big disadvantage of CO2 would be that you would need a hollow fiber, and those are relatively big and relatively expensive. And in private practice, etc., all of a sudden the price becomes an issue as well, because it's frequently paid by the surgeon. So I like to express, at least some of my friends, but I think Chris has not arrived yet. Well, he was here yesterday, but he's apparently not here yet. And I want to emphasize again, don't believe everything that you see.
These 2 guys who decided to pull off an illegal urban wingsuit stunt in Rio de Janeiro. As you can see, the men were Red Bull wingsuit daredevils. They actually successfully threaded the needle between 2 skyscrapers in Rio. One of the daredevils attempted to fly by one of Brazil's famous monuments. Fortunately for him, that was his final.
So, everything you hear today, at least be skeptical and be critical. John, you had a question.
No.
Any questions?
Who are you?
There is a laser which has been got and we are using it. It's called the True Blue Fiber laser. It has a combination. Any experience with that? It works well. It has a fiber, but I'm not so sure about its absorption, as you said, inside the neural fibers. So do you have any idea about it?
I think it's a part of the diode lasers. Diode lasers have different colors.
Yes.
And I think it's one of the types of diode, which are very, very affordable. I think less than 10,000 euros. I'm not sure how many rupiah. But it's they're fairly cheap to buy, but they're not ideal. And the thing is, I mean, my experience with diode, you need to brown or brown the tip first before you, because it's a touch laser. It's not a laser that you can use for. You need to officially touch the footplate or the superstructure. I don't see any issues with the superstructure, but you need to be very careful when you do the perforation. Yeah, that's for sure. But that's an expert opinion. Who knows? Anybody else? You have a microphone. Well, there you go.
Hey, I have about 20 years experience with CO2 laser, like every single stapedectomy I did. And those handheld, once they started the OmniGuide, that thing was revolutionized. It before we used indirect lasers, and it was wonderful. But to your point, that it's prohibitively expensive. The fiber sizes, you can get around that, and it's amazing. And then now switch to diode because of the expense and the availability of OmniGuide fibers. I use a diode on every case, and it's just not the same. It's not the same machine.
No.
It's helpful and it gets the job done, but it's not nearly as efficient or as effective. And
I'm sure we'll be discussing why a laser is advisable, say in revision surgery, etc. But it's absolutely true that the diode is a very thin fiber, the same as the KTP. Very practical, but it's the KTP is more expensive, but the diode is very economic to use. Yeah,
I find it unbelievably frustrating that we are compromised by not having our hospitals buy us a fibre that costs $100 or $200. If an orthopaedic surgeon drops a prosthesis on the floor or a vascular surgeon drops a graft on the floor, they just grab another. There's no argument.
No, but
and ENT seem to be prejudiced
because
against.
ENT is micro orthopedics.
Yeah, I agree.
Micro.
Yeah.
No, the thing is, I mean, it's not the same. You can't compare a total hip replacement or whatever with a stapedotomy or.
No, but they have kit that we struggle to get.
Yeah, because we're not in. I mean,
we don't make as much money.
Let's cry all together, guys. We're absolutely irrelevant to the field. Yeah. Yeah, exactly. That's what it is. It's companies. It's like the miracle that came to us with cochlear implants. That allowed us to do a lot of research, etc. Okay, we're next now. We should go to the block. You can see Robert.
Whether Robert's ready yet? Yes, he may be.
Okay, Robert, can you hear us?
Robert, can you hear us? Robert,
he can. He won't talk to us. Yeah. Okay. Robert.
Yes.
Yes. Good.
Finalement. Allez.
Finalement, hein? Yeah, encore une de.
Okay.
So I'm taking the vein at the moment.
Can you zoom in?
Yes, we'll do that in a second. I didn't find a very nice one, but I will deal with this anyway. Okay. Just before I start, I think Marilo explained to you, but now you can link to the website, to internet, not the website, by choosing conference. If you click to conference on the Wi-Fi, then you have to enter your name, first name, and your email, and that's it. You don't need to use any code or anything. So it's going to run. So please try and let me know if it works. The internet provider is connected with us, so they can deal with this. But it should work now.
It works.
Okay, fine.
At least for one.
All right.
Robert, I mean, I know it never happens to you.
I can't hear you, John.
I know it never happens to you, but when you take the vein, sometimes the clip comes off and the vein retracts and you got a hematoma. What do you do then?
They do a pressure bandage.
Yeah. You don't try and fish around for it.
No, I've had that happen.
Okay.
Robert hasn't.
It's never happened to Robert.
No, but to me it has.
Well, it happened to me too.
Oh,
But-
honesty, very good.
Of course.
Yeah.
I could say that the French surgeon never have any mistake, but or failures, but sometimes we have.
Well, if you have the bleeding, it's not a mistake, I'm sure. No, but the thing is, that's the little disadvantage of the monocreel that we use, because monocreel is very practical. You don't need to take the suture out, etc. But it's a little bit tougher to make the knot, I think. Like Etylon is much nicer to suture. But this is, in a practical sense, very practical. Yeah.
So I was supposed to use the laser for this case, but the company who is providing the laser didn't put on sterilization, so I cannot use it. And the second point is that they were bringing a handpiece which was very big. They couldn't even enter the speculum. So of course we're not going to use it.
Yeah.
Interesting.
Yeah.
Interesting. Anyway. Table en avant, s'il vous plaît.
Of course, normally, Robert, we've been advocating lasers for so many years.
Sure.
And but it also works if it's not available.
Yes. And I think it's good to show without laser, because I mean, it's quite expensive to have the laser. So some people could not make it, so I understand it.
Can you say hi to Celine?
Again, you like Celine very much.
Absolutely. Absolutely.
And now our anesthetist, she was very unhappy with the previous operation,
Okay.
although it was not her fault.
Yolanda.
But I'm sure it's
Can
going
you
to be
say hi
fine
to
now.
Yolanda as well? Yeah.
She's very good usually.
Always.
Always. Always.
Robert.
Yes.
Levent here. May I ask you a question now, or
Yeah.
get your opinion maybe? 10 years ago, I started to use cautery at the start of the operation to mark the incision line. And there is I learned this from the endoscopic people actually. And
Yeah.
this has a tremendous effect in the bleeding. I don't know if you use it or tried it. What is your opinion?
I know. I never tried that. That could be interesting. Yes.
Monopolar in the spray mode, spray one,
Okay.
very low dose. And
yeah.
I just marked the incision line with the cautery with a very thin needle. It helps decrease the blood bleeding a lot, and it's a suggestion. Yeah.
Very good tip.
Yeah, it's good. It could be a good idea. But to be honest, Levent, really the case we had before is very rare to have such a bleeding like this.
Yeah.
It's related to the position of the patient.
How
which
do
is
you,
really
how do you decide the size, Robert?
Well, you have to do it by experience, I would say.
Show us, because the thing is, I come from academia. For me, it would be almost impossible to get a glass plate with a hole. I mean, that by itself.
Yeah, but now it's finished. They don't make it anymore, unfortunately. So I don't know. This is a blade 15. So if you compare the size of a blade 15, this is about the same
about
size
same
as
size.
this. Yeah. Okay. Is that okay for you, John? Wilco?
Yeah, it's clear. Because if it's too big, the surgery becomes more difficult as well.
Yeah. Sure. All right.
Talking about,
Okay.
about lasers, patients
Tête en
always
déclin.
ask me, and I say, a good surgeon without a laser is capable of getting a better result than an occasional surgeon with a laser.
Sure.
And that normally stops them worrying.
Oh, for sure. A laser is only a tool.
Yeah.
That's it.
John's talking about his own experience.
Tête en déclive encore. Vous pouvez monter la table, s'il vous plaît. Montez la table.
Can we see the OR room for a moment? Show us the OR.
Encore. Ah, ok. Montez la caméra de champ, s'il vous plaît. Tête en déclive maintenant.
Okay, yeah. Because this is such an
Stop.
This is such an essential part of the whole surgery. If you don't
Encore, tête en
position-
déclive.
if you don't
Allez-y,
position
allez-y.
the patient correctly,
Encore,
you're struggling with the
allez-y.
whole procedure.
Allez-y. Ok, table vers moi un petit peu. So I try again to place a table vers moi. The patient now is a bit big, I would say. Stop. So
Do you see the angle on the feet, how slanted it is?
yes.
Yeah.
Yeah. Okay.
The other
Now
thing-
the position is not comfortable. You see, we have a quite a fat person, so my red arm will be far away from the speculum, so it's not. L'esprit marche pas là. It's not going to help very much. You see what I mean? This
Yeah.
is. I'm very high.
Yeah, mountain.
But again, this is life.
The other thing I would say is that the speculums used to be malleable.
Yes.
The ones that are made now aren't. And the malleable speculum would fill
Yeah,
the ear canal,
yeah.
produce pressure on the flap, which stop the
Yes.
bleeding. We
Yeah,
can't get
that-
them. We can't get them now.
But I think Levin has a very good idea. I think I would try and maybe next time I have this kind of thing. Yeah, but you need to do it before elevating the flap, of course.
Yeah, I think if I understand correctly, when you do the Rosen incision, just before that you should mark the line, and that's
Oh, yeah, yeah,
At least
yeah.
for the line itself should work well. Yeah.
Yeah. Okay. Aspiration, s'il vous plaît. So again, you notice that I'm going to try to find the right size of speculum here.
Do you never
enter-
consider doing the infiltration before you do the vein graft to give the adrenaline, epinephrine, a chance to?
Yeah, maybe.
It takes 5 to 10 minutes.
Yeah,
Yeah.
There's so much that's injected that it's all an hydro pressure that you create. Yeah. Because you fill up the skin. Yeah.
Maybe the British are taking more time to react. I don't know. Compared to the French.
Maybe.
Surely.
Probably.
Call me-
Okay.
call me Shirley.
Okay, so fixing now the speculum with the speculum holder. And it's quite a small one. On est à combien là de... We have a 5 millimeter diameter speculum only. So again, not an easy case, but I think it's good. Let's go. Live.
The patients are well selected.
Yeah. It's not, you know what, it's becoming more difficult now because we are very close to the summertime or the summer holidays, and many patients prefer not to be operated before holidays. So it's not so easy to determine.
It's better to be operated in the time of the boss. Yeah.
Yeah. The problem that I have, I think it's interesting to explain that. The problem is that I have, it's a small canal, but also I'm obliged to put the speculum quite far away from the tympanic membrane. You see the big distance.
Yeah.
So I prefer to have a lower distance. But anyway, I don't have any choice at the moment. So this is, again, 12 o'clock, 3 o'clock, 6 and 9. All right, so we're going to start now with the incision. I didn't say that, but if you look to the distal tip of this round knife, the distal tip is bent, which allows me to go to the inferior and superior angle, which is pretty good. So I make this incision again, and now I'm going to elevate the flap again with the smooth elevator, and again the position, as I explained, of the sucker posterior to the elevator. And I try to follow, I'm not going straight forward in the middle like this, for example. I just follow horizontal line to stay on the same line until I reach the annulus. And because it's a narrow canal, you see it's not easy to move this elevator inside the ear canal. So I need to turn and trick like this. And now I'm going to use a smaller one, I think, because it's too difficult to use it now. Je vais prendre peut-être un lancéolé direct. So you see the way I'm moving, I keep it in one position like this. I stay like this, and then I turn a little bit, rotating the instrument. Okay, donnez-moi direct, s'il vous plaît. So I need to use a smaller one. Okay. So I want to see the annulus, of course. And I'm close now to the annulus. You can see the annulus now. I'm going to show you this and how to enter the medially cleft. So let me show you this. Okay, let me try to increase the light maybe. Is the light okay for you, or?
Yeah, it's fine. Really good image.
Okay, all right. So there we go. We have, I saw the annulus here. Let me focus on that. Well, the annulus is there. Je vais prendre un 9 là pour l'instant parce que this is the annulus. This is the annulus here. Then you have the mucosa here. So I will enter the mucosa. I will enter the medially cleft. And I will use a smaller suction. So it's bleeding again this case. We don't have a good good luck.
Normally you have 2 erythrocytes, and now you have a lot.
Yes. So there we go. So I'm open up the middle ear cleft like this, pleuron, entering now the middle ear cleft. We can see the distal tip of the incus and a little bit of the stapes, a little bit, which is of course not good enough. So now I need to do the bony membrane section. S'il vous plaît? So we can see here the promontory here and the long process of the incus and the stapes head. I don't see the chorda tympani, which is a problem here. Of course, we need to try to preserve the chorda. And but you know, the chorda tympani is always a problem. You try to preserve it, and you never know what happened. Even if you even if you preserve it completely, you don't even touch it, and the patient will complain. And sometimes you cut it, you overstretch it, and they don't complain. So my advice is that you never have to ask the patient if he has any taste disturbance post-op, because if he has one, he will tell you. Otherwise, you say, do you have any taste disturbance? Even if it's okay, they say, doctor, yes, I didn't think about it. But now, as you asked me the question, there's some taste disturbance, and then comes the problem. So,
but I think it's absolutely essential that in your preoperative letter, you put taste disturbance as a complication.
Can s'il vous plaît?
Depends who's the surgeon, John.
I just, maybe you can ask Levent in Turkey, how do you say to the patient before for all these things, complication? How do you have a paper, or how do you make it?
Good question. So informed consent is very important, as we all know. First, I talk about the hearing, and I always tell them once in every 200 or 300 patients, we can have a hearing loss. And 10% of the time, we may have no change or maybe a little bit loss. But 90% of the time, we have good outcome. Taste disturbance, I always mention pre-op, but usually I tell them the patients, even if after 6 months, even if we cut the chorda, they may not notice the difference after 6 months. And facial nerve, I always tell them. So I have a screen in my office, and I show them the otosclerotic focus, normal and otosclerotic focus, and also the position of the facial nerve, so that they are informed about the procedure, and there is nothing else. And very rarely facial nerve palsy can happen. Never happened to me, but these are all the things. And also 1% tinnitus. I remember 1 or 2 patients, one patient actually, is severely disturbed by the tinnitus, even though there is good outcome, but there is high frequency loss, and that caused tinnitus, and she's very upset. So I think it is better to inform these before the surgery. There will be some dizziness and vertigo after the surgery, but usually it goes away within a week or 10 days. Now I use a small foot plate penetration, and this is much less than before. But these are all the things that I mentioned. Anything else you would add,
No,
Robert?
I agree with that. I totally agree.
I think
I
think by law we need to present also the alternative of the treatment.
Yeah.
That-
Can I ask
Exactly.
what they do in Saudi also? Can you tell me what you do in Saudi? It's interesting to show to
So
turn
the
around
use
the
of
world.
hearing aid option is also very important, and we have
sure, you have to,
mention this as well.
I would like to know what they do in Saudi. I think it's interesting to see.
So, yeah, basically we have to explain. First of all, in Saudi, we don't have as much as frequent here in Europe.
Yeah.
But in general, we do have cases. We explain definitely the 3 options for them. Personally, I explain to them only 2 complications, and that is the 2 serious complications, hearing loss and facial palsy, in a rate of 1%. But in the informed consent, I write everything from bleeding to infection to chorda tympani to And I think there is a medico-legal issue.
Sure, sure.
You have to write it down, but to explain to the patient only the serious. But anyway, yeah, we have this.
Enough super. Yeah. Okay. Fine. And in India, Minesh, can you tell me?
Well, in India, it's more or less same of everything what they said, but then we thought that with the taste or the stretching of the chora tympani, I've realized the female patients complain much more. I don't know the reason, but I've realized they are so particular about it, so they complain. Well,
maybe we should remove that from the live.
And the males, I think they're used, they're having a tasteless life. I don't know, but they complain much more. And yes, we do inform them and give them the option of the hearing aid always, as an option. And most importantly, as he said, we don't highlight each and every complication, because if you tell the patient about each and every complication, he might never come back to you again.
Robert, can you show us the promontory lesion as well?
Sorry?
Okay, well, I mean, you're working away. I think not everybody's used to seeing you do the surgeries. So I think, but I think I see some white on the promontory. Can you?
Yeah, I can explain what I've done. As you could see, I finished the bone resection because I have my two landmarks now. We have the facial nerve on the left and the pyramidal process. So this is the facial nerve, the fallopian canal, and the pyramidal process of the stapes tendon. These are the two landmarks for me. Now, there was also a lot of fibrous tissue like this one, so I prefer to dissect this fibrous tissue before checking everything. And then the next step will be to separate the incus from the stapes. You see a little bit of a foot plate down there, but I don't see a lot at the moment. So we, anyway, check the ossicular chain first, then remove the stapes arch, and then we have a better gap, okay? So
Robert,
first now, yes.
Also, you know, when we talk about the complications, the tone of the surgeon who is talking is very important. Sometimes, you know, if we talk, we can make the patient go away. But if we talk, we can explain all the complications and the patient accepts very happily. So I think we should not frighten the patient, but be honest, and that is very important.
But in France, we have to ask the patient to sign. I give a full paper with it's a brochure explaining the technique, explaining all the complications, the possible complication, and things like that, the average result that I have, etc. And then they have to sign the paper saying that they understood exactly what has been presented to them, and it's a medical legal issue. If you don't have this paper signed by the patient, then it could be a problem. It could also be a problem even if they signed the paper, because they could say that they didn't understand exactly, and so on and so on. But I think here we are obliged to ask the patient to sign.
I think we'll let you carry on now, Robert, because you're getting to the difficult bit, and maybe ask some questions afterwards.
Okay.
Can I just ask one question? How much of the exposure of the incus do you really stop at when it?
Well, that's enough. You know, the incus is okay. You need to have that access, because this is the place where I'm going to place the loop of the piston. So that's enough for me. Okay? Now, I'm going to separate the incus from the stapes. As you notice, I always separate the joint first. So I use the sucker, 0.9 here. Am I hiding the view, or is it okay for you?
No, it's fine. Show them how you find the joint.
I'm just trying to...
Can you first lift the incus to show the
joint?
Okay, the joint is there, but I can do it like this, and you see the movement of the joint, okay?
Because it's synovial, it sucks in.
And then I will go into the joint, but I like to place the sucker on top of the incus to stabilize a little bit the incus while I'm doing this. Because what I don't want to do is to, of course, dislocate both incus or stapes. So you need to help yourself with the second hand. That's it. And now I can check the mobility of first malleus incus. So I will move the malleus, and you see it's fine.
Robert,
yes?
Robert, it's Marie Daval, Paris, France, Word, Universe. Can you tell me, do you perform systematically a CT scan before surgery?
Yes, yeah, we have to. As you know, now it's...
in France, it's mandatory, but is it the same worldwide?
We've been forced into it by the lawyers.
By the French, by the French.
Even in India, we have started now the CT as mandatory. Most of the centers. There are some personal variation, but in general, we prefer to have CT or con beam CT.
I think it is
What do
important
you
now
wait
because
for this CT? Is it only for the diagnosis or is it for something else?
More
for
than the
myself,
diagnosis, to exclude surprises, to
yeah.
exclude the facial, low-lying facial, decent facial, and also to exclude other causes of conduct hearing loss which may cause some other difficulties, like
Yeah,
the
the
superior canal
descent.
descent syndrome.
Yeah, sure, that's the main point.
Okay. And
Yeah.
also sometimes the very wide cochlear aqueduct, you can expect a gusher. So better to have an imaging to avoid surprises during the surgery.
Nice to have cone beam if it's available.
Okay, shall I
There,
continue? Now I've separated the
DCCT
joint
have
and I'm checking the mobility now.
important for the
Yeah,
younger,
absolutely.
younger practitioner to understand that the CT scan is not important to have the diagnosis.
Yeah.
Of course, you will have
No,
it
it is.
before surgery. When you see your patient, you ask questions and you have the audiogram and the Stapenian reflex. Do you check the visually, Robert, during surgery if you see the focus at the anterior part of the?
Yeah, I can check it, but you know, at the moment I cannot because it's hidden by the fact that it's pretty narrow and the superstructure is also hiding the view. So I don't see anything, but I check the fixation. You see, if I move from the top of the head, you saw the mobility of malleus incus. Now I'm checking the stapes, and the stapes is completely fixed. And I check it from the top of the head, and not like this, but this way. Okay? So I know it's fixed. So now I need to remove the superstructure anyway, and then I will check the full plate, and I see probably autosclerotic focus. But the CT scan show it, so which is not always the case. Now I'm going to cut the tendon. All right, and I'm going to drill out the superstructures, starting with the posterior crus. And I'm using that's the time where if we have the laser, I start with vaporizing the stapes superstructure, and then followed by the drilling out procedure. Same for the full plate, by the way. So again, I stabilize the incus and the stapes by putting the sucker on top of the incus, and then I'm using the micro drill with a 0.7 millimeter diameter diamond dust burr, leaving the burr doing the job by itself without any pressure, of course, because again, you can dislocate or fracture the full plate by doing this, so I think it is important to do it very gently.
Robert, this isn't the BNR, is it? Or the...
It's a BNR.
It's
yeah.
Osteostab, yeah.
Yeah, I used the skeeter drill in the past, but this is much better than the skeeter drill. But it's a little bit, where the weight is not the same. Of course, the previous one was very nice in terms of weight, but now it was much more fragile. Now, we need to reach the anterior crus, and that is the problem here, of course. The laser would be a great tool, because then you can, with the fiber optic, you can bend the fiber optic. You cannot do that, of course, with the burr. So you need to try to reach the anterior crus as much as you can. Start drilling out now, and I try to reach the anterior crus. But of course, this is tricky because I don't see it, and now it's done. So I can remove the stapes arch.
And Robert, you always drill from the facial nerve to the promontory?
Yeah. Okay, now we can remove the stapes arch, and now we have access to the full plate. And we don't really see the dot, the white dot, maybe a little bit around the annulus, but the annular ligament, but it's, you can see, I can see, I can show this. I think I hope you can see that.
And the promontory, is that not autosclerosis?
No, but you can see several dots of autosclerosis all around here. It's a little bit white. I don't know if you can see it. More anterior than posterior. Okay, I'm not sure you can see it, but I can see the involvement of the anterior part of a foot plate. Let me see if I can increase the light, maybe, I don't know. Enough, s'il vous plaît. I try to show you this, but it's not easy there. Okay, anyway. Right. Second point, le neuf encore. You need to check. It's interesting. I'm sure Levent will agree. If you do congenital malformation, and neuf encore, respiration, when you remove the superstructure, you need to check the full plate. I'm talking about mainly in congenital, because sometimes there is malformation of the stapes arch, which is fixed to the promontory, for example, and once you remove the superstructure, you find a mobile full plate. So I would advise that you do the same here, and you see if I try to move it, it's fixed. I'm sure you agree, Levent? Okay, so now I'm going to drill out the foot plate. We'll try to increase the magnification. That's I think it's the highest one. Okay, is that okay for you?
Yes, very good.
Okay. Allez, la fraise encore, s'il vous plaît, avec un... Non, non, non. Ah oui.
This was a 5.5, wasn't it? The speculum?
Yes, 5, only 5. So I'm measuring now. I forgot to measure, I must say, and then Céline told me when I was asking for the burr, she said, no, you need to measure. So she's there. Now I measured the distance, the second notch in front of the incus, which means 4 millimeter.
But if it was a thick foot plate where you had to do a lot of drilling, you would measure again to the perilymph.
At the end, yeah, but not in this case.
Dr. Robert, you prefer to drill the inferior central 2/3 or the posterior 1/3?
Posterior if you can, but at least maximum in the middle if possible, okay? So I'm going to do it now. I need to drill out the foot plate. I like to start the drilling out procedure first close to the foot plate. As soon as I approach the foot plate, then you can feel it. You can feel the resistance and then perform the fenestra. And I just, again, leave the diamond dust doing the job by itself. And you can see now the fluid coming out, so it's fine. I'm increasing the size, and I think it's done. C'est un 7, hein? And now I'm using a 0.7 millimeter diamond dust burr. You can see some residual perilymphatic membrane. And I'm not going to remove anything from that, but now the stapitotomy is done.
Nice.
Okay, and now I'm going to pick up the vein and put it over the fenestra.
Robert?
So my advice is that you need to start, I think you need,
Robert,
it's better to wait.
Would you do exactly the same if the facial nerve was not covered by bone?
Yeah, I would do the same, but if it's decent and coming very close to the superstructure, then you need to drill out the promontory. You know the technique of drilling out the promontory to increase the size. And using a different prosthesis. I use a bucket handle prosthesis, which is now made only in titanium, which is not as good as Teflon for me, but there's no choice. But I would do the same, yes. But first I will start by drilling out the promontory to increase progressively the gap, the distance between the promontory and the facial nerve.
Robert?
Yes?
Vico has decided that Mary is the boss and she allowed me to ask a question.
Yes, because I'm very nice.
We saw the nice drilling, which is excellent performed, but when you have had your first step, there was a small and thin layer of bone in the hole.
Yes.
And then you continued drilling.
Yeah.
How can you ensure or do you fear that the bone particles dive down into the vestibule?
Yeah, that's true. But since now so many years in which it happened to me to see that kind of thing, which is a mixture of bone and perilymphatic membrane, I didn't have any problem by doing this, which means that it's so thin that even if some part goes
Can you center the image,
oh,
Robert?
sorry. Yes.
Thank you.
Okay, so now I'm entering the vein. Difficult to use both hands at the same time. It's so narrow. So I'm introducing it with the circle, as I explained before, trying to stretch the vein progressively like this. And now you need to spend some time, if you use vein graft deposition only, of course, you need to spend some time to be sure that you're going to stretch it perfectly. Otherwise, if you put it like this without anything, it's not good. And now you see the position is fine. And what we are facing, I remind you, we are facing the intima of the vein. Okay, the other side, which is the sticky side, the lateral side of the vein, is towards the foot plate, so sticking to the foot plate. And this is a large vein graft. Interestingly, if you have a decent facial nerve, it will cover also the decent. I believe it doesn't make any problem if the Teflon is touching the facial nerve, but if you can do it, it's always better. All right, now I'm going to cut the prosthesis at 4 millimeter. It's a pretty thick incus also, I think. My feeling is that it's a pretty thick incus. Now I need to cut the prosthesis. I put it on a cutting block like this. I think it's too wet. The light is too much. So I
Robert, I said in my lecture, but why have you selected a bucket handle?
Oh, in this case?
Yes.
No, I don't need a bucket handle. There is enough gap.
Oh, right. Okay.
There's enough
Okay.
gap. I use the bucket handle only if there is no gap with short incus or decent facial nerve. So I'm holding the shaft. I'll show you how the way I do. I'm holding the shaft with my left hand and breaking the memory of the loop. You remind you that the Teflon has a memory, so you have to break it. That's it. And when you break it, don't try to, or you do it gently because you don't want to, of course, dislocate the loop and make it in the wrong way. Okay, now I'm going to enter the prosthesis with the sucker. And again, if you look what I'm doing, I'm using the sucker as a real instrument. It's not just for sucking, but I use it to introduce the prosthesis, TORP, and Teflon. The same with the other types of PORPs and TORPs that I could use in terms of ossicular reconstruction. And this is due to this negative pressure system. So I'm introducing it with the circle like this. So we need to guide the shaft going into the loop, to the stapedotomy, and then the loop around the incus. And that's it.
Perfect.
And now
really,
I
really
need
nice.
to close it. I need to close it. I need to close. The trick is, donnez-moi la queue forceps là. If you use a regular curve forceps, I think it's a very nice situation here, which could be interesting to discuss. If you use a curve forceps in this case, I mean, it's big. The curve forceps is big. And as Saji would say, when I say big, it's big. You don't have a great gap here, so it's quite tricky to use it. So the trick of the two hooks in this case would suit very well, because then you can use one hook, like this, and it's very thin to stabilize the loop to avoid any risk of protrusion. And then the other one is used to crimp the loop like this. So of course, it's a difficult technique, but you have to train yourself on temple bone. And once you have it, I think it saves a lot of situations.
But be honest, you love difficult technique.
Yeah, no, it is, sure. But it comes with experience, like everything. And I think after that, you can use it nicely. What I like finally to use is to check the bending sign. You see the distal tip of the shaft. The piston should bend but not move. And you see the bending. And now the
So
mobility.
can you tell us again what size was the hole you performed with the
Oh,
drill?
yeah, the stapedotomy fenestra is 0.8 millimeter diameter.
And the diameter of the piston?
Yes, and you use 0.4 millimeter of a Teflon shaft plus the vein, which is if you don't use interposition, I guess you use 0.6 millimeter in this case. Yeah, that's what you do, right, Marie?
Yeah.
I think. Yeah, 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 yeah.
And if you have the time, can you film the crimp, the tool you use to crimp the?
Yes.
Because I think not everyone has the correct
I explained that.
instrument in the operating room.
Yeah. Okay, I show you this. I put the Mercel and I show this instrument. I think it's interesting point. Yes.
Professor Robert, do you sometimes feel? Have you ever felt that a point, the 4 mm diameter of the piston which you use, it's not so strong enough to sit on the vein graft, or it works fine? Do you need a thicker one sometimes?
No, I never had a problem with that. No, it's strong enough. I think it's a. The piston we make in France are strong. Ménèche. You know what I mean?
Yes, I know.
Okay.
And Robert, you don't use silicone sheets at the end of the dressing before
Not
putting?
not in this case. But when I do tympanoplasty with TM grafting, I use it very often. And sometimes I put it
You
in.
don't have any problem when you remove the.
Yeah, I know what you mean. Yes, it's true. It's true that sometimes it's a little bit painful for the patient. That is right. And maybe I should do it. It's a point. It's a point.
Even
It's
if you
important.
put the silicone sheet sometimes.
Yeah,
it's
no, but
very
you're right.
painful and it
You're
can
right.
bleed.
I think it will be good to do that. So I show you the instrument, les deux crochets, s'il vous plaît. So we call that a Schucknesch hook. So we have those. This one first. Is it okay? Do you want me to zoom in or?
No, clear.
Is it okay?
No, it's okay. It's okay.
Okay, the first one and the second one. So if you look, they are the same, but they need to be opposite like this. Okay? To close the loop.
And can you show the clamp?
Yes, le queue forceps. Elle est où? And you see the difference is pretty big compared to the two hooks.
Yeah.
Donnez-moi un crochet. I can show you both together, and you see big difference, of course. So I mean, it's a good tool, but sometimes you don't have gap between malleus and
Can you show the whole instrument?
The what? Yes,
Oh,
sure. Yeah, this is
because it's bent, and
yeah.
we didn't saw that. Yeah.
Yeah. These are the instruments. I mean, yeah. C'est vous qui montrez là ou okay. So these
No,
are
to
the
zoom
instruments.
in. Can you
Yes.
zoom out?
Yes. I think it's okay. Let me see what I can do with that. Yes, that's better. Is that okay?
No, it's not.
Okay.
It's too much.
Okay.
It's to zoom in, zoom out. Oh,
Yeah,
it's
I try,
better.
but
Oh,
I need to go.
Another point of view. It's fantastic.
Then I need to go away. this is the best I can do. So maybe
Okay.
is that okay? Because let me see. I need to put some lights.
No, we
So
just wanted to see that the instrument was the hook and
Yeah.
the way it was bended.
This is the two.
Yeah.
Donnez-moi le celle pour
Exactly.
le marteau là.
That's right.
This is a very interesting one. Pour le marteau, we have two needles like this. The straight one, the regular one when I open up the middle ear cleft, and you see I call the bent one, okay?
Okay.
Which is more bent for the malleus handle when I do the malleus relocation. All right? Now you have this joint knife, okay? No, this is the hook, sorry. Il est où le pour le joint, pour séparer? Céline knows everything. Without her, I'm lost. This is the joint knife. You see, slightly bent and very thin and nice
No,
joint
it was
knife.
better with the previous view. Can you change the camera? Yeah.
This one?
Yes. We can see the tip of the instrument. Like
Yeah,
that,
yeah,
okay?
that's what I mean. Yeah. Okay. Then I use aussi, we did le crochet fort là. I didn't have time to explain, but in this case, the chord tympani was inside a canal, and to open up the canal, I like to use this one. It's a strong hook and short hook, so you go into the canal and you open it, and then you elevate the chord up more easily. Le round knife, le premier que je.
Do you have specific instrument for otosclerosis and specific instrument for tympanoplasty or cholesteatoma, or is it exactly the same for you?
For me, when I do tympanoplasty, it's the same. I use the same. But for cholesteatoma,
So
it's
the
more.
same box.
It's not. Yeah, it's a bit different, I think. With Thibaut will tell you this. But for me, ossiculoplasty, regular tympanoplasty without cholesteatoma, and stapes surgery, and congenital malformation, I use the same. And you see this one also bent at the distal tip. It's a round knife, the one I use at the beginning. And then I
And is
also
it
use.
sharp?
Yes,
Yeah,
yes, yes, it's sharp.
But
Yeah.
the other side is.
Because if this is the elevator, which is not sharp, and you don't cut with this, okay?
Okay.
And then I think that c'est tout, no?
Robert, who is the manufacturer of the hook?
Oh, the same. Same is made by. I think it's made by. What's the name? Integra. You know, originally all these instruments, that was coming from Microfrance, okay, like this. But Microfrance was bought by Integra, so now Integra is making them. And there is a box called Causse stapes surgery box, and all of them are inside. So you can buy a set, I think, and everything is there with a reference, and so it's very. They are very strong, and especially with this curette.
If you
know,
buy it
it's
during the
very
course, you get 10% off.
Yes, yeah, and the 10% comes to me, of course.
Yeah, then we are happy.
All right.
I was
Is that okay?
asking because the hook is a completely different design from the hooks we use in tympanoplasty, and this is an important detail if you want to remove bone from the foot plate area. So that
Yes.
The
Yeah.
shape of the hook in the detail makes a difference.
Yeah, you notice that the way I was using it to clean the over window
And
to remove
can
all
we
these
have a
fibrous tissue.
panoramic view, because we only see the tools? That's very interesting. But now we want to see Céline.
Allez-y, mettez.
That's
On
what
revient en arrière.
that's what Vilko is asking me.
You want to see Céline again?
Yes, of course. Everyone wants to see
Céline, you are the star.
Yeah.
C'est encore vous qui veulent voir. Eh, c'est comme ça.
She seems so happy.
You know what? Minesh knows that when I'm invited to go to India to do life surgery, and Minesh saw Céline, and he said to me, "You should invite Céline to come." So I said, "That would be great." So she said, yes, I would love to come, and then finally it was not possible to do it. So unfortunately she couldn't join. But she's very,
Well,
I mean,
that,
she's
that
very
was
efficient.
because I think you told me her husband said no because you were coming.
Yes, I didn't want to say that, but it's true. Yes, and by the way, the point is that she's extremely good because whatever I changed in my technique when I was introducing the malleus relocation, then the elastic bending, the malleus replacement processes, etc., etc. She's able to follow the change and immediately get up the change, and the next operation she knows everything, and then you don't have to ask. I don't understand if you realize, but I didn't have really to ask the instrument. She knows exactly point by point what I need, and if I change it, she knows that I'm changing.
course,
So,
we
I mean,
understand.
it's great to have someone like that. But she's younger than me, so that's good because I will probably stop before her.
And Robert, when will you remove the dressing?
Now. Why?
The dressing. When will you remove it? The
Oh,
lamèche,
sorry.
le pansement.
On the 5th day. And by the way, it's interesting. It's again. I know there's a lot of people who are not happy with the fact that I'm picking I'm keeping my patient for 5 days, which is unusual.
In
Everybody does
hospitalization,
that.
you
Yeah.
mean? They stay
Yeah.
in hospital for 5 days.
Yes.
Okay.
Yeah.
And why do you do that?
Well, because I want to follow them. Many of them are coming far away. So I just want to be sure that the bone conduction will be fine. So I remove the plug on the 5th day, and I do a hearing test before they leave. And if everything happens, if I'm not happy with the bone conduction, if there is any clinical problem like some dizziness or any other thing like this, I can keep them a few days more to treat it if necessary. And I think I'm pretty sure, but of course this is a personal view, I'm pretty sure this helps the patient to get better. I think the first time you tell them, they are surprised by that, but then they are happy to stay for a few days and then and then be quiet and then having the removal of the metal cell. But this is a discussion with the director of the clinic, of course, because financially for the clinic,
It's not very
not
interesting.
better.
Yeah.
But this is the point. I mean, this is the point. I think it's something that I like to have because it's just it's a luxury. I understand that. Of course, it's a luxury, but I think it is important. And for me, it's good.
You don't have the system we have sometimes in Paris. We have hostel that can where you can let your patient go, and if there is any problem, they can come back.
Yes, that's right. There's a hostel inside the clinic that could be used also. But I mean, it's when I came here, I learned that from Jean-Bernard Causse and Jean-René Causse, the family, and I was continuing what was doing before. But both could be, the second thing could be an option also,
And so before leaving the hospital, they have a hearing test with only a bone conduction or also a hair conduction?
No,
test?
I do the bone conduction only because it doesn't mean anything. Sometimes they have blood, and I don't want to, and I explain that, and then, and it's interesting. In fact, the fact that I keep my patient 5 days, except the reason why I was explaining, I can follow them clinically every day, day after day, so I can see if they are having any dizziness.
We cannot hear you anymore because you're removing your microphone.
Sorry. Okay, I take it like this. Yes, I keep them 5 days. I follow them day by day, and I can react. And I can know if they have any clinical problem like dizziness or thing like that. And definitely, I tell you what's exactly happening. It's extremely rare that the patient complains for any even small dizziness. Of course, I have complications. For sure. I've dead years like every surgeon. But I'm talking about the general overview of the post-operative time. And it's extremely rare that they complain about some even kind of small dizziness. And I think it's related to, not to me, but to the technique itself. I really believe that the vein graft protects the inner ear and probably makes the immediate post-op more calm than the non-interposition. But this is my feeling.
Before this kind of surgery, we performed a platinectomy, and at that time we had a lot of vertigo.
Sure.
I'm pretty sure that the interposition, it's why you don't have any vertigo.
Yeah, that's right.
Okay. Robert, I have access to a couple of websites where patients give feedback, and the feedback of the stay here is fantastic because the nurses understand what's been done. but I hear lots of stories of patients who say, I hear lots of stories of patients from other units who say, I only had a 5-hour car drive on the day of surgery.
Yeah.
I went in at 8 in the morning, was discharged at 2, and they have a terrible time. And the other vital thing for anybody in this audience is you must have a mechanism for your patient to contact you. If you want an unhappy patient, don't give them a mechanism to contact you. Because you hear stories of I tried to contact the hospital, I couldn't get through to the surgeon, and they get in a terrible state. You'll make yourself much more popular if you have an algorithm for them contacting you, or at least your team.
Yeah. Levent, you wanted to say something?
Robert, first of all, congratulations. That was an excellent surgery.
Thank you.
You know, just like you, I use Batikon to clean the ear at the beginning, but I try to remove it completely because at the end of the surgery, you know what? I'm afraid, you know, we made a cut and the inner ear is open. So any Batikon may diffuse through the incision, may go into the inner ear. So I removed the Batikon very clearly by the end of the surgery. But I think you put some Batikon to make this swelling of the marrow cell at the end. You're happy with that? Any problems or?
Yeah. But of course, you need to remove it only after a few days, not too long.
Yeah, but the Batikon can diffuse. I'm afraid that, you know, we made a cut in the ear canal, so it can diffuse to the middle ear, maybe to the inner ear.
Yeah, maybe. But again, the fact that I put a vein graft prevents to go into the inner ear.
Yeah,
I think.
that's a good thing.
Yeah, I think so. Yeah. Just before we leave, a big thanks to my anesthetist because she's happy now.
Thank you. Robert, do you know if there is another operation in the other ORI?
Yes. We'll go. Thibaut is waiting for you.
There is another question.
Yes, and it's going to be a short procedure. So then we go for lunch, and then that's fine. Okay?
After how many days the patient can fly?
After 1 month. I know some people say, pardon me?
Someone is saying, and diving.
That's a good question. When they talk about that, I say if you try to avoid, if you can avoid that, it's better. But if you really need to do it, because I had to operate some professional divers, then I ask them not to do it before 1 year. And to be honest, I never had any complication at the moment. But it's I don't have the answer. I don't have any clear answer.
But you know, in France, they're starting to a study to see if we can change our attitude and what we say to the patient, because worldwide is very different. I have to operate an English woman, and she was able to dive, and it was not a problem. The surgeon told her it's okay, you can do that. And in France, you say 1 month, 1 year, excuse me, but usually we say no, it's not possible for you to dive anymore in the Russia Foundation.
Yeah.
So they want to have a common attitude and tell us what we can do.
It's true. Well, my experience, seriously, my experience with that is that I never had any complication with patients diving after surgery. But
the problem in France is if you want to dive with the French Federation, it's not possible because you have to fill a survey, and if it's written, you have been operated from the ear, it's not possible for you to dive anymore.
Yeah, you're right. But some have done. I think probably they didn't tell anything.
There's been a big swing in attitudes towards diving over the last 10 years. Certainly, there have been papers in the USA that have said, you know, if you live in Florida where there's nice warm water, it's inevitable that you're going to want to dive.
Yeah.
And to be honest, the biggest pressure change is in the first 2 meters. If they have good eustachian function, and a lot of these people don't want to dive deep, they just want to snorkel and,
Yeah, but
well, I let them dive.
il est prêt, Thibaut, là? Non? I'm asking if Thibaut is ready for. It's going to be a short procedure, so.
So what do you want me to do? To sing? To perform a dance? Or I don't know.
Sorry?
What do you want me to do right now? I can sing something?
No, it's ready. So we're
Okay,
gonna
so we
move.
can
we're
change and move on
yeah,
to the
we move
next.
to the
Okay,
Avivar. Okay.
right.
Thank you, Marie. Thank you.
Yes, it is. I'm a little disappointed, but okay. So can we change the camera and go to the other? Vous pouvez passer à la deuxième salle? Merci beaucoup. Je sais pas, on n'a pas le retour. Ah si, non, ça c'est toujours la même salle. Est-ce qu'on peut du coup avoir le bloc 5? Ouais. On me fait le signe de la victoire là-bas au fond. Ça a l'air d'être bon. Ah, non, il déplace la caméra. Voilà, très bien. Donc on passe dans la deuxième salle. We are now with Thibaut. We don't have any sound. Can you hear us? Thibaut? No, I think it's not working. He's speaking. I can see his lips moving behind the mask. Est-ce qu'on peut avoir le son? On n'a pas le son de votre salle. Ouais, vous? Non, rien. Thibaut, est-ce que tu nous entends? Non, si tu nous entends, fais un signe parce que je ne t'entends pas. Voilà, toi tu nous entends. Par contre, nous, on n'a pas de retour. Toujours pas.
Mais oui, Michel a le
ça y est,
retour
c'est bon.
là-bas.
Non,
C'est
it's
bon?
okay. It's okay. Now we can hear you.
So I present you the case. Alors, il faut que vous passiez le suivant. So, the surgery will be active bone implant conduction sensio-otico. Allez-y. It is a 67 years old female. She was operated on for cholesteatoma on both sides. On the left ear in 1986 in canal wall down technique. For the right ear in 3 times in canal wall up technique. The last surgery was performed in 2003. That means 43 years ago. And she has currently a bilateral hearing loss. At the otoscopy, on the left side, she has a stable canal wall down cavity with a posterior atelectasis of the tympanic membrane on the foot plate of the stapes. And on the right side, she has a stable reinforced tympanic membrane. Passé. This is her audiogram. You see on the right side, which was operated on with canal wall-up technique, the hearing result is quite good. But on the left side, she has 50 decibel mixed hearing loss, and as there is atelectasis of the middle ear, there is no good possibility for hearing repair with surgery, with ossiculoplasty. So we decided to go to a bone conduction implant. Allez-y. And we choose an active bone conduction implant. These implants are compatible with MRI examination postoperatively, but they have artifact around 10 centimeter around the implant that will impede in the future to analyze the ear or the large part of the brain with MRI. And so because of that, I performed systematically a pre-op MRI in order to detect any unknown intracranial pathology. And in that case, the MRI was normal. For the active bone conduction implant, there is...
I just have a question, Thibaut. Excuse me. For the MRI, because it was a cholesteatoma case at the beginning, do you ask for non-EPI diffusion sequences for looking for residual cholesteatoma before putting the device?
Yes. During the same MRI, she had diffusion-weighted sequences. And you have to remember that on the left side here, it is a canal wall down cavity. That means if there is some evolution through cholesteatoma, we will see it through the otoscopy. And on the other side, on the right, where there is a canal wall up tympanoplasty. She was operated on in 2003, 24 years ago, and there is no recurrence currently. So there is, in my opinion, a very, very small risk of recurrence starting from today. So for the bone conduction implants, active bone conduction implants, there is...
I'm sorry, Thibaut, there is a question for you. We move with the mic.
What he explained,
Please?
he will do the MRI?
Yes, I did the MRI. I just explained that.
What?
And so there is currently 3 available active bone conduction implants in France. The Bone Bridge by Medel, the Osia by Cochlear, and the
I was
Sensio
explaining
by
because,
Oticon.
excuse me, Thibaut, I just explain again why we perform an MRI before surgery. It's because we will use a device that contains a magnet, and after surgery, you will not be able to analyze the MRI because we will have mostly half of the skull you will not be able to analyze. So it's important to see if you have something in the brain, something in the internal auditory canal.
We will advance with the
Yeah,
surgery.
yeah, of course.
It's
I let you go. Yeah,
and
yes.
we will be for the question
Sorry,
after.
go on.
So all the 3 bone conduction implants are same hearing results, and the differences are the design of the implant, which is less or more tall. That needs deep drilling or not, and according to that, we choose Oticon Sensio. So there is this incision, and I drilled Pasrato well for the vibrator of the implant. With the Oticon implant, the well has to be less than 3 millimeter deep. So it's superficial drilling and less, for example, that compared with the Bone Bridge. And the antenna of the implant will be positioned in the subcutaneous subperiosteal pocket. And so we are ready to put the implant, to show you the implant and to put it in place and fix it on the temporal bone. On va prendre l'implant. And so currently the Oticon implant is the smaller of the 3 implants. It don't need a deep well for the vibrator, so you can use it in every cases. There is no restriction according to the size of the mastoid, for instance. And the sound processor is the more recent, with possibility of direct connection with cell phone, for instance.
Can you show us the device? I don't know. Now we
Yes.
can see only the field.
Yes, we are.
You already drilled the socket for the processor.
I will show you the device just now. Là, on va la regarder sur la table. Vous avez besoin de lumière ou pas? On va en mettre un petit peu pour pas éblouir.
Non, c'est pas mal, on voit bien. Non,
bon
non, même sans lumière, c'était à la limite mieux.
Sans lumière, c'était mieux. Okay, this is the Sensio bone conduction implant by Oticon. There is an electromagnetic vibrator. You can see that it is thin, then a demodulator, and the receiving antenna. And you can bind the implant according to the convexity of the skull. And I will put it in place, and after, the vibrator will be fixed to the cortical of the temporal bone with a special titanium band that I will screw on both sides of the vibrator. So we will see once the implant in place. Alors, on va remettre ça.
You already drilled the bone. You have a phantom, a sizer to
Yes,
see if it's
yes.
wide enough or it's.
There is this dummy for the antenna and for the vibrator that allow us to place the implant and to elevate the superiosteal pocket for the antenna. And after, to drill the well for the vibrator, there is this dummy.
And if it's not possible to drill that far, is it a problem or not?
No, you can use it without any drilling. The question is that the vibrator of the implant will be more prominent under the skin, and it can create tension on the skin. With all implanted hearing aids, the skin is really an issue. With the time, with aging, the skin above the implants, cochlea or middle ear or all the implants, the skin can progressively atrophy and that can give problems. So I put the antenna in the superiosteal pocket. Et voilà. And I will put the retractor to fix the vibrator into the well. Alors, passe râteau.
And how do you choose the position of the processor and the antenna?
The idea is that the sound processor facing the antenna will be 45 degrees posterior and superior to the auditory meatus, and the upper part of the sound processor has to be higher than the upper part of the pinna in order to allow the two microphones to work properly. So there, the vibrator is in right position, and I have to fix it with a titanium band, which is malleable, and I will put it over the vibrator and screw it. Alors, il faut que vous mettiez derrière mon oreille gauche, je masquerai moins avec les mains comme ça, avec la tête. So,
can you use this device for children?
In France, it is not available currently for children. It is only for adults. In other countries in Europe, it is available for children. So, in the majority of the country where this implant is available, it can be used for children. Currently not in France, but it will come.
Yeah, they started the study, so I think it will be the same in France in a few months.
Yes, in few months. So,
and how do you position this band? Can you put it everywhere, or
no? You have to put it over the vibrator, not over the conductor link, for instance. So it is over the vibrator. I just have to check the place for the screw at the posterior part.
And in the box, you have two different sizes of this band.
Yes.
And one is longer than the other one, in case you couldn't drill so much. That's it?
Yes. If you create a well that like I did, you can use the shorter band, which is 39 millimeter long. And if there is no well, then the vibrator is more prominent, and there is a longer titanium band, which is 45 mm long.
Ok.
Alors, on va essayer de mettre la première vis derrière. Vous déplacez avec la caméra pour essayer de le montrer. The surgery in itself is not extremely sophisticated and interesting, but the hearing results are
That is something that will
really
not please Robert. It's too simple for him.
Voilà. Alors, j'ai mis la première bande et je vais mettre la seconde.
And you have the screw in the box, something that is in the pack with the implant.
In the pack, there is 2 screws. Hop. Alors.
And of course, you don't have to drill before because it's auto-taraudant.
Yeah, it's self-tapping screw.
Yes, that's it.
No need to drill before a hole to put it in place. So that's okay. And so you can see that the vibrator now is solider to the cortical of the temporal bone. And
do you give some antibiotics during surgery or after surgery when you use some kind of device like that?
I use Perop, and that's all.
That's all.
And so, and I have just to close now, and you can see that the idea for the incision is to have a large enough incision to be able to drill the wells for the vibrator, and the incision has to be not above the vibrator and not above the antenna, but it could go above the conductor link between the two.
We
Voilà,
have a
donc,
question for the incision.
yes?
Yeah, I would like to know if you have ever had any kind of problem with this kind of incision of crossing across the implant that you are using. Because with other kind of implants, we have extrusions or some skin problems. I don't know if you had in your experience any of those.
I had not with the Sencho, which is quite recent in France, but I had with other implants skin issues, but it's really not frequent.
And when you had skin issue, did you had to remove the device or did you find a way to keep it?
The more often it's possible to keep it, the more often, not always. It is, if it is a massive sepsis, then you cannot. But if it is trophic troubles, then it is usually possible to keep the device, but you have to cover it with skin flaps, and eventually you may perform vascularized temporalis fascia flap to cover the implant and skin rotation flaps.
And after surgery, do you have any problem of pain or numbness with this kind of device? Because that's what I encounter sometimes with other devices from other manufacturers.
There is some numbness during the few weeks, 3 to 4 weeks after surgery, but that's all. I hear some that say in cases where the soft tissue are very sick and you cannot put the antenna under the periosteum because in that case the soft tissue will be superior to 10 millimeter, which is too much for the transmission.
So you said for the Sensio, the limit of the length of the thickness of the skin is 10 millimeter. Above,
Yes.
you have to put it under the subcutaneous tissue.
Yeah, in that case, I put it in subcutaneous position. I have no experience of problem with that. I heard some surgeons saying, or if you put it in on the surface of the temporal bone, in fact, in subcutaneous position, the patient will have pain when chewing. I have not this experience,
Okay.
but I think it concerns people that put the implant more anterior than myself. They put it more above the auricle on temporal position, and perhaps it's the cause of the pain during chewing, but I have not this experience.
And when will you be able to activate the processor?
3 weeks after surgery. The idea is that the post-op edema has to resorb in order to be able to choose the right force of magnet. In the first weeks after the surgery, it's very important to check that there is no over force of the magnet, and no injury of the skin because of a too strong magnet. The patient has to be informed of that. If after several hours they feel sensation of heat or pain, that means that the magnet in the external sound processor is too strong, and you have to decrease the strength of the magnet in the external sound processor.
Okay, and we said that the device is compatible with MRI, but it's only for 1.5 Tesla, that's it? It's not possible
Currently,
for the...
yes, currently it's only for 1.5 Tesla for the bone bridge, for the Sensio, and for
The VSD.
Osia 2. For the new Osia implant, the Osia 3, it is compatible with 3 Tesla implant MRI.
Okay. Does anyone have a question in the audience here? I can see you have the mic.
One question here. I'm wondering what time you usually fit your patient after surgery with the sound processor?
The implant will be activated 3 weeks after the surgery with the sound processor. 3 weeks. Voilà.
I think it's time for lunch.
Perfect.
Thibaut, let you finish. I don't know exactly where we go, but I saw some tables outside, so I'm pretty sure it's outside.
In front of the lobby of the clinic. You have a big tent with tables.
So I invite you to get up and go and grab a place at the table. We will see you afterwards, Thibaut. It was very nice and very interesting surgery. In France, it's very new, so it's interesting to see how you do that. Thank you.
Thank you.
It's my pleasure to introduce Abdelrahman. He has a very nice talk on green cochlea. We were together in Hong Kong. That was November, October, and I saw his title. I said, what it means by green cochlea? And I was impressed. Very nice talk. So I invited him because I think it could be a very good point for us. And of course, he's very well known. He's at the head of the ENT in Saudi Arabia. Is that right? President of the society, yeah. So we invite only important people. We do politics here, as you can see. So anyway, it's a pleasure again to have you. And as usual, what I want to say is that the aim of this course is to mix people together. And, you know, in this current world, becomes really more and more difficult to mix people. And the point here is that people can say things, can share ideas, and can fight sometimes in a good way. And look, medicine can mix people together much better than politics. And I think it is important for us in the future. Thanks very much, Abdullah.
Thank you. Thank you. Hello, good afternoon. Thanks, Vince, for this wonderful introduction. And I hope you're going to enjoy this presentation as much as Vincent. And if not, I got this warning slide for all of you that another heat wave is going to hit Europe in July 7, if you don't believe in what I'm going to say in this presentation, okay? And this is not an exception. If you go to Spain, if you Munich, even here, the temperature is going to be hot, hot, hot in the coming futures. But one thing good to know about it, in Saudi Arabia, there is a city called Al-Baha. It's not advertisement for Baha. It's a city called Al-Baha, high in the mountain, city of the honey, and you could see how beautiful the temperature. So if you're going to spend a good time this summer, come to Saudi Arabia. Look at this pictures, which shows the greenhouse gases emissions, and this would explain a lot of things we're going to see in the temperatures, okay? China have this high record, and then United States, Europe recognized this fact early, Saudi Arabia as well, and they're making all the solutions to control these temperatures. And let me go to the first class in the primary school when they teach us the exchange between the tree and the human. Can someone guess what's the exchange rate between human and one tree? Is it 1-to-1, 1-to-2, 2-3? Any guess? Okay. All right, we didn't learn this in primary school, so I'll explain it to you. It's about 250 kilos of CO2 emissions, which gonna be from the tree is almost 1/10, okay? So for one human being, just for breathing, you need to have 10 trees, just for breathing, okay? And if you add to this your usual activities, you multiply it by 16. And if you look to the people in the United States, for each person, they need to multiply it by 64. So it depends where you are. For example, in the United States, you need to multiply more and more and more. Otherwise, we will not be able to equalize this exchange. And we're going to lose and lose and lose. Saudi Arabia recognized this and came with the initiatives of Green Saudi Arabia. And not only for Saudi Arabia, also to expand to the Middle East and then for the whole world. So please get something from Saudi Arabia. Greenizing the environment. Greenizing the environment, part of it is the medical service. And in the medical service, we would like also to look to the sources, to the system, to the service we are providing. All of these is one package. We need to work all together to suppress this kind of emission as much as we can. And I'm sure all of you have heard about the green hospital, green pharmacy, green anesthesia and OR. Can we go ahead and go with the green cochlear implants? I hope in my presentation, you're going to be able to see these visions we have. We try to look to everything to make it green and scan everything as much as we can to end up with the minimally invasive, fast, easy, low cost, all of these that will keep the environments as well. If you look to Saudi Arabia, we're talking about 36 millions, and the area of Saudi Arabia is, trust me, 1/4 of the United States, 20% of Europe, and this is why a lot of patients, they travel by airplane, and the airplane is one of the major sources of this carbon emissions. A big families, so they travel with a lot of people in the airplane, so all of these added to the carbon emission, carbon emission, carbon emission. And if you go to the medical service, there is nothing like a cochlear implant because it starts from day one till patient died. So it's a long journey, a lot of stations in the middle, and each station there's a lot of carbon emission, carbon emission, carbon emission. One of the things we look at it is when the cochlear implanted started multi-channels in 1977, at that time, the fitting was 4 weeks, which it makes sense. Like at that time, it was like half of the head is being shaved and opens and so on. And there was a reason to wait for 4 weeks with the head bandage and all of these. But nowadays, with a small incision, a lot of carbon emission, by the way, everything we can count how many carbon emission in each one of them. But nowadays, with very small incision, even in children's, we managed to do what we call early activation. So we activate our patient with the sound processor nowadays immediately after surgery. And you could see this is a child, this is the old sound processor from Adele, just to prove we've been doing it for years and years. So what we did, we tried to minimize the surgery and go with the early activation. From the early activation down to minimize the surgery. So over the last 15 years, we were able to try as much as we can to make the surgery minimally traumatic and easy for the patient to accept it. One of the interesting things, I'm sure all of you are aware of it, is that it's been clearly correlation between deafness and dementia, and a lot of publication coming in this direction. But guess what? With the anesthesia, in reality, we are poisoning the brain. Okay, so we're giving the patient 1 step forward, but in reality, 2 steps backward by giving them post-op delirium, post-operative cognitive dysfunction, and more dementia. And I'm sure a lot of you get experience with relatives and friends who just had a minor surgery under general anesthesia and end up with major deterioration of his cognitive function. So this is very important, something major thing to be considered. Even the publication is going in this directions. Post-operative, the same thing, delirium, and a lot of publication, like this one's meta-analysis showing that mortality, morbidity is high with the general anesthesia, plus it's a lot of carbon emissions. FDA have this warning long time ago and still having it, is that anesthesia is harmful for the children, for any surgery more than 3 hours, repeated one for children less than 3 years, for parents. So this general anesthesia is not safe. Okay, we want to give a patient better life, but in fact, we poisoning their brain with the anesthesia. So this is the usual surgery, what we are doing. You could see here, we're doing it with no shaving. Even shaving, extra 5 minutes intraoperative, it counts. So we're doing it without shaving. Very small incision, 3 centimeter incision. I'm sure all of you are doing it that way. And you could see here, most of the things done, dissection, blindly, and having this kind of very tight pocket, subperiosteal, to hold the implant. And this is the classical way of doing the cortical mastoidectomy without the microscope, because getting microscope in and out, this count with a lot of time. So we just use the microscope as much as needed, as less as we can. And you could see here, we use this template with the sutures because even hard to find it or pull it out. So this is why we love to have this tight pocket and hold it. We developed this retractors. It's made by stores. I'm not getting any advantage from this. But you could see that would really give us good view to the area and to drill a nice bed to hold the implant. The rest of the surgery is almost the classical. I'm not doing it that fast. Trust me, we're doing it very slow. And then closing the incision. And we end up with the same 3 centimeter incision. With that, it's hardly painful, hardly causing any problems. And this is why we fit our patient immediately intra-op. The other thing also we try the best is to minimize the instrument we are using intraoperatively. This is the maximum instrument you need to do a cochlear implant. It's almost the same instrument we're using for tympanoplasty and stapedectomy. You don't need more than this to do a cochlear implant. And these are the set we use to get it with us whenever we travel abroad and do humanitarian cochlear implants. So this is two papers were published in our center. One of them, 2009, the other one, 2019, and looked at the major complication rate, 9.4, and then it dropped to 0.4. So doing minimalism in reality drop your complication dramatically. okay? Although the surgery become fast and easy and more enjoyable, okay? And we published this. The first thing we published is a pilot study fitting our patient 5 days post-operatively. And we celebrate more than 10 years of publications. And we looked to our data, and it was clearly significant. Early activation, in fact, is suppressing the fibrosis intracochlear. We went to 1 day activation post-cochlear implant, and guess what? All significant. The impedance, T level, C level, dynamic range, all in favor of early activation. Then we did day surgery for cochlear implant under conscious sedation, same day fitting. Same day, intra-op, we fit our patient and they become. So this are the things that I would like to pay attention, that the carbon emission from the medical services is 10%. If we are a country, we're gonna be number 5 in carbon emission, okay? And CO2 emission in general anesthesia for 1 day equal the 1 tree for 1 year. So don't underestimate how much we are adding to the environment. And look to the general anesthesia compared to the TIVA. General anesthesia is 20 times TIVA. TIVA is total intravenous anesthesia. And you could see a lot of people are nowadays going toward the green anesthesia, green anesthesia, green anesthesia. This is one of my patients. Actually, he's one of my colleagues. He's an ICU doctor. He's happy to have his face uncovered. And he needs a cochlear implant. And you could see here, he's completely awake while I'm doing cochlear implants, completely awake while I'm putting the electrode in. But more interesting is him and anesthesia negotiating what medication he likes to have and what's the dose he prefers. And he's here immediately intra-op, fitted with the sound processor. And from OR, he went home, jogging. This is another patient, bilateral adult simultaneous cochlear implant under local anesthesia. And he wake up hearing his name. We said, Abdul Aziz, he was like some drowsy a little bit. But so he completely awake, just hearing his name and changed his life completely. So we publish, all these are published papers, all documented in the literatures. So I would like to take you over these 7 facts we know in medicine. So you would accept this common ground we are talking about. I'm sure all of you believe that the cell itself is a battery with a negative charge inside. And also the fibroblast is one of those cells that actually migrate toward the cathodic side. So electricity play a major role in fibroblast migration proliferation. And the fibrosis is one of the diseases that affect all organs with no treatment so far. There is progress in all type of medicine except in fibrosis. And fibrosis actually started with inflammations, more with the trauma and suction, pressure, foreign body, blood, space, and guess what? All of these are inside the cochlea and cochlear implant. And the 4th fact is whenever you have trauma, either we have regeneration or fibrosis, okay? And we know that the brain, the heart, the cochlea, they do not regenerate. They just end up with fibrosis. And guess what? The 5th fact that the cochlea itself is the richest organ in our bodies with fibroblast. And this is why we'll explain why we have this major reaction from the body to the implant and why we have this ossification of the cochlea whenever we have problems. Because all type of fibroblasts exist inside the cochlea. They have a major roles, and also they've been affected by fibroblast growth factors. So in reality, it's a hornet's nest when we are doing a cochlear implant. So the 6th fact is that the neonate is given a name for newborn the first 28 hours. And this is the time there's no sign of symptom clear, and they have high risk of disability and death. And WHO recommending to have prolonged contact and early feeding. Apply this concept to the cochlear implant, early contact and feeding, and this is the time you may miss this sign and symptom of failure of a cochlear implant. And also if you look to the cochlear implants, complication, almost all of them, with no exception, has a link with the fibrosis. All of them. High impedance, low performance, failures, name them all. is being correlated to fibrosis. How can we solve the fibrosis issues with the cochlear implant? This is $1 million question, and I hope this will be answered by the early activations and electrical stimulation in the early stage. So when we do a cochlear implant, we end up with the two mechanisms, a mechanical and immunological trauma, and this end up with inflammations, and then inflammation end up with fibrosis, okay? We think that cochlear implants and early activation suppress inflammation, which happen in the first few hours after surgeries, and we end up with minimal fibrosis. So we published this one, and we looked to the long-term effect of early activation on the biomarkers of the cochlear implant, which is the impedance. And we published this one. We're the first one who published sustainability in cochlear implants, and we call it green practice. Look to the middle, look more than to 1,000 cases of middle case where we do early activations, and notice that the early activation giving you low impedance. Low impedance is the most important landmarks for hearing preservations and for the trauma of the cochlea. For more than a year, this is with cochlea, the other one was middle. For more than a year, there's significant difference between early activations and the late activations in favor of early activation with low impedance. And you could see here, we publish all this experience, and okay. People ask me, when are we going to stop? I said, activation the implant before surgery. So then I'll take you to a second things in my presentation. I hope you're gonna like it as well. That there's a center in Saudi Arabia for humanitarian, it's called King Salman Humanitarians and AIDS and Relief Center. They approached us and they said, are you interested to do a humanitarian cochlear implants? We were shocked, like, no, we thought, no, cochlear implants should not be done as a humanitarian, okay? But when we saw what they have done, they are famous for separating conjoined twins. A lot of conjoined twins all over the world, they come to Saudi Arabia and get separated. And when we look to the cost and the difficult cases like this, we think cochlear implant is much easier and less cost. So we went to this humanitarian issue last 2 years, and we start to learn about it. And we look to the global overview of these humanitarians. In every year, there is a fund for about 35 billions. By the way, billions is 10 to the power 9. So I'm not good in math, but something to remember. And we all believe this is a necessity, something we need to do it, okay? But in reality, this is the global market for chewing gum. And the cannabis is almost the same. Diamond market is 3 times. Tea is 5 times. Coffee 7 times. Gold is 8.5 times. Tobacco, 30 times the humanitarian. But guess what? Alcohol is 70 times the global market of humanitarian every year. So in Saudi Arabia also, we have a wonderful young generation expert otologist, and we were thinking, no, we can do it, okay? So we started this humanitarian. This is one of the mission in Turkey for Syrian patients. So Syrian patients cross the borders before the evolutions, and we used to do it south of Turkey. So in 3 days, we did 141 implants. I took a picture next to those boxes, and I keep it in my records. And the team is 52, including surgeon, anesthesia, nursing, audiologist, and speech therapist. And the interesting things for me as a surgeon, usually at 2 p.m., the anesthetist come to me and said, listen, if you are not finishing the last case in 1 hour, we're going to cancel it. Here, if we finish before 11 p.m., we got threatened by the anesthesia while we finish early. So the point here is that the early activations help us to minimize everything and make it easy even to export this technique outside. The plan is to do more than 1,000 cochlear implants for Syrian patients. more than 1,000 cochlear implants for many countries in Africa. We went to Senegal, to Kenya, Tunisia, and we think we're going to continue learning from early activation, how to minimize, how to make it fast and easy and enjoyable. And in conclusion, we think the green, which stands with sustainability, is something new that required a lot of research and studying, and hopefully will make a change and understanding and support for many patients to go for this kind of service. And I'm sure many countries, okay, they did not exceed 10% of their requirement for cochlear implants, okay? So there's a lot of demands, a lot of needs, and a lot of cost. If we can minimize all of these, will give a better chance for a lot of patients to hear. And at the end is the news that we need to give more awareness in this regard. At the end, I would like to welcome you all to Saudi Arabia, to the Arab Cochlear Implants with the motto of Green Cochlea. And easy to remember the date is 26 November this year, 26. Thank you. If you have any question, but the green one. No question? Make it easy. All right, I think I'm having 10 minutes extra, but I'll give it to next speaker. Levent, oh, please, easy question, Levent, huh?
But just a contribution, you know, this implantation, we were also programming the implants 1 month after the surgery. ABI, I want to contribute to your talk. We were stimulating the ABI 3 months after surgery, initially 20 years ago, but now we started to do it 2 months after, 1 month after. You know what we do now? We do CI and ABI, and when we are discharging the patient after cochlear implant surgery, we 2 days after surgery, we program the cochlear implant, and it's about 10 days after ABI surgery, and we program the ABI after 10 days. So I think we learned a lot from our experience, but we have to be careful with this. And I think it's a great talk and stimulating in this way as well. Thank you very much.
Thanks a lot, Levent. One thing I would like you to know that if you ask the surgeon, are you okay to get your patient fitted next day or the same day? He said, from surgical point of view, it's okay. But I'm worried about my audiologist. They may have problems with the programming. And if you ask the audiologist, are you interested to fit your patient? They said, yes, but I'm worried about my surgeon. He may be worried about the wound and the magnet and so on. But in reality, we know that the wound healed within 6 hours, okay? Patient can have a shower next day. So the wound is not a major issue. It's a 3 centimeter incision. Even bilateral simultaneous cochlear implant children, we fit them, if not the same day, next day, okay? So it's not a major things for a patient. In reality, it's the opposite. It's patient become more interested, happy. They see the outcome almost immediately. The audiologists are direct contact. And soon we're going to publish a paper that it shows that intraoperative measurement can be used objectively to program the sound processor, sometimes better than the behavioral programming from the audiologist the day after or a month after. So in the future, we're going to see a lot of publication in this, which shows clearly that the early activations is saving a lot of time, giving a better outcome, and more enjoyable for anyone who's doing cochlear implant. All right. So, get more question here.
Yeah, that sounds very good and very nice, but sometimes patients are disappointed after first activation. So if we don't meet the expectations which we create in addition with early activation, how quickly do you give them a follow-up, and after what time do they have their maximum speech understanding?
Well, this is very interesting question, okay? I can tell you that early activation is not going to be solving all your issue with the cochlear implant. So even a month or 2 months after late activation, you're still going to have some patients who are not satisfied with the immediate programming. So the early activation is not an exception, not going to make all your patients happy, okay? So still you're going to face few patients that it takes them a while to accept the cochlear implant. But we publish a paper which shows that the early activation gives you faster stable map compared to the late activation. So the patient for long term compare late and early activation, usually the earlier activations get you faster to the stable map, more happy patients at the end, okay? But this is very important point that early activation is not going to be magic. It's still going to have the same experience with many patients.
I have one more question. What is the proportion between children and adults in your group?
We start nowadays to get more and more and more adult. We used to be 90% children, 10% adult. Nowadays, it's almost 50-50. So adult becoming more and more interested because of local anesthesia. So most of the adult concern is not the surgery. If you speak with a patient who need cochlear implants, their concern is not the surgery itself, it's the anesthesia. And even the relative will tell them, Dad, no, don't go for surgery, because remember our relatives, our friends who had general anesthesia, what he ended up with. So a lot of resistance to cochlear implant is because of general anesthesia. And I think this is a wonderful options for your patients. We used to do local anesthesia for comorbid disease, but nowadays almost my routine to offer it to everybody. And I was surprised that almost a lot of people, they are interested to have it under local. Even for humanitarian, we do it under local. We did few cases under local, and soon we're going to publish it.
I also have a question about humanitarian program. So how this works? Somebody has at least somebody has to pay for the implants.
Yes,
at least.
It's
So
Saudi
who-
Arabia.
I see.
Saudi Arabia is paying everything for the device, for the patients, for instruments, and for the follow-up for the second sound processor 5 years from now. So it's a huge budget from Saudi Arabia for this program. But it's not more expensive than separating conjoined twins. All right, these are all interesting questions, all going in the green side. Thank you.
My pleasure now to introduce Levent Senaroglu from Ankara. Very well known in many fields in otology, and especially for congenital malformation. And apart that, is also a very nice person. So also that's the reason why we invite you. So thank you for coming again, Levent, and we're pleased to listen to you.
Robert, thank you very much for the invitation and also kind remarks. And anomalies are actually my love, I can say. But I academically work with more inner ear anomalies. But I also operate middle ear anomalies as well. All the ossiculoplasty, I love middle ear surgery as well. But because of this, we have a lot of referrals, and that's how it starts, actually. So before I begin my talk on middle ear anomalies, I talked about using the cautery on the incision. I just wanted to show a little video how I do it. So this is a stapes surgery right ear. So this is the cautery that we use. So this is actually a Bowie spray 1. It is adjusted with a tip, and we mark the incision that we plan. So as you see, there is very little bleeding afterwards. It makes the surgery easier. So I think it's a wise thing to keep this in the armamentarium. The rest is, we have seen beautiful examples of the surgeries. Necrosis of the skin? No. This is very little cautery. Yeah. So endoscopic ear surgeons, they use this a lot. I actually learned this from them. Maybe you use as well. And it's a very practical thing. So this is a surgical course, and I just wanted to highlight that. So I come from Ankara, which is the capital of Turkey. We have a population about 6 million. So it's in the center of the country. We have a lot of referrals, and we also have very good audiology. So they diagnose these cases very early, middle ear anomalies as well. And that's why we see them a lot, and all the challenging cases that we operate. So this is the outline of my talk. I will show you, as this is the surgical course, some videos of various ossicular fixation combinations, stapedotomy, manubriostapedioplasty, which is a technique we use a lot, we developed, and bone cement applications, also facial nerve anomaly. I think it is very important to notice this. It can be on the oval window or inferior to the oval window, and some audiological outcome. So all the cases that I will talk about, they have normal ear canal, normal tympanic membrane, with various combinations of the ossicular fixation. And the hearing loss is present since birth. It is non-progressive. And usually these children have very good language development when compared with the congenital sensorineural loss. And most important is the stapes fixation. This is alone or in combination. So oval window, we can have the foot plate present and it is fixed, or sometimes we have atretic oval window. So this is a picture from mass iron ear. So we see the stapes here, we see the annular ligament. So this is, we have the stapes and this is fixed. So we do stapedotomy here. So this is one example. This is an old patient that I operated almost 20 years ago, 22-year female patient, non-progressive hearing loss on both sides. It is very interesting that you see the basal turn, but the apical turn is very tiny. Do you know which anomaly is this? Middle inner ear anomaly? This is cochlear hypoplasia type 4. So they have, normally the facial nerve runs around the basal turn of the cochlea like this. So the facial nerve is in the normal position. But in these cases, the facial nerve is anterior superior to the cochlea. So it can run in a different location in the promontory and oval window area. So this is the operation. You see, very interestingly, this is incus and there is a defect. So I have seen this in a few congenital cases. I think as the stapes is fixed, while the lenticular process is developing, the ossicles are moving, but you know, it is defective since birth. And the stapes is fixed. We don't see any round window movement. And I, just like the normal stapes surgery, I cut the tendon. So this is the, before removing the stapes, I like to make an opening in the oval window area. At the time of this surgery, what we were doing is we were removing posterior third of the oval window. This is what we were doing at that time. Now we make a small fenestra, tiny fenestra with a perforator. But at that time, this is what we were doing, which I think is more traumatic. So in cases like this, where there is a defective lenticular process, I like to extend the incus and place the piston so that it will not slip away from the incus. So this is what I did in this particular patient. And in our department, different than what we have seen today, we started this with our teachers in 1970s. So we crushed the bone that we obtained from the ear canal, and we surround the piston with the bone. So it's completely different than what we have seen today. and this is the facial nerve in an abnormal location, and we always check the round window reflex as we see here. So in this particular patient, this is the closure of the airborne gap after the surgery. Sometimes we have oval window atresia, so we don't see a separate foot plate or annular ligament. So in these cases, usually perforator may not be sufficient and we may need to use a drill. So using the drill is very important because we have to estimate the direction of the piston. So if we make an opening like this and then try to insert a piston, it is not possible. And afterwards, if the fenestra is open and we try to drill here, we can cause sensory neural hearing loss, and that happened to me. So it is better to estimate the direction of the piston and then make the final opening. So this is one patient, 25 years old, with a bone gap like this. And when we look at the coronal section, we see that the facial nerve is obscuring our view to the oval window, which is very common in these patients. So this is the operation of this particular patient. You see the incus, and these are the crura of the stapes, freely mobile, because the facial nerve is in the usual location of the oval window. So in this particular case, there is no separate oval window, and this is the area of the oval window. So we have to make an opening here, and I like to use the perforator, but in these cases, because of the thick area, this is not sufficient, and we may have to make the opening with a drill. So this is an 0.6 drill, very slow, and once we have an opening, I always try to make the final opening with a perforator. And as we see, we have the opening, and this is all we do. We make the measurement, and then we place the piston in these very narrow niche. So in these particular cases, we may have to be ready for these abnormal situations. So the round window, oval window niche may be very narrow, and we check the mobility once again. And this is the round window reflex. So we have very good connection. And first we did one side on the left side and then the right side. And we have very good closure of the airborne gap in this particular patient. We also, over the years, developed a technique called manubriostapedioplasty. So when we have malleus and incus fixation, but the stapes is mobile, I think this can be a good technique for these cases. This can be congenital cases, as you will see, tympanosclerosis and cholesteatoma. And what we do, we remove the incus, we remove the head of the malleus, and we have the manubrium. So there is very little chance that manubrium will be fixed again, and we just connect the manubrium and the stapes. So usually refixation is very unlikely, and the outcome is very good in these cases. So this is these drawings are from our paper. So the malleus is fixed here, and incus is fixed, but the stapes is mobile. So we cut and remove the head of the malleus, we remove the incus, and we use cement between the manubrium and stapes. So it is very unlikely that it will fix once again. So this is a 12-year female patient, and there's airborne gap on the right side. Can any one of you tell me what we see on the tomography? This is a course we can ask questions, Robert, to the participants. Anybody? Huh? Fixed malleus, yes. On which side? This is left. Right side. So you see, this is fixed. Normally we have the air around the ossicle, so it is very important to look at this. And in these cases, I like to use endaural approach. The point to have these images is to determine whether we should do endaural or transcanal approach that we see today. So this is the very fixed malleus, and this is the incus here. Congenital, this is 12-year-old, but when we touch the stapes, we see that stapes is mobile. We have to detach the incus and stapes and check it once again. And in these cases, what we do is we drill the neck of the malleus and remove the head so that the manubrium will be free to move. So this is the tensor tympani, and this is the, so there is no other possibility for refixation of the manubrium. And then we remove the incus, as we see here, and this is the stapes. So what we now do is to connect the head of the stapes and the undersurface of the manubrium. We should be very careful not to touch the cement to the tympanic membrane. So we apply the cement between the bony surfaces. In the past, I made some mistake of applying it on the fibrous tissue. I thought it would be easier, but definitely it doesn't work. So it has to be on the bony surface. Now we turn the patient towards us and apply a few drops on the head of the stapes. And we wait a few more minutes until it is dry. I will have a talk on this tomorrow. So we wait until it is dry, and when it is dry, we will see the movement. Look at the round window here. And this is the postoperative audiogram of the patient. Very good closure of the air-bone gap. So we have different fixation, as I mentioned. So this is a 7.5-year-old male patient, more gap on the right side. Can anybody tell me what you see on the tomography? Round window, but we don't see the round window clearly. So this is the oval window. This is the oval window. And there is another thing. Fixed incus. Very good. So this is malleus here. The incus is fixed. And this is the operation of this young boy. At the beginning, I start with a little atticotomy, and it looks like that all the ossicles are fixed, malleus and incus. So we have to be very careful not to touch the burr to the ossicles. But when we are very carefully investigating, you see the stapes looks mobile. Of course, we have to separate and touch it once again and see that stapes is mobile. And our aim is to check the mobility of the malleus and incus. So this is malleus here, and this is incus. So the tip of the short process is here, and using a small drill, I like to freely make it mobile. Please take a look at now. Now it is mobile. So that fixation that we see on tomography, now it is relieved. And I like to make this a little bit gap here so that it will not fix again. Tympanosclerosis has more chance of refixation, but this is evident on pre-op tomography, isolated fixation of the incus, and there is nothing necessary to be done on malleus. Once the incus is mobile, nothing else is done for the malleus, and then we use cement for connection of the incus and stapes once again. And when we touched the malleus, you see the annular ligament here. You see the annular ligament, very good mobility. And this is the closure of the air-bone gap of this young boy. And this is another female patient who had bilateral, very symmetric air-bone gap. And let's look at the tomography. Anybody can tell me what we see? Chris? Malleus fixation. And I want you to take a look how we are very close to the brain. So we have to be very careful when we separate the malleus. We can easily damage the dura. So this is very important. So again, we use endoral approach. Malleus is fixed. Incus is fixed. it looks like that stapes is also fixed as well. We separate incudostapedial joint. Malleus is fixed. Stapes definitely fixed. So what are we going to do? We do a dichotomy. So first we outline the limits of the ossicles. Incus may be mobile, but you see malleus is fixed. So we have malleus fixation and stapes fixation, you know, two combination. So the part that is fixing the malleus is this bone, but we have to use a thin burr, because if we use a very large burr, we will have a very large opening around the ossicle. So thinner burr, but we have to be very careful not to damage the dura. So I like to work a little bit against the ossicle so that there will be more space here. So postoperatively, there will be no refixation. So the fixation here is different than the tympanosclerosis, with very little chance of refixation after the surgery. So now we have very good mobility, a lot of air room around the ossicles, but we still have to do with the stapes. So this is the stapes, facial nerve, malleus, incus, and they are mobile. So we have to make a stapes surgery as well. So we measure the distance. I use the perforator to make an 0.5 millimeter opening, and this is the fenestra. And I then remove the stapes. So this is a 0.4 piston. As I mentioned before, we don't use any interface between the piston and the round window. So this is just the hole, and we place some bone dust. You see, it's very interesting that malleus and stapes are fixed, but the incus is mobile. So we can have different combinations, and we use some bone dust around the piston, as we see here. So first I did one ear, and then after this audiogram, I did the other ear as well. And sometimes we have all three ossicles fixed. And this is the postoperative audiogram of the right ear after operation. So we can have the ossicles fixed alone or in combination. So we have to check each one of them, and sometimes all three are fixed. So this is very important to check each ossicle. Sometimes we can have challenging cases, and the facial nerve is very important, because if we have these abnormalities, facial nerve can pass in an abnormal location. It can be at the oval window. It can be inferior to the oval window. We can have some CSF leak. I'm sure the more we do these operations, the more we encounter the CSF leak, and sometimes we can have severe ossicular anomalies. So preoperative tomography is very important, and no patient is operated in our clinic without the CT. And we have to check the position of the facial nerve on particularly the coronal section. And if there is an anomaly, I suggest you operate the patient with an experienced surgeon. So let's look at this facial nerve. Normally it is superior and lateral to the oval window, but it can be on the oval window, inferior to the oval window, as you will see. So this is a 7-year female patient. 2 daughters have congenital hearing loss. And this is the tomography. And I want one of you to tell me what you see on this tomography. Minish, what do you see? Sorry? Meatus, but she doesn't have any congenital sensorineural hearing loss. There is another thing. What is this structure?
Yes, a bony prominence at the area of the oval window.
facial nerve is at the oval window. So if you see this, don't operate the patient alone. So this is what we see in the OR. So this is the chordae tympani, this is the incus, and this is the facial nerve. So facial nerve in these situations is usually dehiscent. So there is no bony covering when it is in another location. But you can, once you see this and identify, there is no problem in moving the facial nerve a little bit above. But if you make the fenestra further away, then we have more chance to cause sensory neural hearing loss. So we have to place the fenestra in the right place, which is below the facial nerve. So this is one problem. So in this particular patient, the perforator was sufficient to make this. But as you will see, if we place the piston here, it will not be in the oval window fenestra. So we have to make this extension so that the piston should go a little bit oblique. Otherwise, it is not possible to insert the piston. So first, I make this a little bit thin so that it can be applied easily. This is a little bit difficult to place the piston once the facial nerve is in that position, but we can do this by patient. We have to be a little bit patient, actually. And once it is here, we put some more additional cement so that it will not slip off the incus. And so this is the facial nerve. And this is the postoperative audiogram of this girl. And in the evening, with the mastoid dressing, she could talk to the mother in another city without any hearing aid. You know, the father went immediately to Izmir, brought the other girl, and I operated 2 days later her sister. And this is her sister's audiogram, exactly the same pathology. After a year, I operated their other ear, and the father told me, look, I have a good news and bad news. What's the good news? We have another twin. Bad news? Both of them failed hearing screening. So, you know, this is a genetic thing in that family which creates more and more heart strain for the surgeon. So this is the final patient that I will show. It's a 4-year female male patient. Again, normal tympanic membrane. I told you our audiologists are working very hard and diagnose these cases for us. So this is the ear. Any comment? Yes, we have a very good eye here, and this is the oval window area. So normally this is the place of the facial nerve, and this is inferior to the oval window, and this is on the round window niche. So let's see. So this is the facial nerve, not in the usual location, and usually in these cases the incus is oblique, very difficult to attach the piston, and the crura are free, and there is no oval window. And it was very difficult. I removed the remnant of the stapes. So this is the round window niche, and I worked here and there. So looking at the incus, I estimated a position, and first I used the drill and then the perforator, drill again, and you will see what happens now. So there was no particular involvement, but as soon as we opened the fenestra, there was CSF leak, which I didn't like at all. But in cases like this, you know, we are used to CSF gusher in cochlear implantation. We enlarge this opening. We pass the electrode through a fascia and insert. So this is what I did for this particular boy. I passed the piston through a tiny piece of fascia, and I inserted this. So we have to choose a thin piston and make a slightly larger opening. So once it is inserted, we tug in the the fascia around the electrode. Many times, when we have this CSF gusher, usually we are stressed and there is further loss. But so this is the round window reflex here. So I was really stressed at the surgery, but the family was very happy that the child could hear without the hearing aid. They wanted the other ear to be operated as well. I warned them about the risk. The same thing happened on the other side as well. And, this is the final outcome of this young boy. So CSF leak can happen. We have to make a large opening and pass the piston through a tiny piece of fascia, insert them together into the opening, and push the fascia around the opening as I showed on the video. Complications, sensorineural hearing loss can happen. This is just before we started to use the bone cement. And this was a congenital deaf patient. There was bone fixing the incus. At that time, I was a little bit afraid, actually, to separate the incudostapedial joint, because afterwards, I don't know, we didn't have the cement, and now we have it, and we use it routinely. So I didn't separate. And while I was working, the burr touched the ossicular chain, and we had high frequency loss, which made me very sad. So before touching the ossicles or working around the ossicles, always we have to detach incus from stapes. This is one thing that I want to tell you. I operated 72 cases and we analyzed these. Now there are 6 more cases, but these are the 72 cases that we analyzed. So 14 of these had stapes fixation. Malleus and incus were mobile. So pre-op 48 decibel, and post-operative almost 20 decibel air bone gap. Most probably, we have other ossicular abnormalities, angulations, or changes in their shape. So that's the reason why this may not be as successful as the standard stapes surgery that we do. So we had 10 patients with oval window atresia that we had to use drill. It's more complicated, and post-operative gap in these cases was 20 decibel. If there are 2 ossicles peaks, for example, malleus and stapes, malleus, incus, post-operative gap was 23. Manubriostapedioplasty, to our surprise, gave the best results, because if we connect the mobile stapes with mobile manubrium, post-operative gap is less than 5 decibel. I think this is the most successful procedure in these cases. And if all 3 ossicles are fixed, then no matter what we do, we had almost 30 decibel air bone gap after the surgery. As a conclusion, I can say that middle ear anomalies is a very challenging group. Ossicles may be fixed in combination or alone, and we have to make always tomography, particularly coronal sections, and we have to see the position of the facial nerve. Be prepared for CSF leak. Sometimes I have shown what to do, and separate the incudostapedial joint before we do any work around the ossicles. Thank you very much for your attention.
Thank you, Levent. Very nice presentation. I love congenital malformation too, and I have a good experience on that. And I have 1 or 2 points. There's a case which is very interesting, is when you find this superstructure which is not connected to the foot plate.
Yeah.
In all cases, I saw that. In all cases, I found a malposition of the facial nerve, and the facial nerve was running over the promontory.
Yeah.
It's interesting to see that. Each time you see something like that, I saw malformation of the facial nerve on the promontory. And then the same thing, you have thick foot plate, and you have to drill out the foot plate long term and things like that. So it's interesting. My question is, do you use a classification? I use the Turning-Kramer's classification for the congenital malformation, which is, I think, interesting. It's about what you said, but there's something interesting one. So do you use it or?
You know, with images and with the operative findings, Robert, I worked on the classification of these as well, because the Kramer's classification is not 100% applicable to all. But because I was devoted more and more in inner ear, I couldn't have time actually to concentrate on this because there has been certain changes in our procedures, and we have to cooperate that as well. But I should be a little bit more careful about this. You're right. I mean,
there are 4 groups, and I think they fit very well with your presentation. It's exactly what you have. But it's interesting. You presented things with some specific malformation, the facial nerve on one part of your presentation, the oval window on the other. So it's interesting. It's another way of presenting the things. It's an interesting way.
Hi, Levin. Hi, Levin. So I work at our National Children's Hospital, Great Ormond Street. So we have quite a lot of these.
Yes.
One of the things I wanted to ask you is, what age is it appropriate to operate on these children?
Yeah.
Because they've got a conductive hearing loss, they can wear a hearing aid,
yeah,
and they have a slightly increased risk of sensorineural loss and maybe facial nerve palsy.
Yeah.
And I just wondered how you discussed, I think you operated on a 4-year-old.
Yeah.
And we would not be happy doing that just because of the consent issue.
Yeah.
Because it's not the child consenting, it's the parent at
That's
age
true.
4. So I don't know what your thoughts on that are.
You know, here the most important problem is the risk of otitis media. And if there is a CSF leak, which can happen, these children definitely should be vaccinated before these operations. And when the child is older, I think the risk is the same for sensorineural hearing loss, facial nerve, or anything, because the dimensions of the anatomy does not change after birth. But the only problem is bothering me, the risk of otitis media in younger ages. So it's all in the consent. We talk about everything to the family. If they're willing to choose hearing aid, it's okay. If they are willing, you know, there was CSF leak on one side. I told the family, they said, okay, we're very happy with the result because the child is hearing without any hearing aid. We want the other ear to be operated. It's all in the consent. If they're willing, we go ahead with the surgery. As far as I know, the youngest stapes surgery is 3 years old from House Clinic. Maybe Bob, if he is here, he knows. He went away.
Yeah, my point is not so much it's the fact that the family are consenting, not the patient, because it's a 3-year-old or a 4-year-old.
Yeah.
And we have as a policy for non-life-saving surgery, which is purely elective, that you would aid the patient and then operate at an age at which they can consent. And the question is, what is that? Is that 12? Is it 14? I don't know. But it's not 4 for sure.
Yeah, it's not 4. But around 7, 8, you can... Yeah.
Okay.
Yeah.
Thank you. Thank you very much.
Can I ask one question? Just one?
Quick.
Yeah, quick. Yes, just one quick question. It's a great presentation, but yes, I had a couple of papers which were published on the glass ionoma, out of which some of our patients ended up getting myringitis after a few weeks. Do you have some myringitis, inflammation or yes?
So
And second question is, in case you need a revision for these osteoplasties, how difficult is it when you have the glass ionoma kept there?
Yeah. So myringitis, if the cement touches the tympanic membrane, this can happen. In the past, I had, when I first started to use granuloma on the tympanic membrane, it was a child, so it was a tympanoplasty, and it was very difficult to remove the granuloma in a child. And over the time, I learned to place an interface between the tympanic membrane and also the cement. So we should not touch the tympanic membrane, but the bone surface, no problem, no myringitis or anything. The second question?
In case you need a revision.
So this can be easily removed off the bone, but A few days ago, we were in, a few weeks ago, we were in Brussels, where they did a cochlear implant on already stapes patient. And they used cement to attach it. You know, he had to cut it with a Bellucci scissor. So sometimes it is very strong, but it can be removed or it can be cut. You know, we have this malleus nipper. Sometimes I use the malleus nipper in revision cases to cut the cement. It is so hard.
Thank you.
But it can be removed.
We need to move on. Thank you very much. It's of course an honor for me to introduce my friend and colleague, but I hope you understand that almost everybody talking today, actually I should say everybody talking today and tomorrow, are part of a big Otology family actually. And I think we must compliment Robert, who went to the toilet, I think, because he's the one capable of connecting people in the world from India, Saudi, Germany, and even Spain. Because the people that have come here before know Miguel Aristeri. And of course, we know Jose Carlos very well as well. They run a wonderful course in Madrid, because he is from Madrid, but he's also been trained, of course, by Miguel, by many other people, but also by Hugo Visch and Mario Sana. And then he decided to go into endoscopic. It's incredible. But he's been doing that for more than 15 years, and he's going to tell us about his experience, and I'm sure he won't say it's all for all, but it's very interesting. Thank you very much, and it's very pleasure to see you, my friend, again. And you'll see him who's coming at the conference, and he's the guy starting the dance and not leaving the dance floor anymore.
Thank you so much. Yeah, I'm not used to use the microphone. I usually put one of these, but it's okay. So thank you so much, Wilco, for the presentation, and thank you for everything. As he told me, I'm really pleased that you welcome me to this group. You know, it's amazing how things go so fast. 4 years becoming a member of the group. So they give me only 20 minutes to speak about all I have to speak about in endoscopic ear surgery. This is my new hospital, and I have to say that I'm really pleased to work now here, because I have time now for studies and other things other than surgery. This is my disclosure. I would like to have any conflict, but it's a problem. No. Why I think is why we should use endoscope. I think this is something that I've been, working with endoscope 15 years. After 15 years, I don't think there's no place for endoscope anymore. Right now, we need to use endoscopes. They give you a minimally invasive transcranial approach, and you can reach these beautiful videos that Leven show us. I perform that, I do the endoscope, the drilling of the head of the malleus, everything. And I think it's the view what we had, no? For me, it's very important because of the unnecessary mastoidectomies. I remember well when I was trained 20 years ago, I had to perform the mastoidectomy just to reach the middle ear. Remember that when all this began, posterior tympanotomy was not intended for cochlear implants, it was intended to control cholesteatoma and the middle ear. Okay, for sure we have better visualization with the endoscopes, and I think it's very important. We need the teaching purposes. We need to teach anatomy. I remember well when I have those amazing books about books. Remember all that kind of things with pages and everything. I have the Proctor book with beautiful pictures. I never seen that with the microscope. Now with the endoscope, I can see the ponticulus, the subiculum, all those and references. I think it's important also for teaching. So we can get a better control of the anterior attic with the endoscope. This picture is a beautiful malformation. I think it's one of the best, the first I met. I have to control. Look at this. This is the coda. Right? Beautiful view of the coda. I put it there much better than in the middle. So you can also reach additive antrum like this one. All these pictures are old pictures from very, very beginning. You can recognize the hernia. There's one of the first cholesteatomy I have to deal with this hernia. And if you have a CT scan preoperatively and you expect to have this, don't use the endoscope. Use the microscope. It's much better, because in case you have a CSF leakage, it's going to be very tough with one hand only. I usually like this kind of view, you know. I remember well when they told me, "Nah, remember this false, window, a round window," and you can see very well that that mucosa is the false round window membrane, and we can remove it, and you can see all the anatomy. You can see here, you know, all the stapes, subiculum. This is subiculum, ponticulus over there, sinus tympani, you know. All the retrotympani, as you can see also in this picture. This is one of my first endoscopic stapedotomy. I have to say right now that I use the microscope for all my stapedotomies. So it's a step back, but I think it's much safer for my patients, because in the end, you need to have certain conditions to work with one hand. And if you have the proper prosthesis and the way you are crimping the prosthesis is easier. I will always remember my residents that you have to crimp the Causse piston. Is much better you crimp it, because I have many cases that the Causse piston fall down because it's not properly attached to the incus. So sometimes you have this beautiful view without any athecotomy, but in the end you are traumatizing the coda, and you know, in the end you don't have an improvement of the outcome. So why we lose one hand in this surgery, you know? And I have to say that right now I operate more revision cases, and in revision cases you need both hands, you know. And also if you use a laser, because of the smoke, you know, you need to remove the smoke with the suction cannula. And it's also a beautiful view, you know, of the Eustachian tube, the protympanum. It's very difficult to see this with the microscope, because to reach these cells under the tensor, you know, channel is difficult, and sometimes the cholesteatoma can reach that point. So we need to have in our armamentarium the endoscope. This beautiful view, you know, with a Daysen facial nerve, a fracture of the foot plate, you know, I think it's something that you have to got in your hand. So this is one of my residents performing the surgery. I think right now all the technology make a real point, you know, the real difference for us. As you can see, all the anatomy, the ponticulus. In this case, we have also a malformation. We have no superstructure, but you see the ponticulus, the subiculum, sinus tympani. We have all of that at our disposal. Indications. This is my indications. I have to say, tympanoplasty. Well, this is. I come here to speak about my book. It's very important. This is the app. You can see all the videos in the app, you know, because I don't have enough time to show all of it. Okay, but you can see also is Robert over there, Thomas Roland, you know, all the great otologists are there. So indications, tympanoplasty for me is really, really important. You can have this kind of beautiful views of the anterior perforation, and in this case, just to skip a little bit and don't waste time, we are just refreshing the medial aspect of the tympanic membrane, and we use just periumbilical fat, and this is a typical fat graft that we could put inside. Remember, it's very important. You need to have some different instruments. This one, the point ball seeker, is very important, because if not, you are going to give you craziness. To put that with a point needle is almost impossible. You see, I'm suffering putting that ball inside. In the end, just pushing, and you have a beautiful view. At that time, we usually use this hyaluronic acid, also lamina over that. Not anymore because we don't have it. For me, I put exploratory tympanotomy because if I expect a fistula or a fracture or something like that, the endoscope gives me, a point, over the microscope, but not for otosclerosis. If I know the patient has otosclerosis, I go straight forward, as you see this morning, Robert performed. This is a case, as you say, Levin, I use this in almost any case. Sometimes because I don't have any patient waiting for the, for the monopolar, and then I don't wait. But if I have a little bit of patient, I can access to it, and I think it's much better because the bleeding is almost nothing. In this case, was a 7-year-old children that was sent to me because there was a malformation, and we have a fixed incus to the fallopian canal. So the idea was to work over there and to check that fixation was there, my idea was to go through with the endoscope because I can check better. You can see that even only raising the tympanoparietal flap, you can see the pyramid, the tendon, the fascial. So this very beautiful anatomy. And here you can see that's the fixation to the fallopian canal. Okay, so in this case we just perform, a reconstruction over a mobile. We separate the incudus-tapezial joint and 0 degree. Almost all my surgeries are with 0 degree. I don't think you need 30 degrees is okay, but sometimes you can have some reddish in the image. I don't like it. And I use 45 degrees for cholesteatoma because we need to check the adductus and antrum, and you clean everything. So we check. Usually, as advised here, I usually, makes all the, you see us disconnected, and we remove this portion and just cut it. I want to show you that we just cut it and the long process of the incus, and make a reconstruction. At that time, we usually use that kind of punch, dermatologic punch cartilage, like a beret over the, the staples. Yeah, sombrero, una chapela from the north of Spain. Yeah. But not anymore because radiologists told us that they get confused because it's rounded and they thought that it's a cholesteatoma, So not anymore we use that because this is a good point just to put some a pile of cartilage, always the big one down, just to show that everything is in position. Okay, so for me the main goal or the main approach is mesotympanic cholesteatoma. This kind of cholesteatomas can be, treated with the endoscope very easily. This is a young lady, 12 years old, with supposed to be not to have any problem in the ear, but that perforation say that something happened during early childhood. And this case was sent by a colleague. If a colleague sends you a patient, look at the CT scan, something, because it's very strange, something is going to be there. And as you can see in these cases, we usually like to remove the debris or part of the cholesteatoma just to know and to manage to get how much I'm going to have to remove, bone I have to remove, So I usually remove it and show you. And the idea is even we get out of the head of the malleus, we raise the tympanoparietal flap. And as you can see, we have the fascial over there, the stapes, and we remove all the cholesteatoma. And in this case, that's the point. This is a tensor fold that was making the cholesteatoma not to reach farther. And the idea is we remove all the cholesteatoma in the anterior portion, but in a point here, when I'm cleaning the cholesteatoma, look at that. The dissector goes inside. That's the geniculate ganglion. Okay, I have a fascial monitor that tells me also that that's the geniculate ganglion. Okay, so there's a descent geniculate ganglion. I have to open. You see, we open the tensor fold. We can see the supratuberous recess after opening the tensor fold. This is very difficult to see with the microscope. So we proceed removing the cholesteatoma. I like the gauze. I like the gauze to make this. You can use a bar or everything. And the idea is that we also have another surprise in this case because after cleaning the fascial recess, because the cholesteatoma goes into the fascial recess, okay, we also find that here the fascia is also, descent in the facial recess. So it's very tricky case. You see the facial nerve over there, and there's cholesteatoma in between the lateral canal and the facial nerve, and we need to get rid of that. I have to say that this is a dissector. When good dissector with good German steel, yeah, Thomason, but the old one, because you can grasp some bone. I remember well Hugo Fish telling me, no, you can grasp bone with a dissector. Not anymore. Yeah, all my new dissectors bend after making some pressure. No, so you can remove the cholesteatoma, believe me, and you can finish. And in the end, we just clean, bar a little bit, reach the adductus and antrum. I am not, confident if I not remove all the mucosa. And finally, we clean the matrix from the geniculate ganglion. And we usually put a large piece of cartilage just to prevent the recurrence of the cholesteatoma. And this kind of by design of all those kind of things that sometimes helps you when you don't have enough fascia or you don't want to remove more tissue. It's okay. This is also an indication, a limited apical cholesteatoma. For me, the best one is the one that is lateral to the ossicles. That's the best indication for these cholesteatomas. Sometimes it's really, in the limit, at the limit, because the cholesteatoma grows into the adductus and sometimes reach the mastoid. For me, it's very important to have an MRI, because in the end, if you have a cholesteatoma in the mastoid, there's no point, to perform the endoscopically the approach. Then I open the mastoid. So the idea is we have this kind of cholesteatoma. There's also young lady, 20 years old. There's a mild hearing loss, no other problems. As you can see, as we expect to have the ossicles in place, we don't use the bar, as Levin told us, it's not good. So much better if you use the curette. I think it's very important to have the technique to use the curette. When I have this kind of glue coming out from the middle ear, for me it's perfect because I know that the cholesteatoma just block the drainage of the mastoid, and what I found previously in the MRI is correct. No? So we perform the atycotomy and we find the incus and the cholesteatoma is there. We stent out resection. The fascial nerve is over there, down there, with the reddish. Open it. You want to see all the surgery, you have it there. The idea is we perform a modified bonding technique, with the ossicles in place. You see the ligaments and everything. It's very difficult with one hand, but in the end, it can be done. If I can do it, you can do it for sure. So we check that the cholesteatoma never went into the mastoid. It's very important for me because I don't want to have any recurrent or residual. And we reach the anterior epitympanon. Well, it's the anterior attic by removing all the posterior attic blind sac, and there you can see, you can check that everything is in position and we don't have any sac there. So we remove the cholesteatoma, and finally we have all the ossicles in place, the ligaments, everything, and we only have to put a large cartilage there. And this is very important. If you want to prevent the recurrence, you have to close very precisely everything. If not, my first cases, I have problems because I left some tiny space in between the atticus and the bone and the cartilage. And I have some recurrence in those cases because we don't solve the problem, the second tooth dysfunction. Okay, this is as a canal wall down. This was intended to be, before MRI, intended to be endoscopic approach. And after that, we decided to go also through the mastoid. So it's as the same infiltration, elevation in tympanomeatal flap. We can see all the cholesteatoma there. It's a big one, it's a huge one. Is reaching the mastoid. So I'm going to perform also the mastoidectomy. I usually, clean this part endoscopically, but I know very well this case is not a case for endoscope, so I began to perform, because in this case we have a fistula over there. We need to, push all the cholesteatoma down because we are going to go backwards and we are going to go through straight forward through the mastoid. Is a non-nematized mastoid. We need to drill the bone and reach the antrum. I skip everything just to show you how we reach the antrum, and we reach the sac over from behind. And one point I want to show you is that in the end it's just a canal wall up, and you use the endoscope just to assist you. But finally, when I show you again, when you think that everything is solved and clean, you put the endoscope through this, and you can see there's remnants of the cholesteatoma over there. You see? It's impossible to see that. Impossible to see without the endoscope. So in this case, if I don't use the endoscope just to clean that part, this is fascial research. But I can manage that with a canal wall up, So this is very important. This canal wall ups assisted with the endoscope is much better, okay? Sometimes you can deal that with the microscope. You can see that with the microscope. You can use a gauze, you can put something there, trying to clean, but with the endoscope you can clean it. What is a stupid thing for me is to perform a mastoidectomy with the endoscope. It's a stupid thing. Okay, you have both hands, microscope, perfect. For me, it's another and the last one of the indication. For me, this one is especially good one. Is posterior atelectasis. This kind of patients with this kind of with posterior atelectasis with glue, dysfunction. I usually perform also the Eustachian tube dilation associated with this procedure. So the idea is the same. We infiltrate. This is very important. The patient is infiltrated previously, but we also make this hydrodissection because it's very useful just to get these bubbles from the middle ear that is going to help you removing all the tympanic membrane. Okay, we rise, we reach the middle ear, and this is very important. This is the very important step. You need to use some blunt dissection because what we don't want is to damage the tympanic membrane. So we need to reach the level where we have a cleavage plane and we can rise all this tympanic membrane that is debilitated. You see all the mucosa coming, the mucus coming from the middle ear. After removing all of it, we have the incus, and is what I told you. I'm trying to grasp the tympanic membrane, trying not to damage it, and just slowly, with patience, and remove. This is easier with the endoscope because the vision leads you to perform and where you have to push or where you have to, grasp, and it's easier to perform the dissection and to raise everything. This maneuver is very important. It's like in the polyps in the nose. When I was a resident, I used the polyps. It's the same. In the end, what we want is to maintain all the tympanic membrane intact. Okay? So this is the movement, and we raise everything. After checking everything is perfect, and we have all the tympanic membrane raised, then we use what I told is a bridge technique. It's a bridge technique because we use a very large cartilage that we usually put under the anterior sulcus and under the posterior sulcus, like a bridge, to maintain the middle ear aerated. So you have to put it there and bend also. That's the idea, to bend down. And in the end, you can get, this huge bridge anterior to posterior, and you will have your middle ear. You will never have a recurrence with this cartilage. Okay, you have to spread all the tympanic remnants and to check that everything is in position and you don't have any damage here, or I'm very pleased when I push and I feel that the air is not coming from the middle ear, so it's really close. And sometimes at the beginning, we began to put a T-tube at the beginning of my procedures. Not right now. We wait right now because nowadays not all the patients need a T-tube. So if the patient complains about, again, mucus, or maybe I see some retraction in the follow-up, then I put the T-tube in the office, you know. But at that time, at the beginning, we began like that. So that's, for me, is the most important part for the talking. Is the final one. Is, I don't know if you know about the Scott's parabola. This is a very, very good one. I have to say that it was my neurosurgeon that told me that about this gynecologist. And I think it's the rise and fall of any surgical technique. It's important to know that, you know. You can find, if you look for a Scott and a Scott's parabola, you'll find this beautiful diagram. And the idea is that all promising area will reach the standard treatment. I think right now, we are over here. General introduction is not a standard treatment. Maybe we are beginning to use it as like a standard treatment for some diseases, no? But for me, the best part of the Scott parabola is this. Remember this? When the technique, only the old surgeon amazed the juniors with stories about the old days when I used the endoscope or something like that, you know? I think it's very important, you know, that in the end it's another technique we are going to get. Thank you so much for your time, and I hope you enjoyed. I don't know if you have any questions or anything. Yeah, please.
Thanks for a great presentation.
Thank you.
Just wondering, when you're doing canal wall upmus surgery for cholesteatoma,
yeah.
More extensive, with the aid of the endoscope, what's the role of a posterior tympanotomy for you with the way that you approach that surgery, if any?
Yeah, in this case, if we use the endoscope as a part of the procedure, we don't need a posterior tympanotomy. Sometimes you have to do it if you have some fascial recess that is very deep and you can reach it from posteriorly. Then you have to open it, you know, because with the endoscope you can reach that part. So I think there's no point to perform a posterior tympanotomy when we use the endoscope in the procedure. Yeah. I usually use the 3 millimeter for regular surgery, tympanoplasty, exploratory tympanotomy, but for cholesteatoma I prefer to use the 4 millimeter because in cholesteatoma you need to reach, sometimes you have to almost bend the shaft, and then, yeah, the view is better, it's brighter, and sometimes you have to bend over the cartilage of the middle of the sternocleidomastoid canal, no? And sometimes you can damage. For me, it's much better if you use a big cartilage, a big cartilage, and you put it like a bridge, you know, because I've seen some cases that you put a small one, like a banana, and it's not so good. I think so. I usually use an extrude in the inferior portion of some cartilage. It's also possible if you can, not so big, because sometimes you don't have enough cartilage or you don't get enough cartilage. You can use a smaller cartilage, but you have to put any kind of extrude or something to support that cartilage. I think it's just a way to perform it. I don't think it's the only way to perform it. Okay, so there's other ways for sure. Okay.
Yes. Thank you. Thank you very much, Jose.
My pleasure.
Very good. Now I'm waiting for your dancing capacity. No, that's not true. Absolutely not. I've seen you do surgery. That's very good. Joachim. It's a great pleasure for me to introduce again Professor Joachim Müller from München. And I actually thought about it. I think we first met in 2003 in Amsterdam, when you came to Amsterdam. And he's a well-known otologist with absolute German Grundigkeit. We've had him many times in the live surgery program that we had Lion. And the good thing always about Joachim is that when we need it, because if some surgery couldn't go through, we could always ask Joachim, don't you have another patient? Oh, don't worry. And within half an hour, he would have another patient in the OR demonstrating another surgery. So he was very reliable and is very reliable. And we'll lean on you again when we do Lion again. But it's such a great pleasure to have you here. And I'm very curious on your stapes revision. Thank you very much.
Yeah, thank you, Wilco. Hello, everybody. We tried in the... Yeah. Okay. Thank you for having me again. Thank God I can talk about staples and staples revision surgery and not about soccer. We're much better in otology than in soccer. Yeah. But, yeah. Otosclerosis, we have seen a lot and discussed a lot of techniques. It starts with staples mobilization, fenestration, stapedectomy, stapedotomy, partial stapedectomy. All this has developed over the years, and when we do staples surgery, we always should be prepared to deal with surprises. So that can be malformation, as discussed by Levent. We have column-like staples when we operate on van der Heuvel syndrome. We have sometimes as a conductive component fracture of the stapes in osteogenesis or in trauma. We have what I've seen only 2 times, new bone formation around the ossicular chain. I have no explanation. It looks like a 4th ossicle. Maybe somebody of you has seen that, and we don't do a staples surgery, we do a prosthesis then. But it was hardly discussed. When you do surgery, you have revisions, and revisions always come from alio loco. So the question raises, where is alio loco? It's a small city in Spain, a little bit north of Barcelona. Oh. And yeah, one of the problems in staples surgery, if you like to crimp, is that the fixation of the prosthesis remains a challenge, and loosening or not proper fixed loop is one of the problems. The solution we have looked at is crimping forceps, similar to that what Robert showed in the OR, but design was adjusted to the shape of the incus and the prosthesis. Of course, if you're manually that talented like Robert, the 2-hook technique is ideal, but I warn you, this is really a challenge, and it's not as easy as you have seen in the morning. But this forceps may give you a help. Well, when it comes to revision surgery, the statements are discussed controversially. We had the similar discussion in the morning. When should we do the surgery for a child? What is with the consent? And the literature says that the risk of having a deaf ear after staples revision is estimated to be 10 times higher than in primary stapedectomy. Hearing improvement is, even in trained hands from fish, significantly lower. And she assessed it with around 50% chance of hearing preservation at that time when he used the wire prosthesis. So it is somehow more demanding and primary intervention. Just to give the conclusion first, in the series that Dr. Sharaf looked at in our clinic, 80% of the patients reported improved hearing, but all were piston prostheses that were revised and only a few steel wire prostheses. So staples revision surgery needs preparation, and prior to staples surgery, we have an espresso in the morning because the pure pleasure is inside. It's like a surprise egg. You never know what you find and what you will experience, and that's what I'm going to share with you. But what we find in our experience is that failed incus reconstruction with cement and hydroxyapatite. So that's the reason why, after our publication in 1994 with the reconstruction of the ossicular chain with cement, I'm not as positive as Levent, but maybe he has different materials. In this patient, the prosthesis was nicely fixed with the cement, but there was no fixation between cement and incus. And that's sometimes a challenge to get it really properly fixed. You have experienced the same, Chris, I know from the discussion last year. Improper fixation was seen frequently, so the loop was not closed properly by the previous surgeon. We have seen incus erosions at various degrees, also with different prostheses. We have seen it also with band-like prostheses. If we compare it to the older paper, which I will show you later on, the steel wire prostheses had much more incus necrosis produced than the band prostheses, but also the band prostheses produce erosions, as well as the clip prosthesis, which was said to have, because of the clip mechanism, no incus erosions. But if you look at the principle of a clip prosthesis, where the clip closes to a fixed diameter, if the incus is much too thick for that, you will have erosion, and it explains itself. Well, sometimes we see incus erosion on the penetration to lateral to the incus. This often is a combination of two factors. That means reossification of the foot plate and a relatively short prosthesis with scar tissue pulling the prosthesis outside. And the solution is a special double L-shaped longer prosthesis. Basis is a 5.5 millimeter classical staples prosthesis, which is assessed to what we need. And the picture on the right-hand side gave proof that the first introduced prosthesis was too short. We used classic, a standard prosthesis 4.5 millimeter. We don't measure. And if we control the oval niche, we don't use a vein, and see that the piston goes into the vestibule, then we are sure that the length is okay. But in this case, the prosthesis did not reach the vestibule, and so we took a longer one and exchanged it. Well, when the incus is missing, you have a problem. You have to fix the prosthesis to the handle of the malleus, make a tunnel in the middle third, and then fix the prosthesis around, shrink it a little bit, and then the piston part will jump into the oval niche. It's always preferable a partial platinectomy according to Plester, removing the the posterior third of the foot plate. Well, if we have a malleus head fixation, we have seen that with the malformation, with it's overlooked by the previous surgeon, then you can make an atticotomy and remove the bone, drill it free, and then replace the prosthesis from new. Once you have a retraction, also this can cause a erosion of the malleus and the incus, or the fixation is like here, with new bone formation between the incus and the handle of the malleus. I don't know if anybody has an idea how new bone growth can occur in the middle ear cavity after surgeries. Sometimes we found fistula at the oval window. We found it after laser from the carbonization edge where the fistula was found, and often the fistula is under the facial nerve. So in primary surgeries, we put soft tissue between the prosthesis and the facial on the level of the foot plate. So this is an important step to avoid this. Many more cases with fistula we saw with the Audio Technologies prosthesis, which is porous polyethylene, where you had, or we found a gel phase around the prosthesis in between the surrounding tissues, and that caused the fistula. And we have seen this frequently, so that's a prosthesis we do not recommend anymore. And again, a fistula at the round window. Well, dislocated prosthesis is also frequently seen. Sometimes the CT scan prior to surgery helps you, as well as the CT scan helps you to detect a gusher, to avoid or be prepared if it comes. The mechanism is that the scar tissue shrinks around the neck of the prosthesis and pulls tension on the prosthesis, and then the prosthesis dislocates. This, of course, opens the question we had addressed before, that is it a reossified footplate or has it never been opened properly? That's something you have to decide, and some intraoperative findings suggest that sometimes the footplate was not opened properly before. But if you have a malleovestibule assembly and have a revision to do with that, then you're a little bit in a problem if the malleus is not capable of carrying a prosthesis. Then one solution is to use a malleus replacement prosthesis, or take out the prosthesis, seal the round window, put a VSB into the oval niche and seal it, and then have an amplification device directly putting sound into the oval niche, which has an opening and a sealed opening with soft tissue to get the sound transferred to the inner ear. For that, this is a nice mechanical system. If you place the sound bridge down into the oval niche, it's much more stable than connecting it with the torp or oval window coupler, which the company gives you. But this is a paper where you can read the mechanical details on that, but it works nicely. Well, stapes revision and stapes surgery years ago, and then the patient comes with a deaf ear. That can happen, and you should be aware of ossification, and the solution in these cases is putting a CI very early and very quickly, and sometimes use a drill out of the prosthesis. And we decide, or whenever possible, we leave the stapes prosthesis inside, not to remove the stapes if the vestibular function is still there, to avoid additional vestibular problems. As I mentioned before, most of the cases were piston prosthesis. The real challenge is to remove steel wire soft tissue prosthesis like the Schuknecht prosthesis, because they have scar tissues, and this is a CI picture where the knot of the prosthesis hardly can be seen in the oval niche, so better leave these things where they are to avoid any problems with the vestibular system. So we've seen a lot of varieties, what you can find, what you have to be prepared for. One situation should be discussed, that is stapes revision shortly after the first intervention. This is a picture 2 weeks after stapes revision surgery, where we found this foreign body granuloma. The previous surgeon did go in, cleaned the middle ear, left the prosthesis inside, and then 2 years, this farmer, 2 weeks later, this farmer experienced the deafness, and when we went in again, we found this foreign body granuloma. So our conclusion would be, if you have an inner ear depression right in a few days after surgery of a primary intervention, we would go in, take out the prosthesis, and then keep and hope for the best with substitute of cortisone in the thing. So in our group, we had in nearly 50% of the patients replaced a standard length prosthesis. In 30%, we did customized prosthesis and adapted it to the individual situation. In 3% only, we did malleovestibulopexy and an assembly. And if we look at the outcome, the mean airborne gap was 12 dB, whereas in the primary intervention we had 8.5 dB, also including the 4 kilohertz frequencies. And in the distribution function, 85% of the patient heard postoperatively better than preoperatively. This compares nicely with a large series of Robert and others published in the literature. So we are about the same range of postoperative conductive component. If we compare it with the earlier series with my teacher, who included not the 4 kilohertz, the distribution function for the patient is the same, and the majority had an airborne gap of more than less than 20 dB. What the study of Sharaf confirmed also is when you go for revision stapler surgery, there are some patients who do worse or do not experience a good benefit, and those were patients with a moderate conductive component. So the old rule, do staplers revision surgery if tuning fork test RINE is negative with a 1 kilohertz tuning fork test, then you can expect the good results. If this is not the case, be careful, except you do the revision surgery for vertigo or other problems. Well, and if you have an inner hearing loss and no conductive component, I want to give credit to Dumont for the power stapes. This is a solution, and we should not forget about this. And again, the cochlear implant allows for deep insertion also in otosclerosis cases. If you experience ossification inside, I want to bring the apical cochleostomy from Montardon in Switzerland into discussion. This is another point if you are from the old party, and then you can refresh old memories, and as was said before, tell the old stories, but that was something which is useful, and you should not forget it. So in the end, staples revision surgery can lead to favorable results. The number of patients who enjoy improved hearing is high if you respect the indication criteria. The risk of a deaf ear was 1%. We updated the collective and the patient group and extended it. Meanwhile, it's more than 160 patients we have looked at, and it was for this series 1%. Now it's 2% of a deaf ear, which is higher than in a primary intervention, and all the patients had the advantage of an experienced surgeon. And of course, having a cochlear implant to be able to restore the hearing in case of deafness had definitely an impact on the indication. So some of the patients who experience a deaf ear are afterwards with the cochlear implant much better than they were with the hearing aid and staples prosthesis before. So this is sometimes to consider whether you primarily go for a cochlear implant instead of a revision staple surgery, and it should not lead to the fact that you are less critical when giving the indication, because you can also produce vertigo. Yeah, and with that, I'm happy to take questions. And for those who are interested in otosclerosis, on behalf of my friend Mario Zanotti and Santiago Arauz, come to Mendoza. They are setting up an interesting meeting, and they're really nice people, and offering good hospitality. Thank you. The only disadvantage they have in Argentina, they're not very good in public relations, so I'll take advantage of it.
So, congratulations.
Yeah.
Yeah.
Questions?
Joachim. Here.
Yeah.
Yeah. Congratulations. why don't you consider bone conduction hearing aid before revision surgery in stapes?
No, I consider bone conduction surgeries, and that's another tool that we have to discuss with the patient, and we have external systems where we can let them try. But one of our psychologists did the study on patients for stapes surgery on hearing quality and quality of life, and the hearing aid and also the few patients with the bone conductive trial, they report the hearing quality less good as after surgery. So we offer it, and medical legally we inform them, and if they are doubtful, we let them try. And once they have enough from the trial and decide for surgery, we go for surgery, but we don't force. Yeah, like a Baha band or a Apollo system for an external bone conduction device, or they try the classical hearing aid. Yeah.
Welcome, nice presentation as usual. What is your experience with advanced cochlear otosclerosis, where you get this kind of severe mixed hearing loss, and you would like to give them benefit of doubt of stapedectomy, but at the same time you are worried that this get progress fast and then they may miss the chance of better outcome with cochlear implant?
Well, it's surgically challenging with the electrode insertion sometimes. You need to have an MRI to see if the fluid is inside the cochlea there, and having access doing a cochleostomy, while usually in these cases the round window is obliterated, can drive you also a little bit crazy, because you drill much longer than until you reach a lumen, and then you're never sure whether you are in scala vestibuli or in scala tympani. Mostly it's scala tympani, and then usually if the MRI gives a good sign, the electrode insertion with a long electrode is easily possible. What we see afterwards is that it takes them longer to get high performance compared to other patients, and they reach high levels of speech understanding in the level of 80-90% monosyllabic word tests, but it takes longer. But in the end, they are happy and use it. And those patients who had revision stapes before, they do much better with the cochlear implant. So if they are with a hearing aid, an air conductive component of maybe 20-30 dB, and the inner ear bone conduction curve at 60 dB, they most probably do better with the cochlear implant.
You are absolutely right, and I think this is one of those difficult cochlear implant cases in many aspects. One of them is the facial nerve stimulations, and sometimes it's hard to control it.
Oh, we don't see that so much. We have the long flex electrodes, which are soft, and occasionally, about in maybe 3 or 5%, we have to switch off some electrodes, which is much less than it was reported in the literature with other systems. And we have a possibility to compensate with triphasic pulses to overcome the facial nerve stimulation. But switching one channel off usually does not present a problem. And usually it's the channel where the cochlea runs under the facial, and this can be worked out and then adapted.
We're running a little bit over, so I think if you have any more questions, please. No, Joachim, you have a coffee after Marie's session, so please feel free to come and see Joachim. So I'm particularly pleased to receive Marie Daval, who is working in Paris in yeah, of course, Rothschild Foundation, and It's a pleasure also because we also have Diane, and at the beginning of this story, of this course, it was a pure male group, full of testosterone. And then with age, testosterone is decreasing. Now we've got this guy from Spain, which is, again, now increasing the amount of testosterone. So having two wonderful lady with us, it's a real pleasure to have you. And of course, Fondation Rothschild with Denis Aya, she's very well known. And she's extremely brilliant, like Diane. So I'm very proud of having you. Thank you for coming.
Thank you very much, Robert. It's a real pleasure for me to be there today. I really want to thank you for the invitation. And I think it's really important to have this kind of meeting with people that are coming from every part of the world in a very welcoming atmosphere. That's really great. I don't know how to launch my presentation. It's on? It's on. Okay. So I will speak about exoscope and its future. And even if it sounds a little bit pessimistic, you will see that's probably not totally true. But before we start, I want to be sure that we speak the same language, and I want to know if you know what an exoscope is. So I just want you to raise your hand if you know what an exoscope is. Okay, that's great. So you know better than the generator image I use for this photograph, because obviously it doesn't know exactly where the ear is, because it's not over the shoulder, I think. And it doesn't know how the tympanic membranes look like, but you can see there are 3 ossicles. So that's great. And I know it's absolutely not green. I don't know if neuron is still there, but I promise I will use this photo for the rest of my life. So you know what is it, so I don't have to explain much. You need 2 cameras that are slightly apart to record the surgical field and to display it on the screen, or goggles, 3D goggles or 3D screen. And you can operate heads up, and everybody in the room see exactly the same thing. Many manufacturers have developed this kind of device, from Storz, Olympus, Zeiss, and BHS, and much more, but I don't know all of them because I know only the one. That's my phone, but if you can maybe answer my son that probably lost his keys or something like that. So many devices were developed, and I tried most of them. So now I want to know who in this audience already used the exoscope, not in a dry lab, but on real patients. So less, but still a few. Okay, right. And who currently uses an exoscope, not an endoscope, in ear surgery every day? So exoscope, I did some mistake on my, so no one. We'll see. I don't know what you thought about what you tried. We will see afterwards. But it's something that is very expensive, and it's probably one of the main drawbacks of this technique, and why no one in this audience use it every day. So what you knew is that the ear surgery is very tricky because it's a very peculiar area. Everything is very small. It's hidden at the bottom of a very narrow canal. The light cannot reach this area. So, and we have to perform very small gesture with metal instruments. So it's very difficult. And if you want to operate well, of course, you have to see well. And what we need is a visualization system that provides good lighting, magnification, and an adequate field depth. We have 3 tools. The first one is the one that probably most of you use every day. It's the microscope. It provides a 3D image with a variable zoom, and you can operate with both hands. 30 years ago, the rise of endoscope arrived, following the rise of the endoscope for sinus surgery. But it was not accepted by everyone very quickly because it's something that is very different. Of course, you can see hidden area, and we saw that with Jose Carlos previously. It's very economic, and you can have the same image for everyone. And the last technique that was described is the exoscope. And it's the device I want to show you today. You can have a 3D ID, exactly like in the microscope. You can operate with head up, and you can have your both hand. But the rise of the exoscope suffer from the rise from the endoscopic surgery, because it arrives just before. It helps you reach hidden parts such as the attic, the retrotympanum, the hypotympanum, the eustachian tube, and that's not the case with the exoscope. In the exoscope, you still have the same vision in the axis of the external auditory canal. But the endoscope, and I would like to take a quick survey today, the one I do every time. Who in this audience perform endoscopic surgery? If I've done that the year before or years before, the number would have been less. Every year, we are more and more to operate with endoscopic surgery. So why not everyone? Because it's something completely different. And probably you use endoscope because you were taught how to use an endoscope for sinus surgery. If you're a very experienced surgeon who operates with microscope for a very long time, it's not so easy to switch from these techniques to this one, because it's not the same way to operate. You have a two-dimension image. Usually you operate with only one hand, and it could be difficult when it's bleeding. And at the beginning, we bought this kind of device. It's a robotic endoscope holder. Honestly, now we use it less and less, but it was very reassuring at the beginning, because you can have your both hands when you want. You can suck blood if there is any. And it's very useful at the end of the surgery when you want to place the prosthesis, because you have your both hands. So the endoscopic has a long learning curve. So that's why not every surgeon today operates with endoscope. The exoscope is some kind of a bridge between the microscope and the exoscope in the endoscope. You can operate with both hands. You have a 3D visualization, exactly like a microscope. You can share the image with everyone in the room, with your head, with the nurse, so everyone is interesting, with even the anesthesiologist, and even the nurse who is usually playing some games on her phone. But probably it's because it was the beginning. So you have the same image, you have the same posture, you are straight, you don't have back pain at the end of the day, because usually with the microscope you have to turn around and to take position not very ergonomic. And that's exactly the same as in the endoscope. And the exoscope is much more easier to use for a surgeon who comes from the microscope world than the endoscope. It makes sense. Honestly, you can operate everything with exoscope. It's exactly like a microscope. It's very well adapted for the mastoid work. It could be a little bit harder for the tympanic cavity part, because usually when you want to zoom in very much, you lose some light and you lose some definition. It's not so focused, and usually you have a problem of lens of depth. But it's possible. But not all exoscopes are equal. The smaller ones are very easy to use and very easy to handle, but usually the image is not so great. And we saw the difference between this one on the left side, on the left part of the picture, are the devices developed by Storz. The first one was the Vitum 3D. It was very easy to handle, but you have to do it with your hand. And the second one is the Vitum Hegel. It's much more bigger, but the image was very clear. You can use the laser with it, and because it's very big, you have some kind of robotization inside. And the image, I didn't show you a lot because usually we record it in 3D, so I had to bring you some 3D goggles that I don't have, but you have exactly the same kind of image you have with a microscope. But you see here on the Kinevo is the one developed by Zeiss. It's not exactly an exoscope, but it's a microscope that you can put above the field. It recorded the surgical field, and you can see on the 3D screen, and you can see that it's not focused on every part of the middle ear. So sometimes it's very zoom in, you cannot see very well. The advantage of the exoscope is that it's more polyvalent than a microscope. I think you've already experienced the fact that one day the microscope doesn't work anymore, and the nurse say, well, you can use the one from the neighbors, the one of the neurosurgeon or the one of the ophthalmologist, and you say, no, it's not possible because we don't have the same device. Usually the optics are not positioned in the same way, the length of depth is not the same, so you cannot use them. And theoretically, the exoscope is much more polyvalent, so you can use the same for many specialty. And I say theoretically because that's not entirely the case. Most of the devices that were developed for the other specialty are not made for the ENT surgery, and especially the otologic one, usually because, as I said, we have a very narrow canal that blocks the view. And here you can see it's the one we have in the Rothschild Foundation. It's a Synaptive. It's a Canadian one developed for the spine surgery. It's very clever. You can move the camera with your hand. You can move it with your voice. You can remove it with, it's following a tool that is navigated, but it's bulky. It's awful to handle. It's very heavy, so the nurses are always complaining, and usually they don't want to use it. So it's not always adapted. What is very interesting in the exoscope is the 3D vision. It's really a strength because it's wonderful to teach because everyone will see exactly the same, so the interns see the same. Every attendee you want to teach a surgery can really understand the surgery you perform. But some people poorly supported the 3D. Of course, there are headaches or dizziness, but some people cannot perceive the 3D correctly. I had 2 doctors in my department who could not really understand what they see because what was very close to their eye seems to be very far and vice versa, so it was very disturbing. You have to keep in mind that the laser is important, and sadly most of the system cannot be used with a laser, and I know that Joachim don't use laser for the otoscleric surgery, but some of us do. And it's really an issue if you cannot use the laser because you're blinded by the red color of the laser. What we tried and what I thought was very interesting is the combination of many techniques. This one is something we used the Vitam 3D in the mastoid and for the beginning of the surgery. That's what you saw here, and it's a 2D image, but it was recorded in 3D. And the endoscope that is used with an holder to do everything that requires an endoscope. That means everything that is located in hidden area. And you can change, it's exactly in the same screen, so you don't have to bring the microscope and a screen for the endoscope. Everything is on the same screen, and you can change from one to the other very easily. And if you want, you can put both of them on the same screen. So it's a little disturbing when you begin, because you can put the image of the endoscope on one side, the image of the exoscope on the other side of the screen, and you can alternate. You see what you do with when you are in the transcanal approach. And if you want to go to the transmastoid approach, you just have to look at the right side of the screen. So it prevents you from moving your microscope from one position to another, and that's really interesting. But I'm pretty sure Jose Carlos would have said, but you could have done that only with endoscope. Why do you need a mastoidectomy? And probably he's right. But that was what I would have told you 1 month ago, because we were very eager to invest in this device that was the Vitom Eagle from Storz, but they decided to stop marketing the device and to move to some other technology. So that proves that when you want to invest in the technology, you have to be aware that sometimes the manufacturers cannot follow you in the long term. I think the exoscope is very interesting for what I said before, the teaching, the ergonomics, the shared vision, the surgery in the mastoid, the hybrid technology. And in the future, I think it has some very high potential for digital implantation, because it's a digital image. So you can imagine that you can add the neuronavigation, you can add the augmented reality, and it could have been very interesting. But even if this technology was improving, I showed you that the image was better with the Vitom Eagle than the precedent version with the Vitom 3D. So it was a step forward, but they decided to stop because it's something that is very expensive. An exoscope is at least 2 times more expensive than a microscope. And when I say 2 times, it could be 3 or 4 times more expensive. So it's difficult for the manufacturer to develop this kind of device, and it's difficult for the hospital to invest in this kind of device. So, and I will finish with that. I really think that the exoscope is not a flash in the pan. I think it's a really nice discovery, and it can improve. Of course, Storz decided to stop this one, but the other one didn't say anything about stopping the marketing. So I think with the future, with the miniaturization, the adjunction of the neuronavigation and the augmented reality, it could be really something that could replace the microscope in the future. Thank you for your attention. And I want, like the other, to add another date in your really busy calendar, but we are really we are really happy to welcome you to the 5th edition of our Otology Disorders Academic Congress, that this year will take place in Roma, and that I organize with Denis Ayash, my beloved boss, Yann Nguyen from Paris, and Daniele De Seta from Italy. Thank you very much. And if you have any question, I think, I don't know if you have time now, if you want to, okay. Are there any question in the audience? Yes, Joachim.
Thank you very much for the nice presentation. And I agree that the exoscope is really nice, and it's also nice for teaching and education. You mentioned the split screen. How do you manage to look at 2 pictures in one screen? One for the left eye, one for the right eye, or on what do you
Yes, of course, because I'm much brighter than you. No.
Yeah,
of
know
course,
that you can manage.
Of course, you cannot. But you can look at the one side, and if you want to check what you do from the mastoid, you can look at the other side.
You know, the woman can do 2 things at a time compared to men.
You cannot?
But
yes, of course I can.
I think it could be changing in the future, because the young people are using a lot of video and a lot of les jeux de où comment ça s'appelle?
Le paintball?
Non, quand des shots. Comment ça
of
s'appelle
course
ça?
I understand.
And
video
they shot-
game, a
and
lot
they-
of video game and
they have,
the shooting
they
game.
have a lot of screen in the same image. So
Yeah, that's
it's
what
a
they
question of
developed.
use.
The ophthalmologists in our department are developing a 3D headset where you can see the surgical field and the examination you had made before, and you can just look at it, and it gives you the information.
Comes with glasses now, yeah. That's right, yeah. But
But it's not for everyone. Everyone knows that 3D sometimes it's very tiring at the end of the day. Sometimes you cannot stand it, so you have to try it. If you want to buy something like that, you have to try it.
But you know, I had this experience myself. They came to the clinic and we had a great. I enjoyed it very much. I mean, it was very nice to do it.
And it was very easy for
It's
you
very
to.
easy.
It's really not very hard to
No,
handle.
it took me 1 hour
Yeah,
to
yeah,
adapt
yeah.
to something like that, so I enjoyed it very much. But unfortunately, originally we were prepared to do it live today, but because of this, there were some problems with some patients, so we didn't decide to do it. Unfortunately, it would have been very good. No, I think it's great, and I just take the opportunity to let you know that stores, they are presenting a very impressive screen, which
Yes.
is right outside the, just before you leave this place. There will be a very beautiful demonstration, the big screen on the right at the exit of this room. So please take some time to visit them.
No, it's really nice.
Yeah, you know that. You're gonna buy it?
This one?
No, the big one.
Yeah, the big one that is.
Yes.
No, I don't have it. He
Ah,
told me it's not very expensive, but it's a little
It
bit
is
expensive.
expensive.
But no, it seems to be very useful if one day I want to stay in my office and check what the intern do in the operating room. That could be very great. Yes, controlling. Big brother. Yeah. Okay. Any other questions? Okay, it's so. If there is no question, I think we can
Yeah,
go to the
we can
break.
go. We
And
have
if you
30
want to
minutes.
ask me question over there, you can. Thank you very much for your attention.
So it's just the beginning of the study we do. It's a series that I made since now 1991 and until December 2025. So I'm using this database, Otology Neurotology database. If you go to the website, you will see exactly how it works. You can download it, by the way, and you can use it. There's lots of trailer to know exactly how to use it in terms of functional results, outcomes, complications, and you can mix all the different things. And you can also, by the way, create your own database for thyroid surgery, ophthalmology, anything. Anything can be done with this. So, so this is, again, as I said, a preliminary result. Needs to be more precisely studied by statistics. But this is the series of more than 7,000 cases, which is really interesting for two things. It's a big number, so you can work a lot on these big numbers and study different items. But also the long-term results. I think it is important to see how it goes with time, only on primary surgery, of course. So in this series, we have more than 7,000 cases, and on the same time, I was able to perform 1,600 plus revision otosclerosis. On my primary case, far advanced, you know, it's 2%, so it's not that important. I remind you that far advanced is more or less defined by preoperative bone contraction, which is lower than 50 dB, which is, I think, kind of a nice one. And then in terms of age, you see the mean age is 48, running from 8 to 91. So you see the French sometimes, they want to be operated even when they're old, 91. And interesting thing, we will go in more details on that. In my children series, you can see 50 cases. And following 11 presentation, it's not a congenital malformation. It's definitely juvenile otosclerosis. It's not the same thing. So it's a progressive disease with family history, CT scan, everything. So it's a kind of a big number. 50 is quite big. And I published my preliminary results for juvenile otosclerosis many years ago. Now, in terms of surgical findings, which is interesting, in my series, I got 2.2% of obliterative otosclerosis, but it's interesting to compare what's happening in my children series. You see the incidence is close to 20%. So that's very important to know. If you intend to perform stapes surgery on a young child, you have to know that you may encounter higher risk of complicated cases like obliterative otosclerosis and simultaneous malleus ankylosis, which is more frequent on a children's series. It's interesting. So you have otosclerosis and a congenital malformation, because in fact, malleus ankylosis is regarded as a congenital malformation. So be very careful if you want to do stapes surgery. You need to be some experienced surgeon, or you need to have an experienced surgeon with you. In terms of ossicular reconstruction in this series, I was, of course, using mainly incus to stapedotomy in 99% of cases, and 1% malleus to stapedotomy. So this does represent a very low number, but it's still there, and you have to do something in case of malleus ankylosis or malformed or eroded incus. It could happen to have a simultaneous eroded incus. Now, in terms of post-op hearing outcomes, the available data is 6,200 plus, with a mean follow-up of 70 months, running from 3 to 400 months. And in terms of post-operative airborne gap, you see my closure of airborne gap is 91%, which is defined by closure within 10 dB, not 20, 10 dB. It's interesting because when I published my first series of 3,000 cases many years ago, my post-op airborne gap closure was within 10 dB was 95%. And with time, in fact, it's decreasing. So probably because the evolution with the big number of cases, with time, the airborne gap occur again and things like that. So it's interesting to see that. I thought I was stable. I even thought I'd get better with time, but it's not the case. So that's good to show. And in terms of mean airborne gap, you see a good evolution of the mean airborne gap, 3.6 dB compared to 25. Same with the mean air conduction. And the incidence of central hearing loss is pretty stable now, 0.5%, which is defined for me by post-operative bone conduction dropping down more than 15 dB. That's what I define sensory hearing loss. Dead ear is something like 1 per 1,000 in my series. And it's not predictable, by the way. You can have a dead ear, even when the surgery works very well, you are happy with you, and then when you remove, and even sometimes the patient does not complain for anything, and on post-op, when you remove the plug, you do the hearing test, and you have a dead ear. Sometimes, of course, they have lots of dizziness. And I have a case, a recent case, which is a disaster. I did the surgery, and there was a granuloma, but a big granuloma, which occurred with time, not immediately. She was fine post-op, and after a few days, she developed a very severe tinnitus, only a few days after that. Then I kept in the clinic, we treated it with steroids and everything, and she was getting better with a lot of imbalance, so we have to treat with physiotherapy and everything. She got better progressively, she came back home, and then with time, after 2 months or even more, she developed again a severe vertigo, severe dizziness, and of course she had a dead ear already. And she was very bad, pain and everything. And then we did CT scan and MRI, she had a huge granuloma. I've never seen that. It came ossification of the cochlea, of the vestibule, running up to the dura and to the carotid artery. And she was operated by one of my friends, and the operation went very well. But I mean, it was a very severe complication. I didn't get that. Everything was fine, but the technique itself. But anyway, in terms of results according to age, pediatric series, same kind of results, including the elderly. But interestingly, there was no case of sensory hearing loss in my pediatric case. You have the same event? It's interesting. Why? Why? I don't know. I know, it's interesting. Compared to elderly, we have, and on 0.5 to my entire series. And now in terms of results according to surgical findings, if we compare all the different things, obliterative doesn't give the same result, of course, because it's more complicated. And also the incidence of sensory hearing loss is higher, 4%, compared to, remember, 0.5%. So again, if you cross the fact that it's interesting. So we have 4% of case of sensory hearing loss in my children series. On the other hand, it means that the incidence of sensory hearing loss seems to be higher in case of obliterative otosclerosis. But on the other side, the incidence of obliterative otosclerosis in my children series is close to 20% compared to 3% in the entire series. So it should be also having, we should be also having some sensory hearing loss in the children series, but we don't have. It's because the obliterative otosclerosis is not the same anatomically. On the children series is soft. It's thick, but soft, so you can drill out without too much. I think probably true. You probably agree with that. And with the adults, it could be very strong. So I must say that if you encounter a case of strong, hard bone, really hard bone, I think it's better to stop, because if you try to drill out, I think the risk is to increase the heat into the labyrinth, and I think that could be the cause of sensory hearing loss. And just the long-term results. So this is a different series which I was preparing last year. We have to update the number, but it's going to be more or less, I think, the same thing. I was studying until 2024. That was a long-term result over 25 years. And of course, the number is decreasing with time, available data. But you see, what we can see is progressively a decrease of the good result with time. And with time also, you can see the bone conduction, which is the red line, going down mainly after 15 years. It's pretty stable over 10 years, and then after 10 years, start to decrease. So it's clear that with time, there is a decrease of the hearing result. Well, that's it. That's just my publication that I did with the children on laryngoscope and other publication on otology, neurotology. That was the first series I published in which I was happy with my results, a little bit less now, and the revision also, as Joachim was talking about this published paper. So we are working together with Joachim in Munich to publish this big series of 7,000, and I think it will come soon. Thanks very much for watching. I think we could start with the hearing session now. Okay? Okay, great. Oui, c'est ça. On est 8, c'est ça? Two. I take two. You take two. Okay, thank you. We have to go on the other side. Sinon, moi, on est en chercher. Ouais, ça fait 5. Je sais plus. Comme ça. Parce que sinon, on voit pas les temps. C'est ça, ouais.
Okay, can you give
Ah,
me
non,
the...
non, ça va. This one should be the other side.
Like that, because if you don't see the screen.
Oui.
Uh,
Then, one slide.
Non, ça c'est pour la personne qui présente, on va dire, et ça.
Non,
c'est pour-
il prend le.
Ah,
regarde,
ok,
il prend
bah, on prend celui-là, il est mieux.
Ouais,
Celui-là.
d'accord.
Vous êtes de ce côté-là?
duplicate, oui.
C'est moi qui commence, donc je vais rester peut-être de ce côté-là, ouais. Comme ça, je pourrais m'asseoir rapidement.
Do you want the mic?
Oh yes.
Okay.
Vous avez besoin du micro?
Ouais,
ou
je
pas?
prends comme ça. Merci.
Yeah. Okay, so the last session we will also be finishing in time. It's called Tympanoplasty Around the World. It's inspired by the Hearing Group, which is a group of comprehensive hearing centers who work together in research and exchange. And we call it Tympanoplasty according to Wohlstein's classification, and give you some ideas how situations are handled all over the world. The main important people are you, because you should participate, ask and discuss with us. And the expert, of course, give you some points where to go. We have about an hour, and I think if we make it in 45 minutes, then we are ready for dinner, so we hurry up a little bit. Huh? 6:30. Okay, so we will manage that you get the bus, and we look how far we can come. We thought about having different aspects of phases of tympanoplasty. One phase is the opening. We have discussed this during live surgeries. We will discuss a little bit on transplants and implants materials. Asim will also give a presentation on that, which I forgot to mention in the overslide view. And sound conduction is an essential part of tympanoplasty described by Wohlstein. So we will address briefly what possibilities we have, but we will leave this topic for Chris' roundtable on ossiculoplasty tomorrow. So he will go into detail, but just to be with the overview complete, we tell you what the people would do in case of a tympanoplasty in the reconstruction. And if we have time, we can discuss some controversies like obliteration, canal wall up, canal wall down. But in the end, the last speaker will be Hajar on the aftercare, because aftercare is also important to ensure the outcome. Do you have any questions? Do you have any hot topic that you want to address the expert panels? No, questions will come for sure. So we start with phase one, and Mari will come, and we have integrated her presentation, and she will speak on incision and opening the ear. Sorry.
Okay, thank you, Joachim. So let's start with the beginning and the incision of opening of the ear. You know me, and I don't have any conflict of interest. So the first step to operate a ear is to go inside, and there are different ways to approach the eardrum, and that's the different techniques that you of course know, but the transcanal approach, the endoral approach, the retroauricular approach, and the endoscopic one. There is a problem with well, don't worry. So how do you choose the approach? It depends, of course, if it's perforation of the size and the location of the tympanic membrane perforation, if there is a cholesteatoma or not, if you will need to perform a mastoidectomy, how is the ossicular chain, and anatomical consideration, for instance, the size of the external auditory canal, that is very important to assess before surgery, especially if you operate in transcanal approach and endoscopic approach, and if there is any bone overhanging. And of course, that's only for the pathology, and you have to take in account the patient preference, because sometimes they don't want to have any scars. You have to think about the risk of keloid formation in different kind of people, and the surgeon's preference, because usually we have learned something and we try different techniques, and at some point we find the one we prefer. And what I will tell you today is what I think it's the correct choice, but I think if you speak with other people, they will tell you exactly the opposite. There is no perfect technique. So the retroauricular approach, the indication is, of course, for the cholesteatoma, if you have an extension posteriorly behind the short process of the incus. Think about it if you have retrotympanic epidermosis, because it's easier to operate with a wide approach in this case. Enlarged perforation, such as the one you can see on the right side, for revision surgery. And if you want to harvest pinna cartilage, because you are not the first one to operate and there is no tragal cartilage anymore. The advantage is that you have an excellent exposure of the tympanic membrane in the attic, the antrum, and the anterior part of the tympanic membrane. As you can see in the yes. Retrotympanic epidermosis is, for me, when you have skin inside the tympanic membrane. Usually it's when it's not a perforation, but it's a retraction that that means that it's not the correct word in English. That's it. How do you call it? So the advantage is you can see very well all the tympanic membrane, especially the anterior part, as you can see when you have a very big anterior perforation. Okay. And when you have a posterior approach, of course, you can go to the mastoid. And it's the best way, I think, to perform a canaloplasty if you are an overhanging bone canal, such as what you can see on the left side. Yeah, it's awful, this picture. But the endural approach, so it's the one that is written here. It's when you perform an incision in front of the ear between the tragus and the helix. In France, we have huge discussion about what is the best way to cut the skin. And in Paris, especially, we had two schools that were great enemies between the one that perform only retroauricular approach and the one who perform only endural approach. And they say, no, you don't have to do that. It's a mistake, and the other way around. So the endural approach, especially for the posterior tympanic membrane perforation and the retraction pocket. This ossiculoplasty, when there is without extensive disease posteriorly, and when you think that it's not possible to perform an endoscopic or a transcanal approach. The advantage, it's less invasive than the retroauricular approach. You don't have a big scar. The patient complain less of numbness and pain, and you have good access of the posterior mesotympanum. You want me to ask question during the okay.
Panel whenever you want.
So we have the panel. I already asked you in the audience, but I will ask you here. Who perform on daily basis retroauricular approach for any kind of surgery. Okay, Rema. The other one, what do you prefer? Yeah, Robert, I know, I saw you this morning. You are a strong fan of transcanal approach.
Yeah, but I think there is a room for everything.
Of course.
You need to have a
That's
posterior approach.
that's what I said.
But Thibaut and François are better than me in posterior approach. So if I think there is a posterior approach, I refer the patient to them. I do transcanal, but the different thing, even if I have a total perforation, I use a specific technique I call total flap removal. You know, I make a 360-degree incision all around, removing the whole tympanomeatal flap, which gives you a lot of area, drilling out, of course, the anterior wall very frequently, taking care of the TM joint, of course. And then we got a really nice exposure of the whole perforation then, and then I can put my graft in a nice way.
And when you say you remove the tympanomeatal flap, you put it outside the here?
I take it, I put a elastic sheet between the anterior wall, the anterior part and the posterior part, and I remove the whole thing. Put it on saline solution. Then I got only the bone around. I put my graft over the malleus handle, over the bony canal wall, and then I put the flap back. When I was starting this, I was thinking that maybe I will have some necrosis. I never had any necrosis of the skin. And the risk is lateralization of the tympanic membrane.
But that's what I wanted to ask you, because I do exactly the same, but not for the perforation, but for what I call the retrotympanic epidermosis, because I think it's the best way to remove everything that is in front of the malleus handle, because you're not sure you can remove everything.
But now, you know what I do is that after having repositioned the flap, I feel completely, I put 3 elastic sheet all around the canal, plus 1 to keep the graft in position, and I feel completely the canal with gel foam. But I learned that from Benoit Gratacap, and it was...
So elastic sheeting in the ear canal?
Yes.
Or in these cases?
In the ear canal.
And did you had any lateralization? A lot of them or not?
Not so much.
Usually they said we can have some blunting at the anterior part, but it doesn't have any effect on the hearing. That it's not a problem.
Yeah, lateralization has an effect, but not blunting, not so much. And the incidence decreased a lot since I'm using this gel foam technique.
But I don't know if it's the same in other country, but in France, when you say you open the anterior part of the tympanic cavity and you will put something very anteriorly, everybody say, "Oh no, you don't have to open; it's too dangerous. You will have blunting." It's highly controversial in France. Is it the same?
Let's first ask how is Saudi?
Well, for me, most of those cases done in university setup where we need the resident to get exposed and maximum basic technique. So most of the time I do it sulcus, which is also considered retrocochlear, so retroauricular. So basically in the sulcus area, it's small incision, and then we do similar thing like postauricular. For the most of the cases also we got in the university are the difficult or the revision cases. And this is why we would like to give it to the maximum benefit and easy for the resident to practice. For anterior perforations, we most of the time make this anterior window where we pull the graft underneath and then make it as a tint from inside. So that would make it easy, and I think we have a good success rate in those cases. I don't remember we have any blunting or any complication.
Yeah.
And use the same incision you show us for the cochlear implant, so very short one. For the other one, why don't you perform retroauricular approach?
You know, when I was resident, our teacher was trained in the United States, and he learned endoral approach. That's what we do. But when I was resident, I remember in meetings they were having very hot discussions, endoral, postauricular, and it's nothing to discuss. If you have very good tympanic membrane after 30 years, no matter what you do, you are successful. I think this is the most important thing. And I do everything endoral, everything. So, all these indications I do endoral. I make the incision, enlarge it anteriorly, remove that bone there, endoral, nothing. But unless there is complication, if there is brain abscess, or if there is lateral semicircular canal, sigmoid sinus thrombosis, I use postauricular because there is perisinus abscess, sometimes behind the sinus, then you need postauricular. But the rest, all the cholesteatoma in the mastoid, we do endoral.
And with endoral approach, how do you remove bone? What is your technique? What kind of tool do you use?
For this
a
one?
drill? Yes, for this one, for instance.
Yeah. You know, you make an incision. So normally this is.
Can you speak
12.
in the mic? Can you speak in the mic for the audience, please?
So I don't have the pointer, but this is 12 o'clock. This is 6 o'clock. So normally I make an incision like this. But for this case, I make the incision here, elevate this, diamond burr, we remove it. We teach this to our residents. Diamond burr, never.
Agree. Yes, yeah.
Okay,
Cutting burr would be dangerous for the TM2.
What about
But you can use also gouge or that's what some
yes, you can do that.
yeah. That's not what I
do sometimes for exostosis.
Yeah.
I drill out a groove like this, and then I go with the chisels to finish the job. But I don't like too much. I prefer the diamond.
Oh,
yes.
Mumbai speaking.
Mumbai. All right. So I do 80% of my work endoral. I agree with Lemon, because you can access almost anything except the mastoid tip endorally. Now, when you have a sclerotic mastoid, when you want to do a subtotal petrosectomy, it has to be postoral. But otherwise, to expand on what he was saying, there is a Lempert 1 incision. Let's look at this here. That's your first incision here.
Lempert was a German.
This is the Lempert 2 and the Lempert 3. That's lesser known. And if you take that down, you're able to reach up to the, if you have a sclerotic mastoid, you can reach up to there with the endoral. And of course, if it's a small perforation, it's going to be transcanal.
And yeah, I just had one question before. If you, for example, for a cholesteatoma, an aticocolesteatoma, you started with an endoral approach.
Yes.
You discovered that it's not possible for you to remove it only with this approach and that you have to perform a mastoidectomy. What kind of incision do you do? Do you continue your incision or do you do another one?
Not the Heermann's incision. What you're talking about is the continuation is the Heermann's incision, not that.
For us, it's Chambaud.
I would just go postoral because any which ways, if I'm going to do a large canalplasty, I would need that endoral incision any which ways. So I just take a standard postoral incision and go behind.
Advantage of endoral incision is the natural meatoplasty.
Yeah.
So, you know, you make a cut and you don't close it properly. Then you have a very nice meatoplasty. So you don't need to remove here and there. So it has a lot of advantages. And we start with the lateral part of the ear canal. We enlarge it, and then we go to the attic and make an inside-out mastoidectomy. So we follow the pathology until it ends. Sometimes, you know, it ends in the attic, sometimes in antrum, sometimes upper part of the mastoid. So you don't need to make a huge mastoidectomy. Very rarely you have to make a huge mastoidectomy. Then, but it has a lot of advantages.
But you would do your CT scan pre-operatively, you will know where this is going. Yeah. Yes, so you will know how far down it's going.
Yeah,
we stay with the incision. We don't go to MRI for incision, then we are discussing in 3 hours.
Yes.
Thibaut can say something about that. He has great experience with a posterior approach.
And after that, I will ask the audience.
I perform mainly a retroauricular approach. And we have the discussion in Germany last year about principles of cholesteatoma. And in canal wall mastoidectomy, the idea is to keep a small aticotomy and to expose all the cavities through the mastoid, because a small aticotomy is very easy to reconstruct. If you perform a large aticotomy from endoral approach, then you have a large aticotomy to reconstruct, and in my opinion, it's more difficult. So it's really a question of
probably they obliterate. I don't know what you do when you perform an inside-out mastoidectomy.
When you make so when you start with the lateral part of the ear canal, you enlarge it. So, you know, the ear canal is like that, you make it like this. So many times you don't need to make any obliteration unless you make a big mastoidectomy. Then it needs, in that case, you know, what I do, I obliterate only the part of the mastoid that I drill. So usually the tip, I can use the drill. I'm sure that there is nothing left there. But when it comes to around the same circular canals, I like to leave that area saucerized. It becomes a very small cavity. But the chances are much less to have
Joachim that is very stressed. We won't finish. Because we are speaking of everything except the incision.
Well,
so
as long as the people enjoy,
yes,
we go
course.
as far
Yeah.
as we can.
I
But I
would-
think it's what you said is important. It depends on what your plans are and your experience. But your comment first, and then I address the question.
If there is a mastoid work, I would go directly retroauricular.
Okay.
That would give me the easiest of mind and do whatever I like to do. Now, I do both.
Can you speak closer to
so
the mic?
if there is a mastoid work, I know that there is a mastoid work, I will go directly retroauricular and do whatever I like with peace of mind. And I'm sure that there is no mastoid work. Most of my cases I do transcanal. If there is something like anterior hump or something, I know that I have to drill, then I will go with the end oral. And this gives you access big enough to enter your drill and go up to the anterior angle without even.
Okay,
So
and
this is how I do it.
Thank you. And in the audience, who prefer a retroauricular approach? Okay, and I will ask again because endoral approach. Who is endoral in the team? Endoral approach. So that means that all the others.
No
The
opinion.
endoscopic for the last one. Huh? Yeah. Choose, yeah, but that's what I mean. Transcanal approach for me, yeah, okay. And I asked you before, but who are the one who use the endoscope for perforation or tympanoplasty? And in the panel, it's not a good panel. Yes, please raise your hand. I just need one person
Endoscopy,
to.
of course, if it's a medium size or something like these, why not? It works very well.
The only question is the right about image. Are we going to operate that or not?
Right now, you mean?
I think there's one
Yeah, of course.
one more point.
But there is some infection there.
Yes, of course.
Do you operate at this stage or you dry
no,
the
no,
ear?
no, of course. But sometimes you try it as many
But-
treatment as you can. Yeah, okay.
But this is a pure central perforation. Do you dry it or you operate like this? Because there is pus.
Yeah.
But
I
that's
think
a
we
good
always
question
try.
for
That's
the
a really-
audience.
I think we
Who
always
would
try to dry
operate
it out,
on
but
the right
sometimes it
ear
doesn't work, so
to
we
get
have
it
to-
dry, and who would wait until it is dry? To make it dry, who would wait until it is dry?
As far as
Yeah, but
possible.
sometimes
How
you
long would
cannot-
you wait?
But,
1 year, 2 years,
Joach-
5 years? If it's never dry,
Joachim, I think there's a consensus. We all try to wait.
Yeah.
But there are some patients where you have to do something. Whatever you do, it doesn't
And,
work.
and sometimes you have that, especially you saw the patient the week before. You say, I just want to check if everything is okay. It's okay. You gave them some
Moderator,
drops
can I
to
add
be
something?
sure that everything will be right. And the day of the surgery, you see the eardrum, it's like that. Do you cancel the surgery,
Hello?
Joachim?
No.
No.
Hello. Can I add something?
Robert? Yes, of course.
If the discharge is not getting dried up, if the ear is not getting dried up, it's always better to send the pus for culture and sensitivity. You start proper antibiotic. It does get dry up, then you can go ahead and operate.
That's what we want to reach, of course. But sometimes it's not
But
possible.
I remember the Christian Deguin, we met him before a long time ago. He said that we should do that because it's good to dissect. It's easy to dissect when it's inflammatory like this.
You know, those ears that do not dry, usually they have some granulation tissues, this and that. That's the reason why they don't dry. But this is a pure nice perforation. And if it happens at the day of the surgery, I would cancel the operation. Because, I mean, this is not an emergent operation. And, you know, we will take a very nice graft, we will place it there, we want the graft to survive. Yeah.
But then you have the ear seen in a dry stage before.
Yes. So
that's the difference. If it was dry and is wet at the day of surgery, it's a different situation compared to you see this and you never seen it dry.
Yeah.
Yes, of course. But Levent?
But in fact, if you look to what you said, only this is inflammatory. So if you remove this, refreshing the perforation.
The rest is tympanosclerosis.
Yeah.
But Levent?
Yeah, please.
Levent, do you check every eardrum before surgery? The day of the surgery before the anesthesia?
Yeah, 1 or 2 days before the surgery, yeah.
Always 1 or 2 days before surgery? Yeah. Okay.
Ladies first and then you.
How about you?
If it's something that is always dry, I will not sew them just before. But if it's something like that and I had to give some treatment, I will see them the week before because it's usually when they have the appointment with the anesthesiologist. And to be honest, I operate on Tuesday and Wednesday, and my consultation is not, I don't have consultation 2 days before my surgery. So I cannot do that.
So
question.
in those cases, when you do it endoscopically, when you are operating with the endoscope.
Which one?
Those that aren't dry when you go
No,
to surgery.
no.
I'm saying
no.
No,
If I know,
I need to complete the idea.
Sorry.
So in those cases, sometimes you get in and you see block the ear spaces, the ventilation routes. So that is why it's an advantage also to do it endoscopically.
yeah, but usually when it's inflammatory like that, it bleeds a lot, and it's not so easy to do that with the
Right-hand
endoscopy.
side
Yes,
behind and then.
I wanted to say the same as she has said. When you have we all prefer a dry ear, obviously, but sometimes you cannot have a dry ear. So you go to surgery, and you don't make a tympanoplasty. You look the ear. You open the ear and look the block spaces. Where are the problems? And sometimes you can solve them, and then you can have the surgery and you can have a dry ear. But it's not just to put a graft inside and say goodbye. You open it, clean everything, you have fibrosis somewhere, a granuloma here, mucus. That's why the endoscope is so usefeful in these cases.
But you do it in 2 stages?
No,
or
no,
you
one stage.
No, you clean
because
everything,
I don't do
you
a
remove the
meningoplasty.
fibrosis.
I do a ear surgery. I do whatever I have to do to that become a dry ear.
Yeah, but we will speak about what kind of.
Transplant material is the next
It's
step.
just afterwards.
So keep your questions.
Sorry,
Come-
can I just make a point?
Yeah.
I come from a part of the world that we have a very large indigenous population, and there is no way I can cancel that one because the patient, it would never dry. You know, they come from a very poor, low social class, two and a half times disease ear that it will never get dry. So the only time I will cancel a patient is if I look at that, if I start and there's cholesteatoma in there, then I'll say, look, this is more than I expect, then I'll cancel it. But I never get a dry ear.
Do you think you have worse results in this case?
I worry more of meningitis in the long-term outcome, and my second worry will be the closure. But meningitis is the biggest problem for me.
Well, I can answer this question. We did a couple of years ago a study on the Würzburg database, and we looked at Belushi classification prior to surgery, 1, 2, 3, 4. And from the audiologic result, we found no difference regarding Belushi classification prior to surgery. So Belushi 1, 2, and 3 has the same audiological results. However, the infected ears needed a little bit more aftercare. So it took some more weeks. Instead of 3 months, we had after 4 to 6 months completely healed ear. So acoustically, the outcome is the same.
Can I add something? Yes, a small
No.
comment.
No,
Yes, a
no, you
small
go
comment.
dancing
No,
and,
it's very
okay.
important.
Okay, but
I
tell
don't
us.
think this ear is going to be healed, you know, because you wait, because you have all the mucosa coming out. That mucosa is discharging.
it's impossible. So you can operate it. You can operate this case.
But do you try something before? Do you say I will try a treatment? I'm pretty sure it won't work.
Ear drops. What do you want?
Yeah, of course.
But the mucosa is there.
What do you try for treatment?
Treatment.
Yeah.
Yeah.
Ear drops. Sometimes.
Which one?
Ciprofloxacin.
Ciprofloxacin.
Yeah.
Okay.
But we have to consider mastoidectomy in these cases always if it didn't dry up.
Another controversial.
Make it a little
if the
bit more
patient, like he
complicated.
described, we couldn't reach to dry it up, I always add a mastoidectomy to this.
That's the question which I'm coming up. Who would do a mastodectomy or at least androtomy in the case upper right side? Okay, a few.
A few of you.
You do a mastoidectomy only if the CT shows you that there is some disease in the mastoid. Otherwise, no. You check the ventilation routes and you see the tensor fold. And you see if you need to create a new root or not, but not necessarily a mastoidectomy.
But the problem if you take a culture and there is some organism positive, and last week I had one case, I don't remember the organism, but I think it's very strange, like a parasite. I sent to the infectious, they gave her 6-week IV antibiotic.
6 weeks?
6 weeks.
And it would not dry anyways.
Yes, but they try.
Yeah.
They try.
You know,
Yeah,
the
but I
only ears that I will operate wet is cholesteatoma, and sometimes you look at the tympanic membrane, there are granulation tissues in the middle ear, so they produce some blocking. One other thing, we have some mastoidectomy patients with tympanic membrane perforation. Again, there is granulations. Those patients do not dry without operation. But something like this, I would do my best to dry it before.
But
we also use boric acid in alcohol. So this is very effective because
alcohol is effective.
Huh?
Alcohol is effective.
Yeah, because all the ciprofloxacin,
always
ciprofloxacin, you know, is antibacterial. But you know, we have a lot of fungus there. So boric acid in alcohol works for both bacteria and fungus. So I think this is very good to keep this in mind.
Yeah. One more question. We discussed wet ear, dry ear, but in the end, it's the philosophy. Is the philosophy you operate on the ear to get it dry in the long-term run, or never touch a running ear for surgery? Which philosophy is yours?
Mine is to dry it, but there are ears which are not become dry. If there is cholesteatoma, usually there is a little.
I think we must stop these controversies because we have also 4 more points to discuss.
Yeah, well then we
it's
skip
all right
them to
for you?
next year.
I'm okay. I'm okay with that. But I mean,
Yeah, if you want, you can move on to the next.
Well, what would you want? Do you want to continue with the discussion, or you want to have the next
it's
point?
good. I mean,
We
it's
move
up to
on?
you.
We fluently will come to the next
okay.
point.
More.
So, but we will see. There will be more conventional.
But there's one more thing that we have to discuss, which was addressed: supportance of the tympanic membrane in the anterior part prior to surgery. That's what you addressed. Put something in the tympanic cavity to stabilize.
Before surgery?
After while surgery.
But we will see that with, when we speak about cartilage, no?
Yeah, but we can have a nice introduction to the next topic. Are you through with the transcanal?
I think it's okay. No, I just wanted to know if you have a very small perforation and the anterior part is, that means that it's a residual perforation after grommets. What approach will you choose? Transcanal, endoscopy. Yeah, tell me endoscopy.
Transcanal endoscopic.
And?
Basically, plugging it with the facets will be enough with the microscope. So even in the clinic, sometimes it works.
Okay.
Well, come a little bit for this chapter to a conclusion. These were expert discussions, but I want to mind the point for those who are younger. You have together maybe 500 years of experience.
Thank you so much.
Do we look so old?
No.
We all.
If you include yourself, it's going to be 1,000 years.
Okay. Thank you. No, I think when we look back, which is ages back, when our training was then, we need a structure. And I think the question you addressed, endoral or post-auricular, and which school in Paris do you come from?
Both of them. But no.
And then we need to have a guideline for the younger to start and make their experience to avoid mistakes. So what would, in terms of post-auricular or endoral,
Did you know? Did you hear the name Lampert? Huh? Do you know his history? I think you should start study his name, because he was the first to organize these temporal bone courses to teach the people how to do this endoral approach, and he was.
But then we moved to 2,000 years.
Yeah, but Lampert is the fenestration of the horizontal canal endoral, and he worked. He moved from Germany to New York, and he has a big business. Is one of the richest ENT ever. So this is the history of Lampert. But
teach something. So I think it is a little bit behind the post-auricular approach. I mean, when I went to house clinic, everything was post-auricular, and there are many visitors going there. So they see the post-auricular. So I mean, endoral approach is far behind post-auricular.
Yeah, but I think for younger, if you have mastoid work, as it was said before, if you have an anterior perforation, the preference for the first 200 years should be post-auricular. And if you have preparations in the tympanic cavity or small perforation, you go endorally or transcanal. Can you agree with that?
I would agree with that, and I would also say that in the training program, they should be exposed to all four. Whether they should learn the endoral, they should learn the post-oral, and then do what appeals to them the most.
So I need more training. I never did transcanal.
Robert will teach you.
Okay. One more slides, or
no, I think it's the same. Hopla. Thank you.
Okay.
Thank you. We can
stay here with moderating, addressing question. That fits nicely. So we have a balanced gender situation. Yeah. The second is grafting, and we both, Asham, addressed cartilage tympanoplasty. We have seen a lot of cartilage. Cartilage is a hype. That was not ever so. In the 50s, we had skin graft. In the fascia by Hermann, the inventor of the incision. We had fascia. Then we had pericondium, and we can take cartilage from tragus or from the concha. That's a point that I want to discuss with you. And there is something by Marquet, eardrum transplant. This is something what you did with your removal of the annulus and the anterior part. It is not from a dead body, but it's from the patient's own body, and then you reimplant it. And that was first described by Marquet, and it works nicely, and acoustically it's also nice. And yeah, when I want to make a point for cartilage. Cartilage is the natural material for the tympanic membrane repair because it has a lot of collagen type 2 fibers, which are only in cartilage and which are part of the tympanic membrane. So this makes histologically sense. We have different techniques. Utrecht first used it. We have palisades, tragus cartilage graft, composite graft, and the different techniques. And we will skip this from the lab. Have you ever asked you the question, why is the outcome with the cartilage tympanoplasty so good? Cartilage is more heavy, it is more stiff, it has more mass, so it should have a high frequency hearing loss and it should have a low frequency hearing loss. The result is in this scheme, the driving forces for the malleus are only affecting half of the tympanic membrane, the middle part. And the lateral forces are just going to the annulus. And with the cartilage tympanic membrane, you enlarge the sound collecting area of the tympanic membrane that swings like a door-like movement, similar to what Bakershe has described. So this is some physical background from my academic teacher, Franz Schön, where we developed this concept. And now we go to practice. Asim, I start your video and you comment.
Yes, this is a cartilage ossiculoplasty. This is not a tympanoplasty. Is that all right? This is ossiculoplasty.
Everything is fine.
Okay, so as we saw, this is an endoral incision. You are harvesting the tragal cartilage here. The idea behind, there's been a lot of controversy regarding use of cartilage and the long-term softening of the cartilage, but what happens here, and I'll discuss that in a moment, what happens here is that I made a depression in the annulus, and I am removing the soft tissue from the cartilage, but the perichondrium is intact on both the sides. And I think that is the key, because cartilage is avascular. It gets its blood supply from perichondrium, so it's important for the perichondrium to remain. Now you can see a 1.2 millimeter burr used to drill a socket for the head of the stapes. On the other side, I'm trying to address the issue of this is a limited cholesteatoma. So one end of the cartilage gets locked into the inferior annulus, the other end sits on the head of the stapes. And the second cartilage comes in. I'm using Ceprafilm here to prevent adhesions. Ceprafilm is absorbable. So during the healing period, you can get good mucosalization. And this is a second piece of cartilage that sockets into this hole out here on the first cartilage. The advantage of that is that it would prevent postoperative retractions because you've done an athecotomy and things like that. And then the second advantage is that it's, as you said, gives a large moving surface area for the movement of the eardrum. And that gives an excellent postoperative hearing result for free. You don't spend any money on expensive, and this is what it looks like many years later. The biggest advantage is it supports the fascia and separates it from the promontory. It maintains aeration pass through the mastoid and the round window. There's no risk of extrusion since it's autologous. And there is no chance of a retraction pocket also forming because you supported it from behind. So especially from people in areas where prostheses are difficult to come by, this is a very effective technique, and you get good closure in more than 80% within 15 dB of the air-bone gap in 200, 250, 500, 1,000, and 2K. Thank you. So,
Ashim, can I ask you a question?
Yes.
Can you go back a little bit on your video? You know,
At what part?
What part? What part?
What part?
Can you come around here?
Yeah. About 1.5.
When we use the temporalis fascia,
yes.
In the past, I was laying the fascia to the ear canal, but when I switched to the cartilage, I like to leave it on the vibrating surface because when I rest it on the bone, I am afraid that it will restrict. Can you?
Let it run.
Yes, I will do that. And
So,
probably, Joachim, you
to
can
answer your
tell us.
question, this
if you look at the video,
yeah.
Why we?
No. Is there a
controller?
Just 1 second. No.
of the-
Just one second. Can we do height presenter view? What does it say in German?
Just I forward it to you
No,
and
just-
you ask your question, not
Okay.
boring the audience.
Height presenter view. Okay, let's not bore the audience. Okay.
No, autologous, same patient, always the same patient. In India, we're not allowed to use the homograph cartilage. We have problems.
So I like to rest the cartilage on incus so that it is still vibrating.
No incus
or
here,
the
sir.
stapes.
There's one cartilage going from the inferior annulus,
Yeah.
one small socket out there,
Yeah.
and it's like a bridge onto the head of the stapes.
But the other side, on the bone.
Yeah. And the second one is going into a hole on that one.
Yeah.
So it's also not fully resting on the bone. It's separated out.
Okay, let's.
So first of all, I want to know, I saw on your video you use cartilage. Do you always use cartilage for perforation? It was a cholesteatoma before
no, if there is a perforation with incus necrosis, yes, I would use this.
And without incus necrosis?
Without incus necrosis, it would be a temporalis fascia.
Temporalis fascia. Yeah. For the ulcer what
so
will you use?
This is where this comes in, and only a little bit is touching. The rest of it is all floating. Just a millimeter or so is touching.
And we see.
What? No.
We can't hear you. Can you take a map?
Yeah. This is just the ossicular reconstruction. See, it's just a little bit, 2 millimeters.
So the other side is white.
Absolutely. Yeah, both sides, very correct.
And Levin, what was your concern? It was about the audiologic results on.
You know, when I used the fascia in the past,
yes, of course,
I was laying it on the bone, but when I switched to cartilage, so the cartilage, of course, we thin the cartilage, but if we rest it on the ear canal, I'm afraid that it will restrict the movement. But so I like to rest it on the incus or things like that. So I make underlay graft, so under the drum remnant in front, but at the back I like to rest it on the incus so that it will vibrate. My concern is not to lay it on the ear canal, but
audiologically you've never had problems. I'm using this for 25 years now.
That's a discussion we have with the pediatric surgeon in Paris. Because I do exactly like you, I do very thin cartilage, and I don't put it on the bony canal. But in the biggest hospital in Paris, they do thick cartilage and they put it on the bone canal, and they don't have any problem with audiological results.
You know, first time I started to use the cartilage, I used a very thick cartilage, and the results was very bad. But then I learned to thin the cartilage. And now, you know, my experience is a little bit different. I have one of our residents made a cartilage slicer. So I remove the perichondrium on both surfaces, and then we have a cartilage like this. Otherwise, you know, it bends.
Yes.
If there is perichondrium on one side, it bends like this. It is very difficult. And I can tell you that if you remove the perichondrium on both surfaces, if you place it nicely, there is no problem with graft intake. So,
but this is the discussion here is that this is a technique which is good for the tympanoplasty. This is ossiculoplasty.
Yeah, this is different.
Yeah, this is different.
You are right.
You put in some fascia.
Yes, of course, absolutely.
So it's tympanoplasty
it's
as
a tympanoplasty as well.
But first, I wanted to know if in the audience, do you use cartilage? Because that was the discussion we had previously. But who use always cartilage for tympanoplasty? And in the panel,
technique of cartilage do you use?
You need a microphone.
I remove one side of the perichondrium and I leave one side. And most of the cases I do like island graft. In the middle there is the cartilage and the perichondrium bigger than the cartilage. It will lay in the walls. And if I need more, I will put the perichondrium extra.
Who is doing this technique? Good. Which other techniques are used? Huh?
I use a single piece of cartilage shaped to fit to the shape of the rim of the auditory canal. That means you remove the perichondrium on both sides and you can then fit the curve of the cartilage, thinning it in a different way on both faces. Single piece, thin cartilage with the shape of the auditory canal.
And you put it under the malleus?
And I put
above
it over the malleus.
Over the malleus.
Under the anterior sulcus and over the malleus and on the posterior sulcus.
Even by the endoscope, it's very easy to see the anterior angle of the canal. It's very easy to go inside. I do interlay technique. I elevate the skin and the fibers, and I leave the mucosa, and I elevate most of the time to 70, and the upward based flap, and I will put the graft.
But there's one point with the cartilage. I hate cartilage. I do.
Why do
Yeah,
you
I do.
hate
I hate
cartilage?
cartilage. That's
What do you use? You don't use cartilage, Robert?
No, I tell you why. It's because when I revise, people were using cartilage. There are two types of cartilage. I agree with you, Levin. If the previous surgeon was using a thin layer of cartilage, it's fine. But when he put a large one, a thick one, it's a nightmare to remove it, and you sacrifice the whole tympanic membrane. And this is the reason why I hate cartilage. Mainly.
There's one burning question. Everybody mentioned to thin out the cartilage.
Yes, that's important.
But thickness you can measure. How thin or how thick should it be?
I don't know. I don't use cartilage, so.
What do you use? What do you use?
Perichondrium.
Perichondrium.
Yes.
Better than fascia. That's good.
So I know I asked for cartilage. Majority of people raise their hand, but the one who didn't raise their hand, what do you use? Fascia? Who use fascia? Okay. Perichondrium? Okay.
If there is congenital cholesteatoma, I use fascia. I don't take cartilage.
Yeah, because
for that.
you don't. Because you don't need to have something that will.
Sometimes there is a little perforation, but fascia is there. We do endoral, so I don't sacrifice any cartilage around the area. But because there is no ventilation problem, no retraction, this is congenital cholesteatoma. So I use fascia there, but the rest, the cartilage avoids retraction, it's more durable. So if there is ventilation problem, then I think cartilage may be.
And Robert ate cartilage, and I ate fascia. I ate fascia. I remember the time I was a resident. It's a nightmare. You have only one try. Afterwards, it's something you cannot handle. You have to press it again. Wait, it's nightmare. So
we have to answer the question of the thickness. Anybody an idea?
I thin it with a blade of 15 according to what I need, but I don't.
What do you need? Measure in millimeter. What is the ideal?
I never measured it. I thin it as much as I can.
You have the answer?
Yeah.
Oh, of course. He has the answer.
Thickness is
0.3.
0.3 is good. Somebody?
No, I don't agree. Thickness is a compromise between the need of reinforcement and earring. And it has to be fitted at each ear, and with the cartilage thin on the periphery, thicker on the central part, and in the central part, the thickness is around 1 millimeter, something like that. But
Thibaut,
you
you're right.
customize the compromise between reinforcement and earring according to each ear.
I think you're a good philosopher.
With a slicer at 0.5 millimeter without any differentiation.
I think the answer is a little bit restricted. If you want to have a vibration pattern of the tympanic membrane close to a normal tympanic membrane, then you should be 500 to 700 microns. If you have an ear where you need more stability, you have a thicker cartilage. And if you have a really bad ear, you can use the palisades, which are curved outside. This we will have not reached the bust.
Breakfast.
But I think what I want to skip the tympano-ossiculoplasty panel and leave that for Chris. But we have discussed so many techniques and details. I think to look at aftercare is quite important. So Haja, if you are quick, we can hear you. If you're not quick, we go for the bust.
The bus is leaving at 6:30, but he will wait for you, so don't worry.
Oh, you should have
No,
said
no,
it
too late
earlier.
now. The last one,
Cross
it's okay.
fingers.
We have, I would say something like 15 minutes. It's fine.
Yes.
All right. What you do if you have high jugular bulb or dehiscence jugular bulb, and accidentally you find it, or you saw it in the CT scan, is there any different technique to elevate the flap? And sometimes you have conductive hearing loss because of the.
Don't cut into the bicycle.
Make sure it's a jugular bulb.
First of all, I think when you look at the tomography, it is evident there. And one of the very good surgeons, who is a very good friend of mine, during a meringoplasty, while he was entering the middle ear, he punctured. So we have to be very careful, and if we see that, we have to go around it. I think we can finish the surgery, but
yes, because
many cochlear implants, I have seen high jugular bulb. Sometimes it bleeds, but you can try go around.
In fact, you can stop the bleeding. You wait maybe 10 minutes, and then you can continue most of the time, because it's sometimes it's adherence to the jugular bulb, not jugular bulb itself. So when you elevate the flap, if there is adherence, then you make a tear on the jugular bulb. But if you seal this area with I don't forget the name now, but you stop the bleeding easily.
Well, this one of the things here is that
if it's covered with bone, you leave it as it is. If it's not covered, you shape the cartilage, as you have seen with Thibaut in the morning, and cover the bulb with cartilage. So if the next surgeon comes and it is not you, the bulb has a little bit of protection.
The problem is petrous bone cholesteatoma if it erodes the huge part of the jugular bulb. So if that is punctured, it is very difficult to stop the bleeding or continue the operation. Stop the bleeding and continue the operation. So it is better to leave that part until the end. So if we look at the images and we see those erosions, certain things should be left until the last minute. And because the jugular bulb is much thinner than the carotid. So this rarely happens to carotid, but jugular bulb should be left until the last minute.
A very important point here. When you do tympanoplasty, you need to care about the ear as much as you care when you do a stapedectomy. So don't think this is something different and I need to rush and open the middle ear. You need to go slowly and elevate the annulus, make sure it's going to be intact, not to rush inside. If we don't continue questioning, we'll not be able to finish the aftercare, which I think one of the most important things to handle it, because all the debate here is about 1% difference, okay? The 99% of the time, you're going to have very successful surgery, okay? But in this point here, the aftercare, where you're going to end up most of the disasters, and this is the time you're going to quit doing tympanoplasty. So if you have one patient driving you crazy post-operatively, you need to look to these very critical points and handle them clearly post-operatively. Otherwise, you're going to be called at middle of the night because of something silly. You may not be interested to do it. So knowing the post-operative care is as important, if not even more, than doing the surgery itself, okay? So how can we remember? This is the major concern. How can I cover almost everything and explain to the patient how each point is important for the patients? And I think that the easy things is to remember the anatomy-based care, okay? So you need to think about the auricle, the wound, the canal, the eardrum, the middle ear, even the inner ear. But also, you may have also something you think about it is the antibiotics, the painkillers, and also the anesthesia. By the way, almost all the aftercare and complication, you can blame the anesthetist being the cause of this, okay? And then the other causes, like those patients after general anesthesia, they could end up easily with DVT not moving, or they have cardiovascular disease or social issues post-operatively. And you may end up in family conflict after tympanoplasty. So for the auricle, you could easily come up with discoloration like this, even without putting the bandage. So one of the things you counsel your patients about it, this could be swollen, could be protruded, and could be painful for. But another very important things may not be in Saudi Arabia. For many countries where they have the snow, this can easily end up with a frostbite, losing the sensations in the lobule itself, or in even the post for the auricle itself, if you're doing the post-auricular incision. The other thing is the wound. And how many one of you is putting the bandages post-tympanoplasty like this? How many one? Okay. Yeah, covering the whole head and bandage. Yeah, yes, something like this. Okay. All right. I think, okay, this is the worst things we can do to our patients, okay? It's extremely painful, extremely difficult. If you do it on one side, don't imagine patient will come for the next side for tympanoplasty. And I want you to try it yourself. This crib bandage, okay, and some people, they keep it for a week, okay?
Abdurrahman,
yes.
she's a beautiful lady and she's smiling. So she's happy.
Not
She's happy.
This is good advertisement for the... The other thing is the sutures. My advice, make it simple and easy and fast for you, and not, coming again, even children, to remove the suture. So go with the... I never bought it, even in mastoidectomy or in the cochlear implant. So I stopped putting the bandage 15 years ago. Even bilateral simultaneous cochlear implants, I never put a bandage. So I think that would make it extremely easy for you. And by the way, soon we're gonna publish a paper that it shows that with the bandage, you have higher risk of infection, okay? Anyhow, the other thing, the stair strips and all these things, nothing, basically nothing, just leave it, okay? Because we know from basic. Okay.
Yeah, in terms of cartilage tympanoplasty, was we discussed, if you remove the cartilage from the pinna, we always put for 2 or 3 days a package of the pinna
And
the
the
shape of
cotton.
the pinna and
Okay.
the person to avoid hematoma inside where you take
We
out
do
the
as well.
cartilage.
I'm not
So
doing it, luckily.
we
And
disagree
maybe
a
I'm
little
not
bit,
doing
I
as
think.
much, but maybe this is the reason. But anyhow, we know by basic that within 6 hours to 12 hours, the wound would close. So even we tell the patient to take the shower after 24 hours, nothing really harm on those patients. So these are all something we know from basic general surgery stuff. For the ear canal itself, the packing, basically we use it there to pack the skins and keep it in place and make the ear dry and absorb all the secretion from inside and changing the cotton. And I think Wahim is okay. This cotton ball is extremely useful, okay? Because it get all the blood out and not much of an itching post-operatively, and keep the ear clean, and it's a waterproof area. The other extremely important things we always discuss it is the pressure changes. And I have this picture for you in the airplane. I advise each one of you, when you are in the airplane, just to drink water and close the bottle and see what happened to this one when you land. It's going to end up with something like this, unless it is full of water, okay? So I know some people are saying we already packed the ear with the gel foam and there is no much chance of pressure changes, but I think we need to prove it on a study base, okay? But all these are general advice for all the patients. Open your mouth when you cough and sneeze. Avoid any strain. Swimming and flying is another concern in those patients. Crackling sound in the air, taste sensations. And remember, also part of your consent is a facial nerve weakness and even simple tympanoplasty. The inner ear, a lot of people, their concern is the hearing, okay? And you need to tell them that you may not hear for a few weeks. Some people use the Weber post-operatively to see if their hearing is good. There's a new paper showing that the scratch tests are more sensitive than the Weber test to tell you. Some people, they do BTA if they are concerned about hearing loss in tympanoplasty, but this is not the usual that the immediate tympanoplasty BTA done.
What do you do?
I always carry my tuning fork with me. It's there.
It's
because I do operations in different clinics, they don't have this. So Weber test shows you if there is sensorineural hearing loss immediately. So I do this in the OR when the patient is awake before leaving the room, because if there is something wrong, we can give steroids, which is vital for immediate recovery. But I have to explain to the police all the time when I cross the borders, what is this? What is it used for?
Well, I think he and all of us would use tuning fork routinely, as well as facial nerve testing in recovery room. So this is almost like facial nerve. No.
No.
Only tuning fork?
I use tuning fork or scratch test.
A scratch test, yes. So some people, they say the scratches is more sensitive and hearing than the whopper. And also the facial nerve extremely critical in recovery room to make sure you have no problem with that. Then the balance, you can blame most of the time anesthesia if it's mild, but if it's severe one, you need to care more about those patients, or if it's prolonged one. And medications. Keep your patient busy with the medication, otherwise he will keep you busy with the phone call. Oral antibiotic, ointment, drops after you remove the cotton ball. Sometimes you may need to give antihistamine for itching, okay, and skin antibiotic, ointment, and not cream, because sometimes the pharmacy will give a cream, not ointment.
Excuse me, do you use for each patient oral antibiotic for
Tell you the truth,
procedure?
we've been doing it. We have no evidence for that. Okay, and I think who's giving antibiotic routinely post tympanoplasty? Hands up.
Yeah.
So I think still the
No.
majority they give
Okay.
antibiotic.
No, so you know, in France,
yes, please,
there
please.
is some advice of the anesthetic society which concern the use of antibiotic during surgery, and in France it's very hard to prescribe now antibiotic perioperative and post-op.
Mike here, please.
So the Swedish, is anyone from Sweden here? So the Swedes have a very good national database, and their national tympanoplasty database, they found that if you give oral antibiotics, the success rate is less. So you shouldn't, there's no evidence that it's useful, and there is good evidence now that it's not beneficial. So there, you heard it here.
All right, and those all an emergency, you need to let your patient be aware of it to come to your time, extremely important, okay? This is the usual things. Why we say 3 weeks, 3 weeks, 3 weeks? Because this is the time for inflammations anywhere in the body where you end up with the swelling, pain, and this is the time for the sick leave. Some people, they give up to a month. I give usually for a week. And the restriction of any restraint and anything, it's usually for 3 weeks. And remember, acute, subacute, and chronic, 3 weeks, 3 months. After 3 months, either almost 80% recovery or it's end up in a chronic phase. So this is why we wait for 3 months for almost 80% recovery. And this is the time we do the BTA and we get the normal activity. So I try to somehow simplify it for a lot of you who's a junior resident, but I'm sure each of the panelists, they have their different approach. Do you agree with this, or you have different practice? Like, would you do the BTA like a month after, or will still wait for 3 weeks?
3 months.
3 months. 3 months.
But I
3
mean,
months.
I always do the tuning fork test. If there is any abnormality, unusual thing, we do it early.
Okay.
One thing, can you go one slide back? Okay. So suppose you have a patient coming from another city, but you're always flat. But if there is hills, and when do you send the patients back home?
Well, this is very critical questions, particularly in Saudi Arabia, because people are flying most of the time to come to our centers.
So when do you send him back?
Good questions. And
Now I
Riyadh-
ask the question to you.
To me.
Yeah, because all
okay.
the time you're asking us.
Good question. It's not an easy. It's a lot of social issue behind it, and we need to balance. There's nothing like white and black in these situations. But in general, we ask them either go driving by cars or they stay for 3 weeks around Riyadh until we see them again.
Oh, yeah, 3 weeks is a long time. So
it is.
But I mean, how about you, Joachim?
Not really.
No flying for 4 weeks.
4 weeks. I sent them a week after to their home, so that there is initial vascularization of the graft. So this is what I think. I keep them a week. Usually they complain. I mean, it's not easy to keep them for a long, because they have children at home, other people. But I send them home a week after, and 2 weeks later they come to remove the dressing. In that time they use the drops. I don't know how you do.
For how long you keep the packing in the ear? For a week?
So ointment, actually the ear canal entrance, I keep it a week. But the ear canal until the tympanic membrane, 3 weeks. So 3 weeks later, I remove everything.
So you suction the ear and remove the gel foam or what?
Gel foam, yes.
Okay, okay. All right. You know, the best things for all of us is to have these brochures, the website, even the YouTube, to explain to your patient all these things could happen.
Let me ask the audience, how long did you keep the package? 3 weeks or somebody different experience?
5 to 10 days according to the surgeries. 5 days for otosclerosis surgery, 10 days for cholesteatoma surgery.
No, for
the
tympanoplasty.
packing of the
Tympanoplasty.
Tympano?
Otosclerosis.
Tympanoplasty, 10 days.
Otosclerosis, usually we raise, 3 days later, we remove the dressing in otosclerosis, but tympanoplasty is different. We have, there may be bleeding, this and that.
7 days, yeah. Who would say 7 days for tympanoplasty? I think this is the majority, will be 7 days. Could, yeah. This is the time you put
So that's
eardrops, huh?
Yeah.
Do you do the package with silastic or without?
So in the UK with private patients, if you follow up a private patient within 10 days of the operation, you don't get an extra fee. So we always take the pack out at 12 days.
It's 2 weeks in Saudi Arabia, so this is why.
You know, I noticed that sometimes, you know, there is stenosis in the entrance of the ear canal. So that's the reason I keep a stronger one there. But the rest is usually without problem.
True, true. And this is the beauty, I think, of ear surgery, that, you know, you cannot fix rules for everyone. I think based on what you have seen intraoperatively, you decide immediately the best care for your patients, okay? Exactly, exactly. I think case by case.
The age.
What's the age?
When do you operate a child?
I think
there's no age limit.
It's a case by case discussion.
One of the things in elderly, I think we need to think about it seriously, is the local anesthesia. Okay, I'm sure if you try it, you're gonna love it, and you're gonna offer it even for people with no comorbid disease.
But I have a very funny story. Every year we have new audience, so it's a very funny story about local anesthesia. A long time ago, probably 16 for something otology course, there was Michael Glasscock who was there in the audience. He was quite old, and I was impressed by his presence. He was a nice man, and we had a discussion about local or general anesthesia on stapes surgery. And this guy was in the back of the room, and then he stood up. He said, "I have a story to tell you. I had a patient who wanted a local anesthesia, so I did a local anesthesia for the stapes surgery. And then this guy was landing when I was working on the stapes. And then suddenly the guy said, 'Doctor, I want to pee.' He said, 'No, you're going to pee, not going to pee. I want to pee. You don't want to pee?' I removed the stapes because he did the total stapedectomy. And he said, 'This guy was standing up and went to pee without any stapes anymore.' So since now, I never do any local anesthesia anymore." It was a funny thing.
The same thing, if you try anything at the beginning, you get scared and you have a lot of issues. But I think with time, you know, you're going to enjoy the local anesthesia. So I know in academic positions and situations, you may not be able to do it, but this always keep it in your mind. I think we end up with a wonderful discussion at the end of the day. We are not going to miss our buses. The most important things, the wave of heat, and the best things is to come to Saudi Arabia. All right.
It will be hotter.
Thank you.